Hello, everyone, and welcome to this session. It's my pleasure to welcome you here. For those of you who are here live and those of you who are virtually, good morning, good afternoon, good evening, wherever you may be. My name's Mahmood Bhutta. I'm an ear, nose and throat surgeon by background, but I've had a long-standing interest in sustainability, and I work at Brighton and Sussex Medical School, who are kindly hosting this event on behalf of the COP conference. So that is based in the UK, and we have had some interest in developing research that underpins sustainable healthcare, and by that we mean the contribution of healthcare to the sustainability agenda. Many aspects of healthcare impact on the climate, and we know that the NHS and health systems around the world are thought to contribute between 4 and 5% of the entire carbon footprint of a country. So it is important that healthcare not only advocates for the health effects of climate change, but also tries to get its own house in order to make healthcare more sustainable. And that's really what the aim of this session will be. And I'm very glad that we've got an illustrious group of presenters from across the globe to talk to us about the various aspects of how we achieve that. I'd like to start with a few little housekeeping rules. So just to let you know that this session is being recorded, and so will be available on our website, which we'll put into the chat shortly for viewing later, but only the panelists will be visible and nobody else. There is a Q&A function, so please do put your questions and answers into the chat. We will take Q's and A's from the floor at the end of the session. I can't promise you that I will answer every question, but we will certainly try. And if you're able, you can upvote some questions that you think perhaps should be given priority. In terms of other aspects, there are some social media outlets as well, and we'd encourage you to use those, and those will be put into the chat as well for you to look at. And finally, for those of you who may have problems with language or with hearing, there is a closed captioning service available as well. So without further ado, I'm going to introduce each of our speakers ahead of their asking them some questions really around this. And so my first is
Hi there. I think that we perhaps lost Mood for a moment there. And welcome from the WHO Health Pavilion. My name is Dr. Chantal Razan, and I'm in the final year now of my
Apologies,
PhD at
everyone.
Brighton and Sussex Medical
Mood,
School.
So we'll just give him a second to see if he can rejoin.
And I'm looking at ways
to
reduce the environmental impact of the
I wonder if
operating theatre.
Dr. Chantal Razan is there.
So I think we've got two streams going on. Am I being broadcast live? Okay, great. So if we look at the greener NHS pathway to net zero, we see that actually over 50% of the roadmap is reliant upon research and innovation, low carbon products and low carbon alternatives, as well as supplier alignment with the greener NHS ambition. And whilst research is really only explicitly mentioned in one of those that I've just picked out, I'd argue that it's absolutely essential that we have a strong evidence-based approach to all of those different domains. And that's to ensure that we can be confident that when we are making recommendations in terms of that transition to the sustainable healthcare systems, that there's a true net benefit to the environment. And that's especially important because we often have counterintuitive findings when it comes to environmental accounting. So I'll be outlining now three of the principal ways that I think that research can add value in terms of underpinning our transition to net zero within healthcare. And when I'm talking about research, I'm really talking about the highest evidence level, which is our life cycle assessment, which can be used to provide an evaluation of environmental impact for a given operation. Sorry, I think it might be broadcasting another thing. Is this broadcasting live?
It's there to protect patients, but at the same time, you do worry that when you're dressed in oil, as I was today in intensive care and going through 20 gowns, thinking about the unsustainable nature of what we're doing. And so, although some progress has been made, I'd like to just reflect on a few points that probably are reasonably impactful, that could be a message to all of us to think about how we can lead in ways ahead here for improving healthcare sustainability. And I'll talk about the micro, meso, and macro approaches, which have been propounded previously by others. But in terms of the micro, I think that focusing on hotspots is important. So thinking about anesthesia, which is a really big one, and lots of gases have a high carbon footprint. We can think of metered dose inhalers from our respiratory physicians and the GPs changing asthma medications. We can think of nephrology, so all the dialysis, the equipment that's been used for that, all the things that surgeons use that are single use. And then you can even think about we don't forget our good physicianly friends, and think of pharmaceuticals and stewardship that can be done there as well. And really importantly, nurses. So nurses have a role across the spectrum here on what they can start to think to do to improve the situation for not just one group, but for all groups within healthcare, within hospitals, which are really energy and waste hungry parts of the world. So I think that focusing on the relatively substantial is important. So although recycling is fun, and I've been involved in that for 15 years now, it's not really the big part of the story here. It's focusing on those really points that matter. And I think that renewable electricity really matters in making things reusable equipment better. So in other words, having a renewable energy source is quite important. So aiming for the relatively easy first versus the difficult. So the easiest, it's quite surprising. I remember being involved in transforming with the anaesthetic and other teams the use of reusable equipment away from disposables. That was actually much easier than changing the coffee cups in the cafeteria. That's actually a harder thing to do, surprisingly perhaps. I think considering also what is feasible from a solo practitioner's point of view, whether it be a solo nurse or physio or doctor, reducing the amount of syringes, etc., that you're using, reducing the amount of equipment, that's all important. But I think also collaboration is incredibly important here, and other processes to change things. So I think that all of those factors are important. I think also you can think about what matters sometimes to certain groups, which is quantitation and numbers, for example, with anaesthetic gases, but as opposed to what is qualitative and requires a bit of charisma to change things. And examples of that, for example, in intensive care would be, well, we don't actually need numbers to, say, reduce the amount of bags that are being used for renal support or DVT prophylaxis, mechanical devices and things. They can all be changed and reduced whilst not affecting patient care, but they may not need as much data as, for example, comparing carbon footprints of different anaesthetic equipment. So I know I've focused a little bit on anaesthesia there, but I do think I'm trying to give the story that all of us have a role to play in trying to reduce the carbon footprint of healthcare. And I'll just mention with a few other points about creating a hospital sustainability working party is incredibly important, led by hospital executive, and along with that, encouraging the employment of hospital sustainability officers is actually vital, because they're able to free up busy clinicians' time, like my own and other nurses and doctors, etc., and they pay for themselves quite quickly because they're able to, their wages can be spent looking after and reducing energy consumption, for example. Joining medical, nursing and other healthcare environmental groups, here in Australia, Doctors and the Environment or Climate and Health Alliance, but there's many other groups in other parts of the world that have equally important roles to play. And I think agitating at the macro level for medical, nursing colleges, societal involvement, British Medical Association, just to name one of many, is incredibly important, as well as being part of national hospital accreditation requirements, and patient advocacy groups here is going to be really important as well. So I think they're the important points that I wanted to get across pretty quickly to the team that are listening in here, to say you have advocacy, you have agency, we can change things. Collaboration is incredibly important on the road and the pathway to sustainability. So thanks for your time, and I'll move on to the next speaker.
Thanks so much, Forbes. I'm sorry for that technical glitch right at the beginning. I'm back in. So thanks for stepping in. Forbes, perhaps I can ask you, it's great to hear the work that you've done within your organization and also trying to spread the ideas. But people say the behavior changes is the biggest barrier to making our work more sustainable. what have you felt? Is that the biggest barrier to change, or do you think there's other barriers?
Yes, I think that, in fact, there is a list of barriers that exist there, but in a way, it is ourselves that are the barrier, like it was ever so, or ever thus. Being more imaginative and curious about changing the way we do things, I think, is incredibly important. In healthcare, the status quo is important because you avoid inpatient harm. So we are perhaps more risk averse in healthcare than in many other fields of the broader economy, and I think that we need to balance. Always having patient care, number one, but also focusing on planetary care in a sense, or the broader societal care of not wasting as much, and working with all of our different streams within nursing and medicine to change the way we do things. So I think that challenging the status quo and educating ourselves about carbon hotspots, or about different fields of medicine and nursing, etc., that might be problematic from a healthcare point of view, I think is really important. I think that also the hierarchy of medicine in particular, but also nursing to a degree, is important to challenge at times. I think juniors can work with seniors by identifying just one or two seniors that might be able to help them in this. And I was thinking about, like, all you really need is one surgeon, one charge nurse, one physician, one GP, for example, who are willing to get involved in this, and you can actually make enormous change, even if it's the juniors who are trying to make that change and not so much the senior. I think infection prevention and the teams there are going to be incredibly important to working with this, and having leadership there to work with that conflict, that natural, and we identify there's a natural conflict between infection prevention and environment, the broader protecting the patient and the planet. So sure, I think resisting marketing and also working with government is going to be important as well. Thanks.
Okay, yeah. Sorry, yeah, I think we better move on. That's great. So I think there are lots of complexities there. So Chantal, I don't know if you're back on. I'm sorry, we've obviously had technical issues on several points. Are you here with us, Chantal? If so, I can introduce you.
Okay, great. Can you hear me now?
Yes, we can hear you. So Chantal, as I was starting to introduce, and I'm not sure whether how much of that you heard, Chantal is a research fellow at University Hospital Sussex, and currently completing a PhD at Brighton and Sussex Medical School alongside me. And she's particularly looking at how we can reduce the environmental impact of common operations. Was also a founding member of the Royal College of Surgeons of England Sustainability and Surgery Working Group, and has really pioneered a lot of evidence in this sphere. And I think, to my mind, having evidence of what we should do should be the fundamental basis for us moving forward. So, Chantal, we'd be grateful to hear your thoughts on this, on the research and the evidence agenda.
Okay, great. Thank you ever so much. And welcome to everyone from the WHO Health Pavilion at COP26. My name is Dr. Chantal Razan, and I'm in the final year now of my PhD, looking at the evidence basis for reducing the environmental impact of common operations. And if we step back and we look at the net zero transition and the pathway to sustainable healthcare systems from the greener NHS, we see that actually over half of that roadmap is reliant upon research and innovation, low carbon alternatives, low carbon patient pathways, and supplier alignment with the greener NHS ambition. And research is only really explicitly mentioned in one of those areas that I've picked out, but I would argue that it's absolutely essential that we take a strong evidence-based approach in actually informing that pathway. And that's especially given that we know that across environmental accounting, there are often counterintuitive findings. And so we need that strong evidence basis to make sure that when we're making changes towards sustainable systems, that there's a true net benefit to our environment. So I'll be describing the three principal ways that I feel that research can add value in terms of our journey towards sustainable healthcare systems. And in talking about research, I'm talking about the highest evidence level, which is our life cycle assessment, which can be used to evaluate the environmental impact of a given healthcare product right through to healthcare systems. Many of you will be more familiar perhaps with carbon footprinting, which is a subset of a life cycle assessment, or LCA, focusing on the greenhouse gas emissions. So firstly, life cycle assessment is a really useful tool in evaluating and identifying hotspots and seeing the areas within a given system that make the biggest contributions. And for example, within my own research, I look at the most common operations within England, and I look at the underlying processes and the hotspots there. And I can see that actually across the operations that I look at, 60% of those impacts come from the production of the single-use items as well as their packaging. And that's then followed by 20% from the decontamination, so that's sterilisation of the reusables, and 8% from the waste. And so from this hotspot analysis, we see those are 3 areas that we really need to target. Now, that hotspot analysis can also be done at an individual product level. And I found that across my data set, there's just a few items of equipment that actually make the biggest impact. And it's actually 22% of the individual products that predict 80% of the carbon footprint. And that's a really nice illustration of the Pareto principle that you might be familiar with. So that's hotspot analysis. Secondly, life cycle assessment can be used when it's used consistently, using a consistent methodology to compare the environmental impact of different products. And within my hotspot analysis of removal of a gallbladder, I identified that there were just 3 single-use laparoscopic pieces of equipment that contributed 18% of the impact of that operation. And so actually, through life cycle assessment, I modelled hybrid equivalents that were available on the market, which are predominantly reusable, finding that actually reduced the environmental impact by 75%. And thirdly, life cycle assessment can be used as scenario modelling in order to actually look at optimising underlying processes. So sterilisation I mentioned as a real key hotspot, and actually I found that you can reduce the impact of that by around 1/3, and that is through changing from supplementary items into preparing these instruments as part of sets, and from actually optimising the loading of our decontamination machines, using low carbon energy, and also recycling of our sterile barrier systems. Waste was another process that I found that we could have a 50-fold impact in terms of the carbon footprint of the waste, depending on the waste stream that we used, with highest impacts for high temperature incineration as used for clinical waste, and lowest for our recycling. So in summary, that's then we can use the research essentially to identify those biggest areas that make the biggest impact in terms of our environmental impacts. And we can then use the life cycle assessment, more detailed methods to compare between different products, and also to look at optimizing systems. But the academic field of sustainable healthcare is really in its infancy. And to date, at my last check, there was only around 130 published life cycle assessments globally. And there's just a handful of researchers in this field, many of whom are actually on the panel today. And so really, we need to be calling on those that fund research to actually to fund this sort of work, and we need our academic medical journals and conferences to actually support this. And finally, we also need education for our healthcare professionals to improve their carbon literacy such that they're able to access this information. Over to you, Mead.
Thanks so much, Chantal. Yes, I mean, it's very, very important, I think, that we understand where a lot of this work comes from, a lot of our carbon footprint and life cycle harms come from. So it also guides us to where we can direct things, exactly as you've said. But I suppose the question I'd have for you is, many people will be sitting here saying, well, and I get approached of, can we carbon footprint this? Can we carbon footprint that? And I think it's quite a complex thing. So is it more about some principles that we should be following? And then are there any cheats? Are there any easy ways for us to understand how we can sort of measure the environmental impact of things that we're doing?
Carbon footprinting, and especially life cycle assessment, is a really resource-intensive process in terms of time and expertise, and sometimes quite expensive software. And so really it is about using those generalizable principles, as you describe, from existing literature. We absolutely know that when we talk about sustainability, the number one priority has got to be reduction. And if we don't use something at all, then that is, of course, going to be better than looking at a low carbon alternative. Across the existing evidence, we know that reusables are better. There's a few exceptions where we use coal-based electricity for the sterilisation, but really wherever reusable alternatives are available, the majority of evidence points in that direction, and also using those circular economy principles such as repair and recycling helps us to maximize our resources. There are a few shortcuts, as you mentioned, in terms of actually determining carbon footprinting. There are simpler methods using the financial cost as a proxy. That is not necessarily sufficient for the more nuanced work. And I'm developing actually at the moment some novel methods that might be helpful for the clinical context to actually get a rough sense of the carbon footprint based on some easy to measure metrics such as weight, to identify that rough area in which the carbon footprint might lie for a given procedure, for example, and also to point out those hotspots. And so watch this space for some novel methods coming up.
Thanks so much, Chantal. Okay, so I mean, one of the things that we've heard here is about the idea of reduce as a guiding principle, and I think one of the things that we can look to is actually how things are done where we have low resource settings, where actually reduce is a necessity because of the lower availability of resources. So I think I'd like to move on now. It's a pleasure to invite Cassie Thiel and Dr. Venkatesh. So Cassie is an assistant professor in the Department of Population Health and Ophthalmology in New York, and her research has really looked to quantify and look to how we can reduce emissions associated with healthcare activities and medical products. And I know that you spent some time working with Dr. Venkatesh in India, who's the Chief Medical Officer at Aravind Eye Care System in Pondicherry, who's got a special interest in low carbon eye care. And it'd be really interesting to hear from you how things are done differently, perhaps in a low resource setting, and what that means for our carbon footprint. Cassie, over to you first. Thanks.
Sure. Yeah, thank you so much. So I got into this as an engineer working on life cycle assessment in other industries, and I had done some of my doctoral work looking at hysterectomy and birth procedures in the US. And it became very clear to me the more time I spent in a clinical space that a lot of Western medicine is kind of all the same, that it looks like we have a lot of disposable materials, and that seems to be where a majority of our emissions are originating. And so I felt like doing more and more LCA studies in the US may not get us to the place where we can actually really significantly reduce the footprint from clinical care. And in conversations with some colleagues, I learned about Aravind Eye Care System and their approach to especially cataract surgery, which is one of the most commonly performed procedures in the world. So I had reached out to them and fortunately was able to conduct a study there and able to compare their carbon footprint with the carbon footprint of phaco emulsification, a common approach to cataract surgery based in the UK. And what's fascinating about these resource constrained settings and areas like Aravind, where they're really trying to be efficient with the resources, they're trying to reduce the cost of care. They've really found great ways of optimizing all these materials and resources that are needed. So in the end, the calculation was that Aravind's carbon footprint was about 5% of what it was in the UK for the exact same procedure, and their outcomes are great, well documented. So we know that this is possible. I'll hand it over to Dr. Venkatesh to kind of talk more about what Aravind is doing.
Thank you, Casey, and thank you, Professor Mood, for having this great panel. So Aravind was an organization which started 45 years back, and now we see close to 15,000 outpatients every single day, and we perform 2,000 surgeries every day, which is like 4.5 million outpatients a year and roughly 500,000 procedures. So this volume was built over a period of time with a very clear mission to eradicate needless blindness. So we were always looking at the patients first. So we had a lot of unconventional ways of getting patients into the system. We said reaching the unreached or looking for the non-customers in the form of outreach activities, primary eye care centers or the vision centers, which was kind of functioning in semi-urban rural areas where there were no eye care, and they could come to the secondary and tertiary eye care centers for other specialized procedures. But 85% of the treatment could be given in that setting itself, so that they don't have to travel to a hospital, they don't have to do multiple visits. In the same time, our system was kind of non-appointment system. Patient can walk in any time between 7 to 4:30 and register and have his examination done. And we try to close the loop also on the same day. For example, if somebody needs a medicine or glasses, the glasses would be even made and given within a couple of hours after the testing. If he needs a laser or a surgery, for example, a glaucoma laser or a diabetic retinopathy laser, and if he's already prepared, the laser would also be completed with the investigations. So that's where we constantly looked at evolving our efficiency and also kind of training our team to close the loop on the same day. When it comes to cataract surgery, like what Casey said, we do close to 400,000 cataract surgeries of the total 500,000 procedures. That's a pretty high volume for any standards, which is almost 40% of what the state of Tamil Nadu does. We do it in one particular system. So where we are constantly, again, looking at efficiency and kind of reducing and, of course, kind of recycling a lot of waste and things. But how do we reduce is, again, Casey did a lot of work to find out behind it. But we were doing it historically, and we were doing it not because resources were less, because we wanted to give the best to the patient. Whether he was paying or free, we wanted to do the best to him. So we thought we can do that by only giving it in a lower cost. So we had our own manufacturing facility called Aurolab to manufacture lenses, reusable pharmaceuticals, and we carefully kind of continuously used a lot of things. Like a pharmaceutical drug, a bottle will be just thrown out at the end of the day. Things like your gowns and attires will be kind of autoclaved, washed, dried, and autoclaved at the end of the day. Surgical instruments will be flash sterilized in between cases. So each surgeon will have 2 tables, and he'll be operating one after the other so that you can do 7 or 8 cases in an hour. So all of this, kind of reducing the amount of material you use, and also kind of recycling a lot of things in between by flash and full sterilization, and also carefully segregating waste at source, which again, we learned a lot of during Casey's work, but we do meticulous waste recycling. So all this at the end result was kind of helping the patient. So we were also aware that we are friendly to the planet, and we are kind of making profits also. Thank you.
Thanks so much. I mean, it's really inspirational to see how that you can do these things. And I know that you've published some data as well on your infection rates, for example, which are actually lower, I think, than we see in that high resource setting. So it actually turns the whole idea on its head. We have this issue, I think, possibly where certainly some health systems won't necessarily be paying for some of these products, and we develop these systems that use, whereas you've shown that very much we can do it on a much more economical scale, economic both financially but also to our planet. But I guess one of the questions I have is, in that many lower resource settings, people tend to see things done in higher income countries as something aspirational, something they should be looking to achieve. I mean, clearly you don't believe that, and that's great, but how do we reverse that mentality?
I think it's the more the evidence which we give, I'm sure it'll give a very clear path to whatever be, whether you are resource constrained or you have all the resources. And I think people who have all the resources are the ones who are really worried about the change. I'm sure, because once I think that thought process comes, things will definitely change. I mean, there are plenty of evidence, like what you said rightly. Our endophthalmitis rates are 1/4 or 1/5 of what happens in Western standards with whatever we are practicing now. So I think it's only how we kind of play with the both governmental and the other associations to get certain things done. I still remember a UK-based ophthalmologist saying, iodine comes in 500 ml bottle, and you use 3 ml for cleaning the eye, and the rest 497 ml goes into drain for every patient. So who is responsible for that? I think with that question, I'll end.
Thank you. I don't have an answer for you there. So I think is a very well made point. So, I mean, I'm going to bring in here now Fiona. Fiona, you are a public health physician by training. You've previously trained, previous roles have included being Deputy Chief Medical Officer for England and WHO Director. So you're clearly on the public health agenda. You've also been in this game for some time. You published in 2009, I think, the Health Practitioner's Guide to Climate Change, and you're now chairing the Sustainable Healthcare Coalition, which brings together industry and the public sector. So, we have the people who are making the products and feeding what we need. So I just wonder what your thoughts are on how we can bring these ideas together, the industry and effectively the consumer or the user of these products, healthcare and patients, to sort of realize sustainability.
Thanks, Mood. And as you said, I've seen the system from every which way. I think what that has really taught me is that if we want to solve a system problem, then all the players in the system have to work together to come up with the solutions. And as a coalition, we were formed about 10 years ago because the NHS team at the time realised that the supply chain was a huge part of the carbon footprint, about 2/3 of it, and about 1/3 of that is related to medicines and devices. And the challenge we were set at the time was to come together and first of all come up with the first global greenhouse gas footprinting methodology, but also the care pathway methodology. And colleagues like Cassie were great in helping us make that happen. But in the end, I think, as Chantal and others have said, this isn't just about measurement. At the heart of this really is what we're trying to do is design environmental impact out of the system and to use our understanding of measurement to really do that. Because, what we've shown in all the case studies we've done, which have proved that it is possible to change, is that, health outcomes can be improved at the same time as you reduce costs and at the same time as you reduce environmental impact, so that we know it's impossible to do that. But we also know that what we have done for years is chosen to ignore environment. What we need to get to now is a situation where environment is part of every single decision we make in the healthcare system, from the top to the patient care point. That's what it's going to take, and that's a huge change. So I think when you're thinking about how do you work with industry, then what's going to make a difference? Well, the first point is, how do you incentivize that change? And, I think one very big lever is procurement, shopping, how you buy kit, and how you set the rules for purchasing is really important. There's been some great work that's been done by UNDP and Healthcare Without Harm on their procurement system, which is being launched later in the year. But the NHS in England has also looked at that in their Evergreen framework, and they're now requiring all suppliers of the NHS to be net zero by 2030, but also to weight decisions around buying kit to include environment. The challenge, though, is how we really make that really meaningful in the system, because until we change the market incentives and that when you produce a product that environment really counts, the system's not going to change. The second thing I think is that, we also need to think about how do we inspire people to change. And how we inspire people to change, I think, is really unleashing people's imagination. Because knowledge can only take you so far. What we're really talking about is how do we imagine a different world where different rules exist and how we can do things differently and do different things. And what we learned from setting challenges for industry is that actually when you do that and you work very closely with clinicians and patients, you can unleash all this energy for change and really come up with some different solutions. So I think that's going to be critical for solving problems. But I also think it's important to go, if you like, where the action isn't. So Richard, who'll be speaking later, and I have championed some work looking at a big part, we think, of the footprint of industry, which is around clinical trials, to look at research and development. We think that that's going to be quite a large part of the scope, and a study produced about 10 years ago showed it was probably about 1/3 of the footprint of a country like Bangladesh. So we need to go there. But I guess finally, what we need to think about is, I think what each of the speakers have reflected on so far is that we are also all part of the problem, and that this is about mindset. And when I look at other industries and sustainability that I work with, industry has often championed change. And I think that in healthcare, we have had this real difficulty with working with industry, that sometimes we don't have that open mindset of really wanting to work together for change. And that is what we need to engender, because I think we need to move from a situation where we are putting a lot of energy into having fights we don't need to have, but we need to put it on solving these problems and working together to get a different system. And I think each of us needs to have the power, as Forbes was reflecting, to know that we can change, and that, you know, if we demand different healthcare surgeons, if patients are more aware, if the system rule changes, then we can do this, and industry will respond because it responds to customers. That's what it's always done.
Thank you, Fiona. Yeah, that's great insight. I mean, I completely agree. We need to work together because they need us, we need them. So there are definitely companies out there that I think seem to be heading towards the right thing, but there are also there's also been some issues. I mean, I can tell you, I was invited by a major supplier to the NHS to talk at one of their conferences when I insisted that I would speak about the idea of reduce and reuse. Their executive board decided they no longer wish to invite me. And that is a bit worrying to me. So I suppose there is this fundamental conflict between the idea that you need to sell products, and we as sustainable practitioners should not be buying products unless we absolutely need to. We've seen that from India, and we've seen that from Chantel's evidence. So I guess, how do we resolve this? And are there companies out there that are prepared to reduce their sale instead of some of the companies that seem to be frank, greenwashing some of these ideas?
Well, I mean, I think what you've reflected is that, you know, we all would rather have less care. I mean, I hope in my lifetime I never need to go anywhere near a surgeon again. But the reality is that I might need to. And when I do, I really hope that they're going to be practicing in a green way, as you've reflected. So I think, you know, we all would prefer prevention to care. But I think we then need to realize just what the challenge is. And that's, you know, I think for the industry as a whole, the transformation that's required is huge. And that does challenge existing business models around, you know, how are you going to do business? How do you look for value in different areas? For example, in digital services alongside products, there are all sorts of ways that people are trying to reduce impact at the same time as improving outcomes. And I think that's a transition that we need to go on. There are certainly many companies who are innovating in this area, as you well know, because I know that you, Chantel, and others work with them to try to prove that there is less impact by doing things differently. But I do think that we need to realize that there isn't sort of some evil force over there, that actually this is a co-conspiracy, that we are all contributing to this problem because we have designed a system that's different. I mean, I'm ancient enough to know, because I trained in the 1980s and did my surgical house jobs then, that, you know, the world where you had single disposable instruments didn't exist then. It just didn't. And so we could do things differently, just as we were hearing earlier. So I think, you know, yes, industry is challenged. Yes, industry needs to change. It's not just within healthcare, though. I think capital markets will make a difference. So yes, we need to work together, but, you know, business models do need to change as well.
Yeah, so I guess the point you're making is we've, to some extent, created this business model, and it's up to us as well to make those changes. And this is perhaps one of those few instances where we can actually talk about the good old days, and they really were the good old days. So
they were different.
Yeah, well, some aspects of the good old days, Matt. So I think you brought forward there the idea that we all need to take responsibility, and perhaps one of the things that we're not really doing is having the knowledge to take this forward, or the personal responsibility. And one way, of course, to deal with that is through education. So our next speaker is Francis Mortimer, who's formerly a doctor in training in renal medicine, and then moved to become the medical director of the Centre for Sustainable Healthcare, an institution that's been there for well over 15 years, I think now, arguing for these changes. And I was there when it was set up. So she now works to integrate sustainability into healthcare culture, education and practice, and she's developed a framework for incorporating sustainability and quality improvement. Francis, it'd be great to hear about your experience in this field.
Thank you very much, Mood. Yeah, education is obviously critical, and I think one of the important things to think about is it's not just educating people to roll out changes that we have devised that are ready to go. We actually need the workforce to help co-create the changes that are needed, and so we need to think about education as being empowering to people to take things forward in their own setting. I think part of that is obviously raising the baseline level of awareness, and the baseline, and it's actually not a huge amount of knowledge that you need to get across to everybody. It's really the fundamental principle that environment and health are intertwined, and that this is indeed a health issue. And I think there is, as Chantal was alluding to earlier, a degree of carbon literacy that we need people to have, so that they have a sense, in the same way that we can, we have a sense that $1 is different from $100, is different from 1,000 or 1,000,000, that we can have that sense about where the carbon hotspots are in our processes and our products. But that's actually not a huge amount of knowledge that needs to get to everybody, and it is eminently achievable. I think it can be integrated across courses that healthcare professionals in training, but it can also be delivered, quite successfully. We're finding with mass open access online training. Then, of course, there is a need for the actual skills to take these things into practice, and I guess I would divide these into sort of technical skills, about say things like the practicing differently, like being able to, for example, empower patients and help them make make decisions about their care, and which is an important element. So there'll be technical skills around use of, say, local anesthesia or whatever it is. So those things, I think, can be integrated into training, and one of the most successful things that we've found is integrating into quality improvement training. And that's because quality improvement is a method for making change in systems, and change in systems is what we need to do. So and it's also an existing part of training for most health professionals, and it's spreading across to those groups now that haven't previously had to do quality improvement training. So rather than creating a whole new curriculum around sustainability, if we can integrate it in, if we can align bits of training and practice to deliver sustainability, we can do it without massively expanding the curriculum, and it can actually be very powerful, that process of reframing. And one of the great things about working, we've got a project which is in the UK, reaching out to all different institutions that are teaching quality improvement, and giving them tools and showing them how you can integrate sustainability into that. It is a way of taking it from the core committed people out to the the mainstream who may not have thought of it before, and they're actually it's been incredibly well received. I think people just think, oh right, okay, yeah, I can do this, I can see how this can be done. And then the student evaluation that we're getting is also really impressive, in that it's showing that people feel a sense of empowerment and ability to bring about change, and that they have confidence that they have some of the skills to get started on that. And interestingly, when we're starting now to look at the correlation between the different outcomes from teaching and what changes get made in practice, and the changes that people are making in practice has a greater correlation with people saying that they have confidence and skills than it does with their motivation to make change. So we need to move from telling people that there's a problem and this is what the problem is, to giving them some of the skills to act on that. And then finally, I think the other big element of education that we need is around leadership, and we need to engage leaders to help them to reframe this. We need things like fellowship programs or blended learning or ongoing programs where we support people to develop this and take it embed it in systems and learn from one another as they go. So I guess those were the three major approaches. I think the sort of mass education to everybody, integrating across other areas of the curriculum, and then developing leaders, whether that be through fellowship programs or board level training and so forth.
That's great. Thanks, Francis. So, I guess come back to one of the points that Fiona and Forbes have raised, that actually we need everybody to be doing this sort of thing, and everybody on board. I mean, we could argue that those who join your education programs are perhaps the converted, but to create change, we need to reach the masses. And some argue that the majority are not ready to make that transition, that field change in the way we do business. I mean, I don't want to be pessimistic about it. I've been incredibly enthusiastic, as I'm sure you have, over the last few months in seeing that change coming. And there's so many people really enthusiastic and converted that we need to do this. But nevertheless, there will be a lot of people that we need to educate and change behavior. So how can we engage the people who aren't on board without necessarily alienating? Because we need to bring them on board. We need everybody to be part of this.
Well, I think one of the really important things for doing that is aligning sustainability with the core mission of healthcare, which is to care for our patients and to do a really good job and get the best out of our resources. And I think when we start to do that, it doesn't become about, how somebody got to work that day. It's about how they can do a really fantastic job at work. And I think that people are motivated by that. And when you frame it in that way and you get in and you integrate it across the work that's being done, people come on board. And actually, if people are empowered to take action, that feeds back into their motivation. Because one of the things that's really demotivating is just feeling that you can't make a change, and that the system's too big, and then you feel culpable but powerless. And I think that leads, nowhere. So by changing that and then giving people the tools to actually make a change and make it part of core business, I think we absolutely can make it something that reaches everywhere throughout the system.
Thanks, Francis. Yeah, I completely agree. And I think we're fortunate in the UK that healthcare providers and hospitals, for example, and all other health providers have to have a green plan by January, which means that it requires the leadership of those organizations to engage with this, which hopefully will enable all of those who really want to make a difference, hopefully all of us that want to make a difference, to feel empowered to do so. So that's fantastic. And I come back to the learnings from India, that we don't need to think that there is a compromise in patient care when we're changing systems, because we have clear evidence that's simply not true. So I guess one of the things that we also need to do is, obviously, we need to work together. It's still, as Chantal said at the beginning, a relatively small number of people that are working on this in terms of building the research and those sorts of things in the education. And we need to spread word further, and we need leadership. We need institutional leadership. So I'm going to come now to Richard. Richard is chair of the UK Health Alliance on Climate Change, which is an organisation that brings together some of these institutions to work together. Richard was also best known for his time as editor of the British Medical Journal. So Richard, I was going to ask you, how do we build these collaborations across institutions within, say, the UK, but also further afield, so we all sing from the same hymn book?
Well, thanks a lot, Mood. Before I answer your question, I just want to give a description of what it's like here for those many people who've probably never been to a COP. I've never been to one before, and this is my first morning, and it's kind of completely bewildering. So we're here amongst with a health pavilion. There's about 80 pavilions. There's all sorts of noise and hubbub. Over here is the Congo Basin and African Global Challenge. Just there is the Senegal Blue Carbon. Saudi Arabia's just there. The Green Climate Fund is just there. The British Council is just here. There are screens everywhere and people bubbling around. And then there's an audience in front of us, all wearing masks, all on their phones or laptops. I hope they're listening to us, but I'm not absolutely sure they are. And the other point I wanted to make when we're talking about health systems, if you look at the Lancet Global Countdown publishes what's happening with the carbon footprint of health systems, and almost everywhere in the world it's going up. In the US, it's 12% of the carbon footprint of the US. It's clearly crazy that it's going up when it needs to be going rapidly down, as we're talking about here. So I'm the chair of the UK Health Alliance on Climate Change, which probably most people have never heard of, but actually it's existed for some 8 years. It brings together all the major medical and health bodies in Britain, the Royal College of Nursing, physicians, surgeons, anaesthetists, the colleges based in Glasgow, the BMA, the Lancet, the BMJ. And our members between them have some 900,000 members, which is most of the NHS workforce. And it used to be that we had to work quite hard to persuade people to join. Now we have people coming to us. So we've had 8 to 10 new members in the last year or so. People are really waking up to this problem and recognizing that healthcare has to do something and has to be part of the solution. And also that, as you're saying, it's part of the problem. And 3 things I think we can do by coming together. One is we can speak more loudly with one voice. We can go to governments and say, look, this is 900,000 health professionals talking to you. Some of the most trusted people in the community. As we know, nurses are even more trusted than doctors. Secondly, we can all learn from each other. So our different members are at different stages. Because just like the health system needs to get to net zero, they need to get to net zero as well. And some of them are doing pretty well. They've disinvested from fossil fuels. They're investing in renewables. They're cutting their travel. They're changing their canteens. They're having more meetings online. Others are some way behind. So those who are moving fast can help those that are moving more slowly. And then lastly, and perhaps most importantly and relevant to this, if you're going to get surgeons to change the way they practice surgery, who better to do that than other surgeons? It's going to be much less likely that bureaucrats in some skyscraper somewhere are going to influence surgeons. So we've established a working party, which you, Mood, are going to share. Chantal is going to be part of it. It includes all the surgical colleges in Britain, the anaesthetists, the nurses, the obstetricians, the dentists, the vets. So between us, we cover most of the surgery in Britain. So when you and Chantal, and we've got funding for this luckily, come up with a brilliant plan, we can go to surgeons and say, look, here's a formula for what you need to do. And as regards barrier, I suppose our biggest barrier is lack of resources. We have only 1.6 employees. We could potentially employ 50 people and do real good, I think.
Thank you, Richard. That's great. I mean, I'm very happy that you've put it on record that I'm going to create a brilliant plan that all surgeons are going to. You have great confidence in my abilities. So it's great that we work together. And I think what we also recognise, and of course you know this more than anybody, is that health systems around the world are actually very different and how they're structured and funded. So in the UK, we are quite privileged that the majority of healthcare is state provided, although there is not an insubstantial private provision. But in many countries around the world, healthcare is privatized or increasingly privatized, even in low resource settings. We're seeing privatization of healthcare and fundamental difficulty where, let's be honest, there is sometimes a tendency towards over-investigation and over-treatment where profit can become a motive. So how can we bring other healthcare systems, particularly those that have got a private sector influence, into this conversation?
Well, I mean, I would suggest that each country needs a network like ours, and that should include private players. I mean, we have debated whether we should do that, whether we should include pharmaceutical companies and others as members of our alliance. And so far we haven't. We've concentrated on health professionals, organizations of health professionals, because we think it gives us a particularly privileged voice. But at the same time, we're very interested to work with private sector organizations. I spoke the other day at a conference organized by WBA, which for me means West Bromwich Albion, but actually is Walgreens Boots Alliance. And they have a huge coverage. We have to work with it. And I don't agree with your implication that if something is for profit, that means it doesn't mean that you can get to net zero. For-profit companies are going to have to do that as well. And in fact, I chair a small for-profit company of about 70 people called Patients Know Best. We do everything digitally. We don't have an office. We never have had an office. We measure our carbon footprint and we constantly work to reduce it. So I don't think there's any incompatibility between being for profit and reducing your carbon footprint. In fact, as I said at the beginning, most health systems, many of which are publicly funded, have rising footprints, whereas I think most companies, not least because one of the immediate benefits of reducing your carbon footprint is that usually you reduce your costs. And if you're about profit, then you're very, very interested in your costs, because there's no better way to increase your profits than reduce your costs.
Thank you, Richard. Yes, I guess there's always that the balance between when you're delivering the healthcare, you want that as low as possible, but you want more healthcare because that is the bread and butter of how, for example, you will make your money. The carbon footprint of the US is 12%, so that would suggest there is certainly a balance there. I mean, there's been a few questions in the chat, so it would be good to sort of bring out some of those ideas. I know there's been some question about whether we should be carbon footprinting products, and that seems a good principle, but Chantal, maybe I can come to you. I mean, how would we realistically achieve that? Is that achievable? Are we going to get honest, real data on this? Just your thoughts about the technical aspects of doing such a maneuver.
Hi, Mead. Can you just clarify, was that in relation to industry and looking at the supply chain carbon footprint?
Yeah, yes, exactly. So there were some questions about whether companies should be providing their carbon footprint, and that should be a metric on which we make some of our purchasing decisions.
It's really complex. We certainly need greater transparency from our partners and colleagues in healthcare industry, and we need to then have the information such that we're able to, in an open way, evaluate their underpinning processes, for example, in terms of the extent to which they actually use air freight within the supply chain. In terms of carbon footprinting and expectations on industry to actually do that, it's something that's very complex, and it's something that is subject to manipulation, essentially. So I think we're going to have to be very careful in terms of the way that we engage with industry, such that we are able to develop those metrics that are actually meaningful and that actually help us to make decisions in terms of our procurement. So I think it's certainly a challenging area and something that we're going to have to address in the coming years.
Thanks, Chantal. I mean, Fiona, do you have any thoughts on this as well?
Well, I mean, I think it's just that we're at a different stage of measuring environmental impact. I mean, can you imagine producing a product where you didn't know how much it was going to cost you to manufacture it? That's just part of what we do, in the same way as when we now develop any healthcare intervention, we think about health outcomes. That wasn't true half a century ago. We could change it so the environmental impact just becomes part of how we assess what we do. And that's, I think, we need to challenge our thinking. We might be at a different stage, but we need to just make an integral part. We don't need to make measurement a nightmare in terms of complexity, but we do need to make it part, because that's the only way we're going to change impact.
Thanks. And Cassie, perhaps I can come to you. I mean, one of the questions we've also had, I mean, Richard Newton, I know, has put on the chat the idea of infection control and this idea that we have to have a lot of single-use product and a lot of products. I mean, I'll be honest, I go crazy about the gloves that are used, for example, in a hospital. And although this is not the forum, I could talk to you about the endemic forced labor in Malaysia that has been created by our penchant for using billions of single-use gloves at the lowest possible price, as well as all the environmental harms. But there are lots and lots of things about infection control. Is that actually a concern, or is the learning, for example, from India and from your own work, that actually those two things are not discordant?
I don't think that you need to have disposables to have good infection control practices. Of course, because we're here in the US, for example, really geared around disposable equipment, it will take some shifts in process and in behavior to get used to not throwing everything away every single time you use it or not use it. But we definitely see in other settings that it's not, these things don't go hand in hand necessarily. So we can definitely design better systems. We should definitely try to do so, because it's really not sustainable to have to constantly be buying brand new disposable items every single time. And as we saw through the pandemic, it's really not a great strategy for resilience either, that we depend heavily on these global supply chains that have cracks in them, and climate change itself will cause issues and disruptions in our supply chain. So we'd be better off diversifying into more reusable products. The reusable products have to be designed for reuse. So we have seen some issues with endoscopes, for example, not being designed well for cleaning. So those are other aspects that need to be considered when looking at infection control. But we could certainly use more infection control people working on these sustainability issues.
Thank you. And that's certainly a discussion I'm trying to have. And I think, the learnings from India are fantastic, both in terms of infection control, but also bringing the production of products close to home so that we can actually control this and bring economies of scale that we would dream of now in high income countries. So I think it'd be great to, I think it's time that we need to finish this session. I want to thank all of our speakers for a very broad and engaging discussion. It's clear that we need lots and lots of different aspects to this. We need industry, we need leaders, we need education, we need research, and we need collaboration to make all of this work. And I encourage all of us, in fact, I've been really enthused over the last several months at how much this is gaining traction and how people are talking about this. So please let us all continue and let's make healthcare a leader in this field, because this is as much as a climate crisis as it is a health crisis. So thank you all also to our audience for listening in, and thank you again. Goodbye.
Thank you.
Recording stopped.
Yep.
Couldn't hear anything.
Hello? There we go. Okay, welcome everyone. Thank you for joining us today. If you don't have them yet, you might want to get headphones on to be able to hear more easily. Sorry?
Doesn't work for me.
It's not working. Okay, we're having a little bit of technical difficulty.
Okay.
Here. Yeah?
Okay.
Okay. So let's go ahead and get started here. Welcome everyone. This is the Climate Smart Healthcare Delivering Sustainable and Climate Resilient Health Systems session. So very exciting work happening in this space, and I'm really glad you're here to have an opportunity to hear about it and have some dialogue about it. So we know that at this point, health systems around the world are kind of facing a threefold challenge. We need to be able to provide universal access to high quality, affordable, prevention-oriented healthcare. We need to be able to respond to health threats from climate change. And we also need to transition towards zero carbon healthcare so that we're in line with the direction that we all need to move globally in order to address the climate challenge. So this event is going to explore what it takes to provide climate smart healthcare, national challenges and solutions in delivering that, and it's going to showcase some examples of how that's being done. We're also going to talk about policy solutions for climate and health and how we can drive healthcare provision that's fit for the future. So we have a number of panelists. We'll have a bit of opportunity for questions, and we'll have some examples to share here. So, without further ado, I'd like to introduce and turn to our first speaker, Dr. Purnima Prabhakaran of the Public Health Foundation of India. So Dr. Prabhakaran is head of environmental health and is the deputy director of the Center for Environmental Health at the Public Health Foundation of India. And I'm personally very honored and fortunate to get to work with her regularly because she also sits on the board of the directors of the Global Climate and Health Alliance and represents PHFI on the WHO Civil Society Working Group for Climate Change and Health. So with that, over to you, Purnima.
Hi, everyone. Thank you, Jenny. I think the feeling is likewise. I just enjoy working with you as well. So I'm really grateful for the opportunity today to be speaking to all of you and present some perspectives from India on building climate resilience of health facilities. So next slide, please. So I don't need to have this slide really, but just to bring us all onto the same page, climate change, why are we talking about it? It is the biggest public health challenge of the century, but it also presents us with the biggest opportunity of the century. So really, we are all here to address this with the most appropriate and timely response that we can all think about. And a big component of that is building the resilience of our health sector, because they are really the first responders in the term of in the event of acute climatic events. Next slide, please. Yeah. So this is a very busy slide, but I was just putting that up there to give us some perspectives from India. So in terms of, India is home to about 18% of the global population, and it has extremely diverse climate zones. We are often described as countries within a country. We have 29 states and union territories, and every one of them has a different climatic zone. So we might be having floods in one part of the country, but we will be seeing a severe heat wave and a drought in another part of the country. So really the response has to be contextualized at the state level. We're responsible for about 3.2% of the global emissions, and every year weather-related disasters result in several deaths and morbidity as well. So disease burden is also increasing in India. And most of the developing countries, like India as well, we do not have a firm public health infrastructure. In terms of the numbers as well as the doctor-patient ratios, we don't do very well. And we don't have enough investment as well in public health infrastructure. So apart from the health access and the disease burden that we need to address, India is one of the most vulnerable to climate impacts, and we face huge social as well as economic costs. That figure over there, every additional ton of carbon dioxide will cost India an additional $86. This is Science Nature report in 2018. So the implications of climate change for India cannot be understated. Next, Alison. So what links climate change and healthcare? I mean, it seems very intuitive, but there are two things. One is that there is increasing recognition of the impacts of climate change on health. There's going to be a surge in disease burden, and there's going to be a growing dependence on healthcare services. Do we have the requisite capacity? Do we have the knowledge? We're hearing this time and again, that we do not have this even in medical curricula. Forget air pollution. I'm a doctor. I never studied air pollution. I heard about tobacco, but this new tobacco of air pollution, we did not have it in medical curriculum. And climate change is still more an abstract concept. We don't have it in medical curriculum. So do we have the knowledge and the infrastructure even with our health workforce? And are we prepared? The answer is probably, sadly, no. And so this is really a wake-up call. Next slide, please. So I want to then take a positive look at the situation. In terms of a response in India, we fortunately had the Prime Minister's Council for Climate Change, which was established way back in 2008. So while that was the positive side, you will see that it had 8 missions. And do you see health over there? No, it didn't happen till, next click please. It didn't happen till 7 years later. In 2015, they added 4 missions, and one of them was the National Health Mission. And thankfully today, next slide please, under that National Health Mission, which was established in 2015, we have a national program for climate change and human health, which is hosted by our Ministry of Health and Family Welfare. Next slide. Yeah. So that program is sitting within our Ministry of Health. What they have done is they've recognized this is not something they can do alone. So they reached out to institutes of repute that bring domain expertise into the program. So they recognized 18 centers of excellence within the program to contribute to the development of a framework for climate response. And we are there as a center of excellence. Next, please, next bit. To feed into the climate resilient and green health infrastructure piece. And we do a bunch of different things. We are developing the health adaptation plan. We are developing standard operation guidelines, a number of training programs as well within this program. Next. So our Center of Excellence at the Public Health Foundation of India is working to develop an overarching framework to develop climate smart healthcare facilities. Once this national framework is developed, we're going to be handing it to all our states to then customize. Like I said earlier, we have different climate vulnerabilities in India. So every state will contextualize this for their zone. Next. Yeah. So in terms of dimensions of green and climate resilient facilities, this all comes from various frameworks we've drawn from the experience from WHO guidance documents, Healthcare Without Harm, there's a World Bank report. All of them have given us some guiding blocks to develop this. So our framework now includes these components. It starts from site selection, where you're going to site your healthcare facility. You look at historic flood zones, flood levels. So talking about site selection, building and infrastructure, resources, optimal use of water, energy, how we handle our waste, healthcare waste management, that has a huge footprint as well. Transport, communications, human resources I mentioned before, awareness, so capacity building programs, and last but not the least, we need leadership. We are looking for peer leaders like you who can take this agenda forward. And of course, climate financing and intersectoral coordination. The health sector cannot do this alone, so we have to work with the transport, the energy, the agriculture. Everybody has to come together to do this. Next slide. So just a graphic of the same thing. This is the framework that I'm going to be giving to all the states. So the same 10 components, and at the center of it, you will see human resources, capacity building, leadership, and money. The climate financing is so important. There's very little, 1.2% of our GDP is invested in public health. It's an abysmal number, but that's why I've put climate financing at the center of all of it. And we have some front runners not only in the public health facilities, that's a primary health center in the state of Chhattisgarh. This is one state that has solarized all their primary healthcare facilities. And we have a bunch of primary public hospitals and private hospitals who are already showing exemplary work in terms of moving the agenda for climate smart healthcare. Done? Yeah, next, last slide. So I wanted to also place here a picture of our Indian healthcare system. That's what it looks like. It's not like in the UK, the NHS, where you have a single health system. We have this challenge of a public and a private healthcare system. And in the middle of all of that, you also have the Ministry of Defense, the Ministry of Railways, all of whom have their own hospitals and healthcare systems. So when we talk about moving our healthcare system towards climate smart healthcare, we're talking about addressing all of these different hospitals and healthcare facilities. Yeah. And I just wanted to close by showing you some examples. We have some exemplary healthcare facilities and systems in India who've already started working towards many of these components of climate smart healthcare. So that's a private hospital that was set up in Bihar, the state of Bihar. It's one of the poorest states in India, but one hospital, 100 beds to deal with the pandemic, but also built on principles of sustainability. So some clear front runners and exemplars of for action. And I'm going to stop there, but I'll be very happy to take questions. That's really just a whistle-stop tour of the scenario in India. Thank you.
Thank you so much, Purnima. Just fantastic work that's happening there. Okay, next we get to hear from Aziza Rangunwala of Groundwork South Africa, who joins us actually virtually from South Africa, representing Groundwork. And her expertise is in developing policy in line with the Sustainable Development Goals. And I just have to say, I've worked a little bit with Groundwork in a few different capacities, had the opportunity to learn about the work that they're doing, and they're just doing extraordinary work. So over to you, Aziza.
Thank you for the introduction, Jenny. My presentation is just about how we work with climate smart health systems in South Africa. My presentation is not on. Can I share my screen or? Okay, let me try and share my screen.
Don't share your screen, please. It's coming up on the.
Okay, all right. Now it's just thanks. Okay, so at the core of greening the healthcare systems are environmental health practitioners that are dedicated to protecting public health. So their work includes water quality, food control, waste management, health surveillance of premises, surveillance and prevention of communicable diseases, vector control, and environmental pollution control. There's been great steps in getting these health workers involved in healthcare facilities in South Africa. And doctors and nurses that are primarily dealing with patients are also roped into these issues. Global Green Healthy Hospitals has 99 institutional healthcare members representing interests of over 1,000 hospitals, health organizations, and health systems. Next slide, please. When it comes to climate change, there is a need for capacity building. 9 years ago at COP17, the importance of involving environmental health and other healthcare practitioners in helping communities increase their capacity to respond to the impact of climate change was highlighted. We are making strides, even though the progress is slow. And in the Global Green Healthy Hospitals program, several workshops and exchanges are planned to capacitate healthcare workers. And these workshops are accredited by professional boards, such as the Health Professions Council of South Africa and the South African Medical Association, for continuing professional development. Now, climate change information should be part of the university curriculum from undergraduate levels to postgraduate levels for all health workers. Like Dr. Purnima just emphasized, that as a doctor, that was what was missing in her curriculum. In South Africa, the University of Cape Town Masters in Public Health students are starting to incorporate climate information. So water scarcity, waste management, and energy sources are important considerations when it comes to climate change in South Africa. Healthcare's mandate is for people to be well, but the procurement processes alone end up we end up with 70% of that purchasing ends up as waste. Hence, the pledge for Race to Zero involves doing business innovatively, looking at the entire life cycle of the product. Now, waste management says cradle to the grave, but we are trying to eliminate the need for a grave. The photos on the side is actually how COVID-19 waste is being handled. And as you can see, boxes are used instead of reusables and are also bagged, which is excessive. And waste generation also increased significantly during the pandemic. We need to find a balance between infection control, occupational health and safety, and reducing our waste and carbon footprint. Now, waste as a major cost driver and cause of pollution means we have to look at alternative treatment of healthcare waste, and that's one of the ways we are decarbonizing the health system. According to legislation in South Africa, pharmaceuticals and anatomical waste has to be incinerated, which affects OHS and the environment. There are many non-burn technologies available, and they should be assessed thoroughly. The picture shows members of GGHH visiting off-site treatment facility using microwave and frictional technology to render the waste unrecognizable. This treatment site is from a certain service provider and it's off-site. And on the other hand, we also look at on-site treatment using chemicals and shredding. Now, speaking of service providers, they are interested in green technologies for treating healthcare waste. The Think Green picture I put in is actually from one of the waste trucks. And we have involved them in GGHH activities, including mercury elimination. Now, businesses that work with healthcare facilities are being roped into the circular economy and should be held to a higher standard to ensure sustainable business practices. Now, the school shoe you see is basically made from PVC material from health consumables such as drip bags by Netcare South Africa. And these school shoes are donated to kids that don't have school shoes. Now, recycling initiatives are gaining momentum, but where possible, this should be avoided. We're looking at recycling empty pharmaceutical containers as well as trying to get businesses to use less packaging. So just to conclude, I want to say generating enthusiasm in the healthcare sector is also about giving recognition and doing ceremonial tree planting at the facilities to seal the deal and pledge to going green. Thank you.
Thank you so much, Aziza. Really wonderful to hear about the work that's going on there, and what it takes to get it done, and what you're looking to continue to do with it. Okay, for our next presentation, I will turn to Andrea Hurtado, who is coming to us from Healthcare Without Harm in Latin America, and who came to Healthcare Without Harm with a background from the Mexican Foreign Ministry, where she was the coordinator for sustainable development. And I was really thrilled to get to meet Andrea in person here, having worked with you a bit over the past year or two. So Andrea, over to you.
Thank you so much, Jenny, and it's 100% mutual. So first of all, thanks to GCHA, thanks to PHFI, the Wellcome Trust, and everyone, and of course the Health and Climate Network and everyone who's made this event possible. So I've been asked to talk about what's going on in Latin America from the policy perspective. A lot of it has already been said by the speakers that preceded me. But as Jenny was saying, before joining Healthcare Without Harm, I worked for the Mexican Federal government for over 8 years. So in my experience, there's 3 key elements that make a policy successful. And what I would like to do with these 5 minutes is to talk about these 3 elements and how we're seeing them play out in Latin America. So first key element for me is to have a high-level mandate. It's crucial to have this high-level mandate because, first of all, it's an expression of political will, but also because very complex issues, such as the climate crisis and, of course, the compounding health crisis, are not to be solved by a single sector. You usually need cross-sectoral collaboration, and that can only be achieved when you have a high-level mandate. And also when that high-level mandate comes in the form of an international instrument that adds this additional layer of international accountability to that high-level commitment. So the key example that I'd like to bring to everyone's attention from Latin America in this respect is Argentina, who last year became the first country, not just in the region, but in the world, to include measures for mitigation and adaptation in the health sector in their NDC, their nationally determined contribution. So this was a key milestone. There are lots of NDCs that talk about health, but usually constrained to the adaptation side of things. So the fact that they're putting mitigation in there for the health sector really, again, creates this mandate and forces ministries that have probably never been, or are not traditionally involved in climate policy to become involved, right? And so that is one very big thing that happened this year, well, at the end of last year, that I think is a policy innovation from Latin America that other countries should replicate. The second element that I'd like to bring to your attention is that these high-level commitments that we've been hearing so much about at events such as COP, you hear these big political headlines, but they need to translate into national and subnational laws, plans, and programs. Otherwise, you don't get anything done, right? And so in this regard, I'd also like to bring a couple of examples from Latin America. So first of all, from Colombia. Colombia is actually mandated by law to develop these, they're called comprehensive climate management sector plans, and there's a lot of line ministries that are mandated to create these. And now the health sector has been mandated to develop one of these, and the Colombian Health Ministry is actually already working on this. And that plan is notably going to include both mitigation and adaptation measures for the health sector. Then there's, of course, the case of Chile. Chile is one of the very few countries in the region that currently has a national adaptation plan for the health sector. It was developed in 2016, and it is to be updated in 2022. And it is also notable that in Chile, there's currently a discussion in the Senate to approve their own national climate change law. And if approved, if the current draft is approved as it stands, it will create the mandate, again, for sector plans to be developed, and one of them will be for the health sector, again, including both mitigation and adaptation. So that will be fantastic to see. And a third example is Peru. Peru has developed a portfolio of adaptation measures, of 14 adaptation measures expressly for the health sector. So these are the kinds of plans and programs that will actually make such a high-level commitment a reality on the ground. And then third and final key element, and Purnima has said it, and Asisa has said it, I can't stress this enough, is the means of implementation. And of course, when we talk about the means of implementation, we're talking about financing, but we're also talking about technology transfer, and as everyone here has very much highlighted, capacity building. And I'd like to focus on the capacity building bit, because that's what we do at Healthcare Without Harm in Latin America. We do technical support. So with Colombia, we just signed an MOU and a memorandum of understanding, the details of which we're going to be announcing very soon, but with the Ministry of Health of Colombia, through which we will be launching a pilot project to estimate the carbon footprint of the Colombian national health system at the facility level through a representative sample of the facilities in Colombia. And that will be hopefully an example to replicate elsewhere in the region and in the rest of the world. Then, of course, with Chile, in 2018, we ran the first estimation of the national public health system's carbon footprint at the facility level using Healthcare Without Harm's climate impact checkup tool. And that resulted in one report in 2019, already estimating. It was the first country in the region to estimate its national healthcare footprint. And this year, at the beginning of this year, we had another training session with the updated Healthcare Without Harm tool. And they have now updated that estimation, and they will be publishing very soon. And with Peru, of course, so that portfolio that I talked to you about of adaptation measures, it was developed together with UNDP. And now the Peruvian Health Ministry has become a member of GGHH, the Global Green and Healthy Hospitals Network, and we will be working with them next year also to help them estimate their climate footprint. And they've already undergone a first training session with a checkup tool. So that's the kind of work that we're doing. But I do want to highlight before I finish that this is just what Healthcare Without Harm is doing. It's important, but it's certainly not enough. And I do think that it is important to say and recognize that these are all very interesting, very important policy developments and innovations that are happening. They are led by the health sector in the middle of a pandemic, and so in the developing world. So that is nothing less than heroic, in my opinion. And these kinds of initiatives should not just be recognized and seen, but they should also be supported. So let me end on the note that many of you might have heard that this year, for the first time in the history of COP, the presidency has put out a COP26 health program that includes a few initiatives, two of which ask countries to make national commitments. One on developing climate resilient health systems and the other on developing sustainable and low carbon health systems. Now, I can't say which countries have committed to that until the 9th of November. Be looking out for that announcement on the 9th of November. There will be a presidency event on this. But I can say that there's quite a few Latin American countries that have joined the commitments, that have joined both commitments, and they will need more than technical support. They will need financing, they will need technology transfer, and they will need all of our support on capacity building. So I will leave it at that. Thank you, Jenny.
Thank you so much, Andrea. Such extraordinary work, and for so many years that Healthcare Without Harm has been moving the needle on this issue, and it is really, really exciting to have this initiative as a part of COP. And I can't wait to find out which countries have committed. It's like, what are these? Looking forward to it. Okay, fantastic. All right, so our final presentation before we open up to some questions is Mrs. Ngai Khan, Director of the Green ID Vietnam, who is a very strong member of NDC's, NCD, not NDC, but NCD Alliance and NCD's Vietnam. So over to you, Khan.
Yes. There we go. Yeah. Okay. So can you have to open the slide? Yeah. So first of all, good morning, good evening, on the audience joining this session here or online. Today I am very happy to represent for a number of alliance in the new network partnership we call Climate and One Health partnership in Vietnam. This partnership that's new established with the participation from NCD Vietnam, Vietnam Sustainable Energy Alliance, Climate Change Working Group, and also the environment and community group. So my presentation will share the information that's prepared by the colleagues at in Hanoi from NDC and also from NCD and also from the Ministry of Health, because COVID situation keep high intention in my country. So the response person in charge of this topic cannot come here because she have to work at home to help the nation. So next slide, please. So in my sharing, I'm trying to share what happened in Vietnam regarding health and climate, and also what are the response from civil society on this, and the way forward, how we want to learn and cooperate with the other partner. Next slide, please. So as you may know, Vietnam is one of the most vulnerable country by the impact of climate change. We have a low delta, and we also have a different tropical weather. It was estimated that annually we lost 2% of GDP caused by nature disaster and climate change impact. The health impact of climate change in Vietnam can be classified in like a communicable disease, like some like a dengue fever, There's influenza, hand, foot, mouth disease, and also increasing hospitalization by non-communicable disease like stroke, heat disease, and respiratory disease by both air pollution and climate change. Next slide, please. To respond to this situation, I think like many other countries, we also have a national like action plan on climate change, and it's led by the Ministry of Environment and Nature Resources. But then each sector develop a sector plan to respond to climate change. So the Ministry of Health is in charge of the national action plan on climate change regarding health, and this national action plan was developed and approved by the Ministry of Health in 2018, with the period from 2019 to 2030, with a vision to 2050. It have a overall objective of strengthen the adaptive capacity of the health sector to prevent and mitigate the risks and the impact of climate change to the health system and human health. I think this is overall one will be implemented through a number of specific objectives. First one is consolidate the mechanism and policy of the health sector in response to climate change. The second one is to enhance awareness and strengthen capacity of health worker and community in climate change response. Last but not least is strengthen adaptive capacity of the whole healthcare system in response to climate change, with the priority given to grassroots level. The implementing agency of this national action plan for climate change in the health sector is the Health Environment Management Agency under the Ministry of Health. This is also the department now mainly in charge of COVID response. They have many support from international organizations like WHO, UNICEF, UNEP, and also work closely with the local network of NGO, including NCDVN, the new partnership among CSO and Health and Climate Change Partnership, and also the other INGO like FHI 360, and also World Bank ADB provide the finance support, and they also cooperate with the other relevant ministry. A number of activities they have been implemented recently is they conduct the climate change vulnerability and adaptation assessment at national and the province level. And based on that, capacity building on climate change response also develop and hand over to the local level and the health sector. And doing raising awareness of health worker and community on climate change response through a number of training and sharing experience and material. And regarding the action from civil society on health and climate, before coming here, we have organized a number of events taken into account the key message from 4 briefing paper from Health and Climate Network, and also taken into account the recommendation from WHO. Firstly, the network was formed just like I think 2 months before COP, and we respond by doing together in a series of meeting and workshop with multi-stakeholder covering a number of topics. The first one is climate finance for health system, and the second one is energy and health, how those the two things can go along, and also diets and food system for health, climate and planet, and nutrition and food system, and transportation and health. So those topics were discussed in detail in a number of workshops we organized with the other ministry and officer and NGO. So we delivered one recommendation letter on health and climate change to the delegation who come here before the opening of the COP. Next slide, please. And for PodCop, we also plan a number of activity. We continue to run our social media and media campaign to deliver the message and also from health climate network and also from WHO's recommendation as well as the updated progress here. I'm very happy to share with you that our country, our Prime Minister has made a breakthrough commitment that our country aim to achieve net zero by 2050. And yesterday, the Minister of Trade and Industry also delivered the message, enjoy and sign on the global statement on transition from coal energy to renewable energy, in which it have a four 4 point. I think that if all those points be translated into action, it support a lot for protecting the health of the people and also the health of our planet, because it confirms to not giving any new permit for new coal power plant, because that is the biggest emission and also biggest pollutant to causing air pollution and health impact. Besides the awareness raising, we also we organize maybe podcast event to update the situation and also strategize what we need to do to follow up and support with the Ministry of Health to align and revise the national plan to make it follow net zero. And also a lot of effort we need to work further to advocate for the national energy plan to revise. And we continue to join hand and engage with the Ministry of Environment to contribute and advocate for a number of under law regulation were developed to promote greenhouse gas reduction and environment protection for health. Next slide, please. So what we need from both the ministry and from civil society, from the ministry implementing national action plan will require a lot of collaboration and partner with the international organization and partnership. So they need technical support, they need the financial assistance, and also how to be able to tap the climate finance for the developing country. For civil society, especially for our new partnership, we also want to cooperate with the other partner like Healthcare Without Harm. We didn't have a follow-up for a number of years, but I think that is the right time for us to put together the action. And we also need to be build capacity to consider both adaptation and mitigation for the health sector. So that is my last point, but I really want to learn from you all, and we hope to have a good discussion. Thank you.
Thank you so much, Khan. Wonderful to hear about the work that you seem to be pulling together, all of those presentations and sessions in 2 months after forming the collaboration. Extraordinary. And we hear some themes coming up across here, the need for finance, the need for technical support, the need for capacity building, and also the need for both high-level mandates and policies to actually implement things on the ground. Okay, so we're going to take 1 or 2 questions here so that we have time for an interesting discussion that comes right after the panelists. And then if we have time at the end, we'll allow for some additional questions at that point. So are there any questions for any of our panelists at this point? Any questions right now? Yes.
Hi, good morning. Thank you for sharing about the help program for the presidency. I was just wondering, where should we submit the commitment? Because I was talking with people back home, if asking them if my country, I'm from the Philippines actually, asking them if my country has committed, and we believe it hasn't yet. So we're just trying to figure out how can we submit commitment and what are the requirements. Because I've seen the website of Healthcare Without Harm. I did not see my country's name in on the list who committed already. Thank you so much.
Great question. Is there anything that you actually are able to say about that?
Sure. So first of all, there is a website, a WHO website that has the full program in it. So there are some requirements per initiative. So for example, for the resilience bit, there is a requirement that countries will commit to doing a vulnerability assessment for the health sector, and that they will develop a health national adaptation plan. For the sustainability and low carbon bit, there are differentiated requirements depending on whether it's a big emitter or not. But some low and middle income countries who are not big emitters are committing to reaching net zero in their health systems by 2050 or even before that. I can't say which countries have joined, but I can say that these are non-binding commitments that countries present not to the UK government or the presidency, but to their own populations. They just do it through the platform of the COP presidency. And it is as simple as having a ministerial level letter signed and presented to the presidency through an email account. That is the COP26 Health Team email account that I'm happy to share with you after the panel.
Wonderful. And kudos to you for doing that work and reaching out to your government. That's the kind of thing that makes changes. Yeah. We have a question online. I can't hear you, sorry. Okay, so Louis, if you could unmute and ask your question.
Thank you very much. I'm sorry I came in a little bit late, so I might have missed this, but I think it's essential not to obviously we have to reduce emissions from our facilities and make them greener. But in addition to that, do we not also need to transform the way our health systems work and the way we think about health? For example, we should reorientate health systems towards a primary healthcare approach, moving the center of gravity of health systems out of hospitals into communities where health promotion, disease prevention can play an important role if it's properly delivered by community health workers and other locally based health workers. This will reduce the amount of travel you have to use to go to the hospital. It'll reduce the burden on hospitals and health facilities. If a lot of the care is in the home, there'll be a massive reduction in the need for procuring high-powered equipment and so on. So I think it's essential for anyone who's interested in reducing emissions from health systems to advocate for a shift out of hospitals to communities and comprehensive primary health care.
Yeah.
That's my comment.
Yeah. That's a really excellent point. Thank you so much for that comment. And indeed, part of the framing of this session was to articulate the need for universal access to healthcare. So providing that primary care, providing that localized care, I think is vitally important. And so it's not just changing the existing health systems, but really transforming our health systems as a whole. So because of time, Purnima, it looks like you would like to jump in on that, or?
No, just to say that I think we've been talking about reimagining healthcare. That's become like the punchline. So it's also about changing to innovative models of healthcare delivery, and I think the COVID pandemic showed us that the entire shift to digital, telemedicine. But in terms of telemedicine also, there's an equity issue over there. There are communities that may not have access to internet. So there's an innovative model that we are piloting in India. It's called assisted telemedicine. So you put up a very small unit in a remote village which has one doctor, one nurse, and one laboratory personnel who can run, in a one-stop shop where they get everything done and also connect them to an expert through, right there in that unit. So everything is done at that place, and that's why the concept of assisted telemedicine. The other model is about task shifting. So we have poor doctor-patient ratios in many parts of the world. So it's also a livelihood issue. Train other people who can take off the burden from the doctors and deliver some of those services that doctors need not do. We have a few models that could work, and I take that point. I think it was Louis, right? So yeah, you think about moving it to preventive and preventive aspects of healthcare delivery, prevent disease and promote health. Basically.
Yeah, absolutely. Thank you so much. Okay, I'm now going to thank our panelists and invite up Mohammed and Rhiannon. So would you two join us, and maybe our panelists could switch?
Thank you.
So thank While you are getting settled up here, thanks for the reminder. Before we shift you all, we have a set of slides that showcase international examples of success.
Hello, I'm Antonella from Healthcare Without Harm. Just want to show you a few cases of how this is being implemented in the ground, just shortly. So one of the very good cases that we have from Colombia during the pandemic, these are all cases during the pandemic. So in Colombia, this case is on sustainable procurement. This is a hospital that was already working in sustainable procurement. They already had a policy and a team when the pandemic hit, so they were in a very good place to think outside the box in a way, and they were able. I remember when we talked, and they say, if we implement the protocols as they come, we're going to produce 5 more times waste that we are doing, and they were working really hard before the pandemic to reduce waste. So they prioritized reusable PPE, and they started creating their own for all the tasks that could really use reusable PPEs, and left the disposable ones that they couldn't get because they were short. The shortage in the supply chain happened in many developing countries, so that was an issue. They didn't even have enough disposables. So with the reusables, they really saved. They purchased 36,000 less per month units. So that was 3 tons less of waste per month, tons of an $82,000 per month saved with just this act. One hospital in Colombia. This is a hospital of around 600 beds. It's quite big, but not that big. So this is the first one, and it's one of our leaders. So in Colombia. So yeah, let's go with that. Let's move. Yeah, and we have 500,000 less masks. So it's a lot, really. It's a lot. And this is just one institution. So imagine if this replicates. So let's go. This is one of South Africa. We have cases of institutions where, as Purnima was saying, some of you, where access to healthcare, it's an issue too. So with buildings that we are saving water, reusing water, and heating hot water with renewables is what it doesn't say here, that you are heating water with renewables, so you're saving liters and you're saving money too. Let's go to, this is Chhattisgarh, I think. The case that Purnima was showing is Chhattisgarh had 900 health centers powered with 100% renewables, and that allowed these institutions to provide better care and increase 50% of the patients that they were receiving per month, because as they now have a more secure energy system and they can rely more in the electricity because they have the solar panels, they can receive more patients. And that that was very good for the system and for childbirth. And it really was. We have all these cases published in a report that we just recently released with the World Bank. So these are all case studies that are online this week. And that, no, just you see, in 2019, before the pandemic, they had 900 hospitals with this. In 2020, during the pandemic, they increased that. They almost doubled that because as they already knew that it was going to be good for them during the pandemic to be able to provide care. Okay, so, and we have this from Malaysia. This is Suchi. This is one of our members too. We have many members in Southeast Asia that are really serving only vegetarian food. And they are using reusable food containers. You know that like caterings are a big source of plastic waste, so using reusables is really good there. And these have helped reduce their contact with the public too when you need to. Okay. So do we have time? Okay, so let's go. No. So so we don't have time. So but we have all these in the World Bank report, and we are here. It just Healthcare Without Harm team is around, so ask us because we have members in 74 countries. So there are many things we can tell you about. So that's it.
Thank you so much, Antonella. And those are fantastic examples, and I'm sure you'd be happy to talk to folks about other examples after the session. I want to make sure that we have time to talk with our two discussants here. So we have Rhiannon Osborne from Students for Global Health and Mohammed Aissa from International Federation of Medical Students Associations. And I would like to ask both of you to discuss a couple of questions. So the first questions I have for you are, as young people are entering the medical profession, what is your top concern for the health sector in the coming decades as we face the climate crisis?
So I would say that's like a difficult question because there are many concerns regarding the health sector. But I would say our awareness of the issues and our capacity in terms of addressing these issues, because this is what we actually call for. We always call for the capacity development of the medical students. We always call for the capacity development of future healthcare professionals in terms of their issues. So what we're talking about, for example, when we're talking about climate change, we don't have climate change in our medical curricula. We don't learn about it. We don't know, we just learn about it from our external or extracurricular activities, which is actually a big concern. So this is a problem because there will be thousands and millions of medical students who are graduating and actually getting into the health profession without understanding the determinants of health, which include the environmental determinants and include climate action and climate change. So this is actually the big concern because we are trying to work on this. We are trying to work on the inclusion of climate change in medical curriculum. And even in one of the webinars we have been in before, we have been discussing even including this in the residency programs and the training programs. However, still it's an issue. Still, medical students themselves, many of them are not aware of how major issue it is and how it's contributing to health. So I would say the awareness and the opportunity of working on our own capacity development in order to be able to address this issue, whether as healthcare professionals or whether as just humans being affected by climate change.
Yeah, and I know IFMSA has been calling for that inclusion in the medical curriculum for a few years now.
Mm-hmm.
Yeah, Rhiannon, anything to add?
So was my mic on? Okay, yeah, there we go. So I always feel kind of bad because I always come to health events and then I hijack it by talking about economics. But I would say that probably my major concern when it comes to health and building kind of climate resilient health systems is building a global economic system that can support that. And I think it's important as the health community that we reflect on the fact that this is set to be the most exclusive COP ever, in a large part due to the incredibly horrific global inequality in terms of vaccine access and ability to respond to the COVID pandemic because of international trade laws and a lack of technology transfer from monopoly companies to other companies mostly in developing countries who could make COVID vaccines. And global pandemics are something that are likely to increase as the climate crisis worsens. And so I think there's a direct relationship between people not being able to be here because of global vaccine inequality and the kinds of things that we're calling for, like loss and damage finances and finances for health adaptation. So I think it's really important that as the health community, we think about how all these things are interrelated. Another example being that the majority of low and middle income countries had to spend more money servicing their debts to the IMF during the pandemic than they were able to spend on strengthening their health systems. So I think for me, as someone entering the health profession, what I really want to see is engagement and an understanding, both within the health community and outside of the health community, of the global economic justice dimensions of what we need to build strong and resilient health systems.
Thank you. Yeah, and so that really segues nicely into the next question, and both of you touched on different aspects, but what do you really want to see from the health sector in order to address the concerns that you're talking about? What should the health sector be doing to address the concerns that you're talking about with respect to capacity, that you're speaking about with respect to financing and equity?
So so I would answer this question maybe more a strategic way, using WHO actually framework of health systems. Since like we have our own building blocks that are there, but we don't like use them much when it comes to working on the climate action and working on tackling climate change. So maybe I would look for better health governance, better like leadership, better in terms of understanding actually the issue. What we're facing here is that like country leaders and people from party delegations, they still don't understand what's the link between health and climate change. So we need better governance. The people who are leading the health sector need to understand actually the issues that we're facing. Another thing, the financing, how much we're allocating, and like we need to work on better strengthening our financing system for the climate action. Many people just rely on domestic investments, many people just rely on private funding. We need to make a strategic framework for how we are financing the health sector and financing the education actually for the medical students in terms of the inclusion of the climate change in their own curricula. Another thing, the health workforce, which is actually us, working on our capacity building, working on our training, working on our education. Unfortunately, in many areas, it's just like a doctor has to be specialist in the clinical medicine and that's it. But it's not just about clinical medicine. That's why public health is actually very much connected to clinical medicine. So it's something that we need to work on, the service delivery itself. And this is very important because we are the frontliners when it comes to dealing with the population. And the population will be educated, like the population has so much trust in the doctors and in the healthcare professionals. We need to make use of this. We need to educate the people while we're delivering the service to them in terms of consultation, in terms of diagnosis, treatment. We need to talk to them about what's actually causing their problems and what's causing their diseases. We need to work on stronger health information systems, having databases, having better understanding of what we are working on and using the technology much more strongly in our work, taking into consideration that many countries do not have this technology. So we also need to make sure how we're using our digital technologies or how we're using technologies in general. So we talked about health workforce, financing, governance, service delivery, and we also need to work on access to essential medicines and access to access to, I wouldn't say here essential medicine, but actually to the essential information, access to what we need to know in terms of health literacy. So all these, like, there are more building blocks, but just all of these are just the equation that needs to be met together in order to ensure that the health system as a whole is actually working on better tackling the climate action. Thank you.
Fantastic, thank you. Rhiannon?
Yeah, I would say that something that I would really like to see more of, and I think it's been really exciting to see things like the Healthy Prescription Letter, is health workers being actively engaged and mobilized in political action. I think a lot of the time we kind of are a bit nervous and about going outside of our health system and talking about health, but I think it's absolutely essential that we build the political, and by that, I don't mean by that like kind of party political capacity of health workers. I mean our understanding of power and relationships and how we make change not just within the health service but outside of it as well, and mobilizing health workers to do that. And like congratulations to like GCHA for the incredible work on the Healthy Prescription Letter. And I think, I think the other thing I was going to say that we kind of need to do more as a health sector is also listen to other people as well. I think we have a lot of expertise in the health system, but other people have so so much expertise which is often not traditionally acknowledged or respected in health communities. And I think we need to start going outside of traditional knowledge and peer-reviewed papers. Not that they're not great, but like looking to like communities at the front lines of the climate crisis, looking to refugees and migrants who can't access healthcare systems because of migrant charging systems, and listening to those communities, and also as well as lending our voice of expertise, recognizing that sometimes there is space for humility as well.
Fantastic. So we just have a minute left, but I think this last question is super important. What would you ask of leaders here at COP26? What would you like them to do? What would you like to see them do here at COP26, national leaders that are gathered here?
Oh, that's a really hard one. I'm going to end up being here all day. I think the biggest one would be committing to a million, the 100 billion of climate financing and loss and damage. I think like addressing that is like the biggest public health intervention that we have, because there's no amount of money that can ever compensate for the loss of life and suffering that the climate crisis is going to cause. But at minimum 100 billion a year is the least that we can ask.
Yes. So what I would just ask, yes, I'm here representing 1.3 million medical students, but yeah, actually on a personal level, I'm coming from a low middle income country. Please, health equity when it comes to climate action and health in all policies. We have been calling for this for ages. Health in all policies. Health must be in transport, in finance, in energy, in every single pavilion here. It must include health. This is very important for us to mention, and it must be like an intergenerational, intersectoral approach. It can't be one stakeholder. And I have in one, I guess it was Mrs. Panoza in the opening plenary, she mentioned it's a shared responsibility and it's a shared planet. So it can't just be the country leaders sitting out there making their own negotiations and decisions and leaving us here. We must all be included in the same room, talking together and trying to find a common solution for our own shared planet. So yeah, health in all policies, health equity and inclusion. Thank you.
Well, thank you to both of you. Could we have a round of applause for our two discussants as well as our extraordinary speakers? Thank you for a fabulous session. We are out of time, so I encourage those of you who have questions for any of the speakers to corner them after the session and ask them your questions. And thank you once again to everybody who was part of this session.
Can you hear us? Hi, everyone. Can you all hear all right? Welcome, and thank you so much for joining this COP26 event that's led by My Green Lab. It's so wonderful to be here with all of you today, and it's such a privilege to have this stage with you all. My name's Gail. I work under the leadership of Nigel Topping and Gonzalo Munoz on the Climate Champions team, and I'm the health sector lead. And it's been a privilege to work with such amazing organizations, including My Green Lab, Sustainable Healthcare Coalition, AstraZeneca, over the past few months. In this role, I focused on the pharmaceutical and medical technology sectors in bringing non-state actors to the race to zero, where members commit to halving emissions by 2030 and becoming net zero by 2050. We also have the 2030 breakthroughs because we recognize that long-term targets need interim and tangible ones. So for the sector, our interim target and 2030 breakthrough target is to have 95% of laboratories across major pharmaceutical and medical technologies My Green Lab certified at the highest level by 2030. I'm pleased to be joined here physically today with Ben, who's the climate lead at AstraZeneca, as well as virtually, which I believe you will see shortly. I think, yep, their videos should be turning on shortly. And the wonderful virtual speakers who I'll introduce shortly. So with that in mind, I'll hand over to James, who's the CEO of My Green Lab, to give the full introduction. James, over to you.
Thank you, Gail. Thank you for the warm welcome and introduction. I'm so excited to be joining all of you at the COP26 World Health Organization Pavilion, as well as the nearly 500 people we have registered online. It's clear that this year's conference is a turning point for the global climate change movement. And as Gail mentioned, we believe it's also a turning point for the biotech and pharmaceutical sector. So I'm joined here today, both online and in person, by Girish Narula, the CEO of Urgentum, an award-winning science-based target-aligned climate risk advisory firm, Dr. Fiona Adshead, chair of the Sustainable Healthcare Coalition, and in person, Ben Norbury, global climate lead at AstraZeneca. Today, we are unveiling a brand new study produced by My Green Lab with support from Urgentum, quantifying the total carbon impact of the biotechnology and pharmaceutical industry. This is the first study to address the extensive supply chain of the industry, including Scope 1, 2, and Scope 3 emissions. We identified critical hotspots for change, as well as charted the industry's progress towards achieving Paris Climate Agreement targets. The conclusions are clear. Biotech and pharma has a significant carbon impact, and it must be part of the climate solution. Like nothing else before, the global race to develop and distribute a COVID-19 vaccine has demonstrated the power and the positive impact of science. However, the development and delivery of these breakthroughs can come at a significant environmental cost. Laboratories are incredibly resource-intensive spaces. Labs use up to 10 times more energy than a typical office space, 4 times as much water, and they produce an incredible amount of plastic and other hazardous waste. In fact, a 2018 study that inspired what I'm going to be presenting today found that the pharma industry globally has 55% higher carbon intensity than the automotive industry. Healthcare globally is 4.4% of total greenhouse gas emissions. And 71% of that comes from the supply chain, of which biotech and pharma make a significant contribution. This is the challenge that My Green Lab is trying to solve. Our mission is to build a culture of sustainability in science to transform the industry into a global leader on environmental sustainability. Through education, community engagement, and market-leading certification tools, we are inspiring the scientific community to integrate sustainability into everything they do. And I would like to quickly acknowledge My Green Lab's corporate, government, and private foundation partners. This paper and all of our work would not be possible without the generous contributions of our funders. So as we dive into the first conclusion of our study, unfortunately, we still have a lot of work to do. While the largest companies by revenue are reducing their emissions year on year, the majority of companies within biotech and pharma do not have targets aligned with 1.5 degrees C. More aggressive targets have to be set, and those targets have to be backed up by measurable action now if we're going to avoid the worst impacts of global climate change. Carbon emissions and carbon accounting is separated into 3 different scopes that I'm going to be referring to throughout this study. Scope 1 includes the direct emissions from burning fuels on site. Scope 2 includes all the electricity and the carbon impacts from that electricity that a company purchases. And then Scope 3 includes the upstream and downstream impacts of a company's value chain. And that tends actually to be a larger portion of an industry's overall emissions. So as you can see from this chart, measuring the carbon emissions in biotech and pharma over the past 5 years, the largest companies have actually been making reductions. You can see on the bottom lines here, the 2 green, the light green, and the dark green are the top 15 companies and the top 25 companies by revenue. So they've actually been driving down carbon emissions for scope 1 and 2 year on year. Unfortunately, when you look at the rest of the industry, the picture is not quite as good. In fact, overall, when we look at 66 companies for which best quality data was available over the past 5 years, carbon emissions for scope 1 and 2 is increasing. If you look at scope 3, the top 15 and top 25 companies started reporting their emissions largely in 2015, 16, and 17. That's the big bump you see on the chart there. Those companies have actually peaked and begun to decline. However, many of the other companies have not been fully reporting their scope 3 emissions. So we actually expect scope 3 emissions to increase in the short term as more companies report. And unfortunately, while the leading companies have set ambitious targets like AstraZeneca, who's joining us today, the rest of the industry is lagging behind. Only 42% of companies in our study had set carbon reduction targets. And of those carbon reduction targets, only 3, less than 4% of the total, were aligned with the Paris Agreement targets by 2030. And it's critical that companies set carbon goals not only for 2050, but also for 2030. We simply can't wait to start reducing. In fact, in order to meet the IPCC's 1.5 degree low energy demand scenario, the entire industry will need to reduce emissions by close to 7% year on year, starting now. Our second finding looks at the magnitude of the total carbon impact of the industry. Looking across the industry at 234 companies, we found that biotech and pharma has a significant carbon impact, 197 million tons CO2 equivalent. Surprisingly, that's actually more than the semiconductor industry, more than forestry and paper, and even more surprisingly, nearly half the total annual carbon output of the UK. And this study is only looking at publicly listed companies. If you include private companies, universities, and government labs, that number is much, much higher. And as I mentioned before, biotech and pharma can be an incredibly resource-intensive activity. In fact, for scope 1 and 2 emissions, biotech and pharma is 15th out of 38 industry sectors. But scope 1 and 2 is just part of the story. Our study found that scope 3 emissions are typically 5 times larger than scope 1 and 2. So achieving zero carbon in this industry will require engagement across the entire value chain. This next chart breaks scope 1 and 2, as well as scope 3 emissions down by company. The bar graph represents scope 1 and 2 emissions, and the dots represent scope 3. As you can see, scope 1 and 2 emissions are highly variable from one company to the next. You will notice companies that have headquarters in Asia Asia Pacific tend to have higher carbon emissions for 1 and 2. This is likely due to dirtier energy grids and a larger portion of in-house manufacturing. Most companies in biotech and pharma outsource at least a part of their research and manufacturing, and that's a growing trend. That's not going to show up in their scope 1 and 2 emissions data. That is why it's so critical that you look at the entire value chain when you're evaluating the carbon impact of the industry. From the massive variability in the data for scope 1 and 2 and scope 3, it is also clear that better and more consistent reporting is needed. Lastly, we dug into the hotspots for scope 3. And it turns out purchased goods and services, as well as use of sold goods, tends to dominate. And biotechnology and pharmaceutical is similar to medical technology, apparel and textiles, as well as healthcare retail. So it's clear that biotechnology and pharmaceutical need to engage both their suppliers and their customers to be part of the solution. In conclusion, our findings show that the biotechnology and pharmaceutical industry has a massive amount of carbon impact, and that carbon impact is largely from scope 3. So suppliers and customers are critical to drive change. Furthermore, the industry overall is not aligned with a 1.5 degree world. More ambitious targets need to be set across the industry if we're going to avoid the most devastating impacts of climate change. However, as Gail mentioned, setting ambitious targets is just step one. Those targets must be backed up by concerted and measurable action now. That's where organizations like My Green Lab come in. We provide the education, awareness, and industry-wide sustainability frameworks to turn climate talk into climate action right at the lab bench. My Green Lab certification, our flagship program, targets carbon reductions of a company's scope 1 and 2 emissions by improving the efficiency of a lab. My Green Lab's ACT label, the premier eco-label for lab products, supports carbon reductions for anything purchased or consumed at a lab. Further, since many companies outsource their research, My Green Lab certification can also drive reductions in their supply chain by asking those labs also to become certified. The need to move from commitments to rapid measurable action is why My Green Lab certification was selected as a breakthrough outcome by the UNFCCC. The UNFCCC's Breakthrough Outcomes campaign set a goal, as Gail mentioned, that 95% of labs in pharma and medtech are certified by 2030 at the highest level. And we believe achieving this target will be a crucial turning point for the industry on their pathway to zero carbon. Further, as we pointed out in our study, you can't have green labs without green suppliers. So My Green Lab's ACT label, which stands for Accountability, Consistency, and Transparency, is a critical tool for driving reductions in the carbon emissions of laboratory products. ACT rates products in terms of a number of key sustainability criteria from manufacturing use to end of life, and then allows scientists and companies to make better purchasing decisions, as well as providing a framework for manufacturers to measure and reduce their impact. In sum, My Green Lab's programs are a self-reinforcing ecosystem to drive holistic change throughout the scientific community, from engaging labs through our Green Lab certification to suppliers through our ACT program, and individual scientists through our Ambassador program and our Green Lab accredited professional program. While we are still far from achieving our goal of 95% of all labs certified at the highest level, we're making incredible progress. From humble beginnings at the founding of our organization in 2013, we have now certified over 700 labs in 31 countries, and the program is truly starting to scale. But given the enormous environmental impact of research that I mentioned, we can't rest on our laurels. We need engagement from everyone across science to achieve the widespread transformation necessary so that the industry can meet Paris Climate Agreement targets. Today at COP, we're issuing a call to action to every scientist, to every supplier, to every university, every funding body, and the global biotech and pharmaceutical industry. Join us in achieving our 10-year vision. Just imagine if every scientist was fluent in sustainability and knew how they can make a difference in their work and their actions. Imagine if every lab was green and if every laboratory product was designed with the environment in mind. Imagine a thriving culture of sustainability at every leading institution in science. There is perhaps no other industry that has the culture of innovation, the resources and ambition, and the tried and true experience solving the world's most complex problems for the benefit of humanity. We firmly believe that science can and must move from a laggard to a global leader on environmental sustainability and serve as a model for the rest of the world to follow. So with that, I'm going to hand the screen over to Girish Narula, the CEO of Urgentum. He's going to introduce himself, his organization, and speak briefly about their data set and methodology that form the backbone of this study. Girish?
Thank you very much, James. That was quite interesting, even though we were part of the study. It's quite interesting the way you framed this problem and the 10-year vision. Hi, my name is Girish Narula. I'm the CEO of Urgentum. We are a company which focuses on climate transition risk. We do three things. We collect data. We analyze around 5,000 companies across the world every year. We have a data set of modeled plus reported data of around 30,000 securities, and we are continually expanding that. We also work, we have a platform where we put all this data together for producing some of the analytics that you saw earlier in the presentation. We work with the financial services industry through our climate solutions team as well. Some of our clients who you may have heard of are the European Central Bank, IMF, European Commission, and so on. And on the commercial side, we work with the leading asset managers and banks in the world. We are a small team, but we share your ambition and passion. We are a mission-driven company. One of the things that we want to do as part of our work is create more awareness, and that's why we are part of this study to enable some of your big pharma companies and others which are not yet reporting to start disclosing and provide them tools which can help them look towards the future and align for a more sustainable work environment. So no, glad to be here. And then I can talk a bit more about data if anybody has any questions.
Awesome. Well, thanks for joining us. Yeah, if people have questions about the methodology, I will defer to Girish and thank you. And thank you for providing the data for this report. Next, I want to introduce Fiona Adshead from the Sustainable Healthcare Coalition. Fiona and her colleague Keith were reviewers for this paper, and she's going to place this work in the context of the global healthcare movement. Fiona?
Thanks very much, James. I mean, as you've said, I think, we're at a tipping point. It's the first time that a COP has recognized health as one of its scientific programs. And it's great that Race to Zero is now working with all of us to really get the sector to change. But I think I've been working in this area for a little while now, and I guess what I've noticed is this real acceleration of interest in the last 18 months. And I think, in the past, the healthcare sector has not really had much scrutiny from a sustainability point of view. But as a number of reports from Healthcare Without Harm and the UK NHS has pointed out, that healthcare is part of the problem as well as being part of the solution. I mean, globally, we represent about 4.5% of admissions. So we need to do something about it. But we know that we can be part of the solution. And we were formed as an organisation about 10 years ago because the health service in the UK recognised that the supply chain was a large part of their overall footprint, about a third for medicines and devices, but overall about 2/3 of their own footprint. And really, they realised that they couldn't work on their own, that they needed to work with industry, and they needed to think about how they could both measure by measuring carbon intensity of products and devices, medicines and devices, which is, we came up with the first global guidance on that, but then to put that into the context of the patient journey through the system by developing guidance and measurement around care pathways. Well, measurement in itself is not an end. What we're really trying to do with that is design environmental impact out of healthcare. And that's, I think, where we're really at the tipping point, because we're really beginning to understand that that's necessary. And that once we begin to look at some of the case studies that we've done, what we find is that things that improve health outcomes also reduce environmental impact and also reduce cost. So in fact, these things go together. But really importantly, I think the point that healthcare professionals have begun to realise is that there is a choice. We've chosen in the past to disregard environment, but what this transformation means, and what, as you suggest, is behind your vision, James, is the fact that every decision we make every day in healthcare needs to have environment as part of it. And that's really where we need to get to. But I mean, how are we going to change as a system? Well, I think one of the ways is through incentives for the industry. And now, both at a global level through the work that Healthcare Without Harm have been doing with UNDP, looking at the Sustainable Procurement Index, and the work that the Greener NHS team in the UK has been doing, looking at putting net zero for its suppliers at the core of what they expect, that's beginning to incentivize and change. But I think central to what you were saying is that if you're going to have a vision, it's not just about the knowledge that you have today. We also need to imagine what the future is going to be about. And it's that imagination that can really inspire action. And one of the things that we found as a coalition is by bringing clinicians together with manufacturers to really look at products and services and really redesign them differently, we can make a difference. So it's both about incentives, but it's also about inspiring people to work together to change. But it's also about shining a light on the areas where there isn't much action at the moment. And you've mentioned Scope 3. And one of the areas as a coalition with our partners that we've got very interested in the last year are clinical trials. We know that research and development, innovation is absolutely core to the industry. And we were mindful of a study that was published about 10 years ago by the Sustainable Clinical Trials Group, showing that basically, if they estimated the impact of the then 350,000 clinical trials that were in the system at the time, they worked out that that was about a third of the footprint of Bangladesh. So in other words, it's huge. So what we've started is a piece of work with the Institute of Cancer Research, funded by NIHR and the Medical Research Council here, to really come up with an eco-design tool for clinical trials, because we want to work out what their contribution is, how to design them before we start to reduce that impact, but also to look retrospectively at current trials, and also to really think about how that could contribute to the sort of work that you're going to do. And we're very interested, as you know, James, in thinking about, well, how could we use that kind of approach for clinical trials as a continuous improvement process, just as you've done for Green Labs. So I guess really we are at this tipping point, and yet we can go further. And we're really delighted as a coalition this week to be part of the newly launched Sustainable Markets Initiative, which is being championed by AstraZeneca and many other colleagues in the industry, to really look at how we can collaboratively go together, because we need to work at pace and at scale globally, as well as in the granularity that I'm talking about in the everyday with clinicians. And obviously take the agenda to new areas such as clinical trials, which we know are so valuable to come up with the new medicines that everybody needs, but where we're not really scrutinizing the impact they have. So that in the end, to match your vision, what I'd like to see is that every day, every decision around healthcare includes environment alongside the important outcomes for clinical care, but also the consideration of cost. Thanks, James.
Thank you, Fiona. And lastly, I have the privilege of introducing you to Benjamin Norbury from AstraZeneca. AZ is one of the first companies in the industry, and really, in fact, in any industry, to set science-based targets for zero carbon, including Scope 3. They also happen to be the largest adopter of My Green Labs programs globally and are truly walking the talk when it comes to sustainability. Ben?
Thanks, James. So I'll introduce AstraZeneca and our climate strategy. We're a global pharmaceutical company. You've probably heard of us now. We're operating through the full development life cycle of medicines, from idea, research and development, manufacturing, sales. And really, we see climate change as a threat to public health. The climate emergency is a public health emergency. The causes and consequences of climate change have negative health impacts that will undermine development in healthcare and all the progress that's been made in the last 50 years. While the solutions to climate change also, reduce pollution, have direct health benefits, whether that's more active travel, cleaner air, cleaner water. So really, regardless of climate change, you could make the case that we need to take these actions to decarbonise for public health reasons. as someone's already said, the healthcare sector is responsible for over 4% of global greenhouse gas emissions. It's huge, and the new report highlights that variation in reporting. But one theme comes through very clearly is that supply chain challenge and also the use of goods as well. But I think even if we can't quantify to the fine degree all of the things in our scope 3, we know where the hotspots are. We know what we need to focus on: purchase goods and services, and that's why through our flagship Ambition Zero Carbon strategy, we've committed to reach zero greenhouse gases from our global operations by 2025 and ensure that our entire value chain is carbon negative by 2030. To date, we've made some good progress. Scope 1 and 2 emissions are down 60% from 2015. Over 99% of our purchased electricity is from clean, renewable sources. And we're sending those market signals to some of the initiatives we've joined, such as the climate groups EV100, EP100 and RE100 commitments there, so that we're giving that voice and demand in those markets where maybe the infrastructure does not yet exist. So, as I was saying, the report highlights how key the supply chain is to decarbonisation. That's why we were very keen to be part of the road testing of the Science-Based Targets Net Zero standard. At the same time, we were going through the process of having all our Scope 1, 2 and 3 climate goals verified in line with the 1.5 degree scenario. So we're very pleased, to come through that process. It's not easy, but we're a science-based company. So we apply the same logic to dealing with climate change as we do to dealing with, coronavirus and new medicines. We're one of the only 7 companies to so far have our targets verified for net zero. But we want this to be a collaborative action. It's going to be a kind of a hollow milestone if we're only one of 7 in 12 months' time. So we really want to see that collaboration support into our peers and our supply chain to take it to the next level and take the blah 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 out of net zero, some might say. So that's why we're going to collaborate. Announcement yesterday on renewable energy with our peers as well. 9 other large pharma companies collaborating to support suppliers to access renewable energy. Even if we can't get perfect measurement on that full Scope 3 value chain, we know that moving to renewables is directionally positive. So we will do that, and we will resolve the data as we go. But really, we know it's the right thing to do for climate change and for public health. Thank you.
Excellent. Well, thank you, Ben. And I think we'll hand it over now to Gail for some questions, unless there's also questions from the audience.
Great. Well, maybe we'll start with questions from the audience, actually. So you had your hand first. I think you might need the microphone.
Hi, can you hear me? Yeah, thank you so much. Sorry. It's Jacob here with the RC Psych. Thank you so much, and it's really exciting to see working so closely with industry, and obviously within mental health, pharmaceutical companies have a huge role in providing treatments. I just had 2 questions in the spirit of having a dialogue, and there's lots of discussion of this collaboration between industry and the health sector, and generally I think how finance can support the transitions. But I just wondering, given prevention is synonymous with low carbon care, is pharma prepared to make less profit for the sake of greater climate mitigation? And then my second question is, there's discussion of collaboration and less blah, blah, blah. And also this interesting point about the need to incentivize industry. But it is important to remember that pharma global revenues were 1,600 billion in 2020. AstraZeneca, I just checked, and profits were up 10% last year, which congratulations, but also thank you for all that hard work that you guys did. But given that this is a global health crisis, as partners in health, what are the panelists' thoughts on supporting health-focused decarbonization projects that are outside of the global value chains of pharma companies, such as through financial donations, perhaps mirroring some of the philanthropic work we've seen in the last year?
Great. Thank you so much for that. So maybe, Fiona, do you want to have a go at answering that question first, given the work that you've been doing at the Sustainable Healthcare Coalition?
Well, there are quite a few questions within that. When I was talking about incentivizing the industry, you're right that there are lots of ways that industry can act without being incentivized. I think, and they are, and I'm sure that others can talk to that. But what I meant was that when we're purchasing things within healthcare, that environment counts. Because at the moment when we purchase goods and services within healthcare, environment really isn't part of the decision-making process. And what I was really saying is that we need the market to shift so that that's recognized, because we can design the healthcare system that we want. So having environment as part of the decision-making process is really what I'm talking about. And then of course, to move from, Greta's phrase, blah, 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 we need to be able to move to a system, just as James is encouraging, where we've got greater transparency reporting, and that we then have third-party verification. And when you look at the journey that the Greener NHS team is going on, it's absolutely about that. It's about transparency and moving in that direction, because we not only need to act, but we need to prove that we've acted too. And that's why impact and measurement is so important, because then we know. But finally, coming to your point about prevention, I'm a public health doctor. My whole career has been based on persuading people that prevention is better than cure. So absolutely, I would agree. Where we would all like to be is to have less to do with the healthcare system. My aim as a doctor is always to go nowhere near it for my own healthcare needs. I'd much rather be healthy. And when we do, we need to make sure that that's delivered in a personalised way, where environment is part of the choice that I can make as a patient. Because I think what's interesting is that people, all of us who have healthcare too, are increasingly interested in this. As an industry, we've got to get ready to have more scrutiny and more questions. And there's a good example in the UK at the moment around the debate on inhalers. But I'll stop there and allow others to put forward their answer.
Great, thanks so much, Fiona. And I think just to pick on the point of collaboration, because Ben, you spoke about it, and I know that yesterday there was the announcement of the Energize program. You mentioned the Sustainable Markets Initiative. Can you go into a bit more, what does that actually mean? I know the question was about outside the value chain, but this one's something within, and then maybe your thoughts on what AstraZeneca wants to do beyond that in terms of philanthropy or anything that the question asked for.
Yeah, sure. So we're a founding member of the SMI, and our CEO, Pascal, is heading that initiative on the pharma side, and that is bringing together other CEOs of those other peers that we have to really create that system change that's needed in the whole industry, and then that embeds it basically in a business purpose, because we're aware that something that's led from the environment team may last 12 months, 18 months, something that comes through the CEO is going to last and be embedded in the DNA of the company, and then maximising that with the collaboration with the peers as well. We'll see that the whole industry change, and in terms of what we're doing around this and who's asking for what, I think the investors are holding us to account on climate change, asking the very difficult questions, as are our employees. So really, it's not a case of if or with profit and dealing with climate change. That's about attracting and retaining the best talent within our workforce. The My Green Lab certification scheme empowers our employees to be doing something on climate change. So it really does go hand in hand as a future fit business.
Great, thanks so much, Ben. And I guess on the point of profit, the concept of the triple bottom line and really saying that you can align profit with planet and people. AstraZeneca has been one of the leaders for a very long time in this, and I can see that you definitely believe in it. But what are kind of the key lessons learned that AstraZeneca has had from aligning their goals with sustainability and still seeing profits like that was mentioned? What are the lessons learned that you would encourage peers to also consider?
I think the coronavirus has just shown us that collaboration's key. It's vital, and it can happen fast and very decisively when we all have the same goal. So I think there's no good as operating on our own. Only those working with our partners is able to deliver that change at scale.
That's great, thank you. So to the floor for the next question. I'll go here and then I'll...
Hi, thank you so much. My name is Julius Alejandre. I'm a plant health researcher investigating the impact of pharmaceuticals in the environment. I want to ask questions to Fiona and Ben, specifically because Fiona mentioned that in the consumption chain, in the medicinal consumption chain, in the medicinal product supply chain, we need to integrate the environment and how we decide on the process, and part of that change to the consumption side. So what do you think are the tools that's needed by, because there's a lot of medical practitioners who really want to integrate environment in their, and how they prescribe medicines and how they select medicines. So what tools do you think the medical practitioners should have in order for them to integrate environment in their decision-making process and how they select medicines which are more environmentally friendly? And is the pharmaceutical companies such as AstraZeneca ready to support any tools that the medical practitioners need? Thank you.
Great. Fiona, over to you.
Okay, well, I think in terms of tools, for Care Pathways, we've got an online toolkit which allows practitioners to really pose what-if questions around their own care pathway for their patients. But in terms of prescriptions, one example which I think is there at the moment is in the NHS, there's been a lot of support around inhalers. So there's a site called PressQuip, which has a bulletin which gives you the carbon footprint of the different inhalers. So if you're a practitioner, you can do that. I was talking to some respiratory physicians earlier in the week, and they were sharing with me examples of one part of England in Sussex, where they have videos to support practitioners and they have easy guides. And I think the easier we make it for people to make those choices and have the conversation with patients. And that, I think, is the other bit, is that this needs to be about personalised care. People are always concerned about shifting just on environment. So every choice that we discuss with patients needs to also be about the best outcome for their health. And that means that we need to take them through examples and a narrative that enables them to choose for both. And there's some really good decision tools that NICE, our National Institute of Health and Clinical Excellence, has produced. And again, clinicians are now producing for discussions with patients. So there's a lot we can do, but that's the kind of resource I think that makes it easier. So it's there when you're having the conversation with the patient right in front of you.
Great. And Ben, do you want to answer the point on AstraZeneca?
Yeah, sure. So, I mean, following on from the talk of, the respiratory products, the inhalers, that is, just under 15% of our total value chain footprint is patient use of those inhalers. We've got a very active program to look at alternative propellants and bring those through, and that's part of our science-based targets as well, to launch those. In the meantime, we're doing a lot of research into, a well-controlled asthma patient is, a lower carbon patient. So you never let things get to the stage where there's an emergency intervention, because that's when the carbon footprint of your care pathway skyrockets. So really that earlier intervention, controlling something as well as possible, as well as redesigning those products with the climate in mind, is the solution.
Great, thank you, Ben. We've got another question from the floor.
Thanks very much, and thanks everybody for a really interesting discussion so far. My name is Colin, I'm from Ireland's Health Ministry, I'm in the Climate Unit, and I'm formerly a negotiator in this space, so it's really interesting to see from your side how you see the interactions between the climate, and we're trying to map it as well, between the health sector and how that interacts with the climate space. Some of what My Green Labs have talked about reminds me of some of the measures that are being taken by the finance sector in terms of voluntary reporting of how they're divesting from fossil fuels and being more sustainable. And I think that these kind of hubs that we're talking about, and especially as you look into scope 2 and scope 3, it's a really interesting space to bring the conversation into. What I'm wondering is, and I guess what I'm kind of hoping it is whether My Green Labs or AstraZeneca has any experience as they look outside their own direct emissions into the people they engage with, whether they're encountering other hubs who might be also taking that forward from the point of view of producing the raw materials or the machinery or whatever it is, and if there's actually, or this could possibly be the beginning of a process in that general area, or if you have any thoughts on that. Thanks very much.
Great, thanks, Colin. So James, do you want to answer that from a My Green Labs perspective?
Sure, happy to answer that. And it's great to hear from the Ireland Health Ministry, and My Green Lab actually has the largest number of green labs of any country outside the US and Ireland, and our program has been catching on there in both clinical labs as well as in research labs. So one of the things we realized earlier on with the Green Lab certification is you simply can't have green labs without green products. And there's an enormous amount of consumables, chemicals, and equipment that's purchased for laboratories through a very extensive global supply chain. So we launched the ACT label, which I just showed briefly on the screen, as a tool to help companies within the supply chain of biotech and pharma begin to measure and evaluate environmental attributes about their products and then provide needed transparency to scientists as well as to corporate purchasing and the sustainability teams about what products not only are more efficient in use, but actually have reduced their carbon impact in their supply chain. And it's been incredibly positive to see companies engaging with this actually. While the tool is designed as a benchmarking tool so scientists can make better choices, it actually becomes a self-reflective tool for the manufacturing community. And it was the first sustainability intervention in the lab products industry, an industry that really hasn't been focused on green and sustainable. It hasn't been a priority. And we're working with companies now that are making huge capital investments to retool their facilities, to install solar. The industry as a general is really trying to grapple with the issue of single-use plastics, find different alternatives, figure out collection and recycling and circular economy models. And so we're seeing it actually happen quite rapidly, and it has been really exciting to see collaboration among the supply chains within the manufacturing community. I think the importance of this is that it needs to start, though, with demand. And so Fiona talked about the NHS and other health systems starting to demand that their suppliers of medical devices, of medical treatments are zero carbon over time. That's now filtering down to biotech and pharma, and they're requiring it now of their suppliers. And you can kind of see how these things are completely interconnected. And if there's a consistent, clear ask, and then companies are given clear data where they can benchmark and measure their performance against their peers, then we will see reductions. And we're starting to see it rapidly in the lab supply chain through the ACT label program.
Great, James. Thanks so much. And I guess just to dig in before we go to another question as well, is that we often kind of bundle medtech, biotech, pharmaceuticals all together. Do you see that, these three subsections of the wider category that we're talking about has different challenges, and, which ones will go through the hardest challenges and how can we help overcome these? James, over to you.
Yeah, certainly different challenges, and we sort of straddle both academic research, university research, government-funded research, privately funded research through biotech and pharma, as well as the entire industry that supports these companies. And maybe to kind of talk about the industry from the supply chain on up, if you're a maker of pipette tips or you're a maker of a piece of analytical equipment, you're very, very responsive to what your customer wants. So if your customer begins asking you to make a more sustainable product that's in line with their sustainability targets, you will absolutely move forward and do that. And so what we've seen happen is the health systems have been the leader, and perhaps because the health systems understood the connection between health and climate sooner in some ways than others. And they have a focus on people, and many of them are nonprofit or government-funded organizations themselves. So they're taking the lead, and then they're driving it down into their supply chain, which is the biotech and pharmaceutical industry, which is driving it into the manufacturing industry. And so they're all actually connected together in sort of a shared supply chain, but there's an incentive flow or a demand flow that has to start at the very top with the end user, in this case, the patient, and making sure that the patient's getting the best healthcare with the lowest carbon impact. That's then driving transformation throughout the industry. I think some of the challenges that biotech and pharma is placing that the report points out is there's a lot of variability in how companies are reporting their scope 1 and 2 emissions, as well as their scope 3. So much of research is outsourced. There's not product level data. So even if, for example, AstraZeneca or another company made a decision to buy a lower carbon or a more sustainable product, that might not show up in their carbon reporting the way that it's being done at the aggregate level right now. So I think one thing we need to do is really get a handle on all of the things that are being purchased in the supply chain of these companies, come up with some basic understandings of their carbon footprint, and then show what products can be better so companies can really start making decisions and they can benchmark their supply chain, not just using an aggregate spend number, but by the actual products they're buying from actual companies. And I think that will facilitate faster transitions.
Great, thank you so much, James. We've got 2 questions from the floor, but just on the point of reporting that you mentioned, I just wanted to ask a quick question to Girish as well. So how do you think that, we've got so much variability in the way in which carbon's being reported now. How do you see that changing with future regulation that's coming into place?
Yeah, no, so we have been collecting data for the last 10 years, and we're seeing a lot of improvements in the reporting. Companies which were not reporting earlier have started to report. Regulation has come in with standards like TCFD, which are being followed more and more. So we hope that more and more companies will adhere to the GHG protocols, TCFD kind of norms, and more importantly, that these norms will have some sort of parity across the globe. So the UK won't have its own norms, US won't have its own norm, because as you can see with these large companies, they are spread all over. So I think that's one of the important things to remember. And we focus on scope 3 quite a lot as well. With the new regulation coming in, hopefully scope 1 and 2 would become mandatory, and a lot of larger corporates would disclose. One of our main objectives to be part of studies and collaborative efforts like this is to engage directly with the corporates, encourage them to disclose publicly, so companies like us can then provide that information to various stakeholders, not least the investment and the financial community. So I think there is hope, and I'm hopeful that more and more, as they go to My Green Lab for accreditation, they would also start disclosing more and more in public domain.
Great, thank you so much. I'm just going to walk to the floor for the next question.
Thank you very much. My name is Bas Tunter. I'm from the Netherlands, Nijmegen, and I'm graduated in molecular life sciences, and I saw during my internships an enormous amount of single-use plastics, and it seemed to be immensely ingrained in the way research is being done. And to say, all right, we're not going to use, or we're making it energy efficient, that those are, in my opinion, too small steps in order to get to a green, sustainable lab that we're aiming for. And I'm trying with the idea to get it from single use to make it sure that we can reuse, cleaning, sterilizing items. But how do you, as supply chain and the reporting, how do you transfer something that is so ingrained in the way research has been done, has been pushed for the last couple of decades? How do you change that mentality? Because I could really use some help in changing that mentality. Thank you very much.
Thank you so much. So James, over to you for that question.
Yeah, so that's a great question, and I think in large part the reason that sustainability in the lab is sort of a topic that's coming on the collective agenda of science and has it before is because the assumption has been it's too hard. The science is more important, and it's impossible to change people's behaviors and the culture of how they do research. And we've proven through our process time and time again that it is possible to change it, but it can't come sort of what we found from a dictate, hey, you can no longer use this process or system or tool. It has to really come from the bottom up. So our mission is to build a culture of sustainability in science. And the way that our Green Lab certification functions is it's actually a tool to educate and build awareness for scientists and researchers at the lab bench. One, about the environmental impact of research, and then giving them actionable tools and best practices for what they can do to make a difference. And so then it's up to them as a researcher to look at their processes, look at what they're doing, and understand what they can be doing to shift and change over time. And what we're seeing is this is actually leading to whole different processes by which products and treatments are being made, or whole different processes by which new ideas are being tested out. So we really put the knowledge and we empower researchers themselves And I think when researchers are empowered, just like Fiona talked about, clinicians being empowered to understand the environmental impact of their decisions, they can make better decisions that have significant ramifications throughout the entire culture of an organization. And if you really need that cultural change to shift these ingrained attitudes, behaviors, and habits. And that's what we're really targeting with our programs. And so I would encourage you to reach out to me. My email is just james@mygreenlab, but it sounds like our program might be the perfect fit for the type of cultural transformation you're trying to drive. And we do it now with hundreds of institutions all over the world and would be excited to partner with you on that.
Great, thanks so much, James. And I guess just to add, yesterday there was a COP26 Futures Lab on healthcare as well, and we heard from Omnia El Omrani, who's a resident, influential speaker, but she was also talking about, this culture change and saying that you need to embed it into the curriculum, into, not just medical students, but all students studying sciences, to really be aware that, when you work in the lab, when you work in practice as a professional, you do embed sustainability in everything. So yeah, just echo everything that both of you said and how important this is. Absolutely. Final question, I think. We've got time for perhaps actually maybe just two more. So Sonia, you've had your hand up, so I'm just going to go to you, and then we've got a few more from the floor as well.
Thank you very much. I've also worked in this space for a long time, and it's great to see this acceleration. I was just wondering what the next point of acceleration might be, and what you think the economic model behind this might have to be. Could we move away from payment by product to payment for outcomes, and what would that look like? And if we were to move in that direction, who would be the people bringing that change about? Because it's not just going to be people making daily decisions. We're going to need innovation at a huge scale to really accelerate the change. Wonder if you had any thoughts on that.
Fantastic question, Sonia. Fiona, I know we've been discussing this one for a few months, so maybe we'll start with you and see if any other speakers have anything to add. Tricky one.
Sonia, thanks for being such a good questioner. You always ask the tricky questions. I think the answer to that has to be, yes, of course, health outcomes have come to the fore. And we talked a lot about that in terms of value-based care for a while. I think we do have some new mechanisms, for example, digital can be a fantastic accelerator. I think, although it's a bit boring, metrics of measurement are important, because if we can't count it, we can't change it. And I think those are the accelerants. What I've noticed, though, is really the upswelling and the emerging trends within the healthcare system. It's fascinating that clinicians are now demanding change in a way they never were. And whilst we can talk about all this complexity about how healthcare is delivered, for me, it always comes down to that conversation with the patient. The choice of what you prescribe or the procedure that you do, or whether you focus on prevention or cure, all of those things, that healthcare in the end is about that. And I think if we really focus to how do we revolutionize personalized care to not only produce the best outcomes for somebody where they want to have it, for the reasons they want to have it, in the life they want to lead, plus that we do that in a way that doesn't damage the environment or minimizes damage, then that's really the sweet spot that we need to aim for. Because we've also talked for years about personalized care and really focusing on what patients want, and we've not done brilliantly at that either. So now's the moment, I think, to use digital and other things to revolutionize both, really making care patient-centered and making it environmentally friendly as well. That would be my thought.
Yeah, and I think just to build on the question as well, and the undertones of kind of, moving to a circular model, essentially looking at paying for services and outcomes. Ben, what's AstraZeneca kind of doing on this wider circularity agenda and kind of looking at outcome-driven perspectives?
Yeah, I think it's certainly on the agenda. Not maybe something I can talk to with any depth, but I do think it comes back to a bit like Fiona was saying around that earlier intervention. And circularity and less wastage, because if you're serving a patient with a product that isn't effective or isn't working for them, then that's a waste of all the embodied carbon you've used to create it and get it to them. So I think working up the care pathway as much as possible, start to support that anyway, and taking that life cycle approach to where the impacts are and tackling those.
Great, thanks, Ben. final question from the floor, then we'll just go.
Hi there, my name is Elaine Lockhart. I'm also from the Royal College of Psychiatrists. Thank you very much for all of this. COVID-19, we have seen some really disheartening changes in our increased use of single-use products within healthcare, and a very understandable push to develop vaccines and treatments for COVID, where saving lives understandably has been the first priority. But I think it might, I'm asking and guessing it might have set us back in terms of our carbon footprint. I'm just wondering if anything has been learned during the work during the pandemic to actually reduce the carbon footprint in all of our healthcare work.
Great, thank you so much for the question. And I guess because this is a wider healthcare system question, maybe Fiona and James, do you want to have a go at answering the question?
Yes, in terms of PPE specifically, Chantal Reason at Brighton has done some fantastic work on this, and you might have heard her recently on a radio programme in the UK talking about this. So look up Brighton Medical School's work, and Chantal in particular. And there they've really looked at how you can in fact reuse masks and other protective coverings. So that's definitely been looked at. I think what we've also learned is that we can change rapidly, that we can be much more ambitious, that the things where we found 1,000 reasons for not acting suddenly melt away when we have an imperative where we all need to act to protect health, you know, whether it's using digital consultations or other things. So I think what I've taken away from it is that health really matters to the economy and society, that we need to treasure it, that we need to realize that if we trash the planet, we trash our health too, and that we have a choice. And every day we need to bring that choice, you know, whether we're a manufacturer, whether we're a clinician, or whether we, you know, set policy or buy services, that's a choice. And we've got all the tools we need to make the changes. We just need to make it happen, which is why all the initiatives that you've been hearing about are important, because we can't do it alone. We have to do it together.
Thanks, Fiona. And James, over to you for further additions, as well as just closing remarks, as we're running out of time now. Thank you.
Great. No, I was just going to completely agree with Fiona. I mean, there's certain aspects of COVID-19 that have increased consumption of single-use plastics, but it's also demonstrated that we can get together as a global community to solve an incredibly dangerous existential threat. And climate change is a similar dangerous existential threat to health and the well-being of our planet in its entirety, and the people and the creatures that live on our planet in its entirety. So we need to work together to address climate change with the same intensity, the same spirit of collaboration that we brought to resolving COVID-19, and that, or the process of resolving COVID-19 that we're currently engaged in. And that's kind of brings to the fundamental conclusion that we have at the end of this report. And I think we can kind of wrap that up, which is, I just want to echo something that Ben said. You know, AstraZeneca follows the science. Science and the biotech and pharmaceutical industry is the industry that has the resources, the ambition, the knowledge and skills to lead the world on global climate change. And I think it's important that if we get it right in this industry, and we're a model for the world for how you can achieve zero carbon sooner, and maybe even beat the Paris Climate Agreement targets, will serve as a model for the rest of the world to follow. So I encourage everyone to take part in that. And I noticed some comments here. I agree, it can't just be a grassroots effort. It has to go from the individual scientists at the lab bench up to the boardroom. And that's what we're seeing now, which is incredibly encouraging. Companies' corporate goals are aligning with the new culture that they're trying to build. They're aligning with the new people that they're bringing into their business, and younger people are more and more concerned and more interested in addressing and making sure their company and or workplace is a leader on issues of climate change. And I think we're on the verge of a massive transformation in this industry. And I'm excited and encouraged about COP26, and particularly the change that's happening now in biotech and pharmaceutical. So thank you everyone for joining us, and encourage you all to download the report. We sent a link in the chat here, or reach out to us individually. And thanks everyone for joining us for this event. And Gail, thank you so much for your excellent moderation.
Thank you, James. Thank you, speakers. It's been so wonderful. Thank you for everyone for attending this. It's been a great session.
Hear you. Hello? Hello? Can you hear me? Hello? Hello?
Hello, everybody. Thank you so much. Thank you for coming. I'm very pleased to be presenting today with Dr. Courtney Howard. She's a very good friend of mine. She's an Emerge doc. She works in, can everybody hear?
Can you hear me? Oh, you can.
Can? Okay, I think we can. Okay. So Dr. Courtney Howard is an Emerge doc in Yellowknife, Northwest Territories. She is an associate professor at the University of Calgary, Cummings School of Medicine. She's on the WHO Civil Society Working Group, past president of the Canadian Association of Physicians for the Environment, and a lot of other credentials. And I'm really excited to present with her today a summary of a past change-making project we did together. So, Courtney, to you now.
Okay, you guys can hear me? Right on. Thank you for coming. This is an exciting time. I think we're feeling a lot of change happening here at COP. And, you know, I went to medical school and I didn't really learn how to make change. And so this is part of the change-making journey that we recently went on. Next slide. So this is me. This is Will. Will didn't introduce himself. Will is an engineer. He's a green buildings engineer. He works for the government of the Northwest Territories. He's in charge of permafrost, of protecting roads from permafrost. So, like, thanks, Will. I'm glad it's you and not somebody else. It's a big job. He's also got incredible design skills, communication skills in both Canadian official languages. And so I would highly advise that if you ever decide to take on something like this, you find someone like Will. It's a extremely, very multidisciplinary type of work, and multidisciplinary people are awesome to have on your team. Next slide. So this is where we live, and this slide is actually taken the week that I had my climate awakening. So I was a new Emerge doc. I had just graduated from McGill. This was in 2009. I wanted to work for Médecins Sans Frontières, Doctors Without Borders. And so they said, okay, if you want to work for us, you better go north, because I want you to get some experience working in a remote place without many resources with diverse populations. So I did. And on the way up, I was kind of embarrassed because I had just spent over a decade doing medical training, and I actually didn't know anything other than medicine. I hadn't followed politics. I didn't know what was going on in terms of the world at all. And so I had embarked upon a program of outside reading that to this day exists in a folder on my computer called Geeky Learning About the World. And so I picked up a book on climate change simply because I thought maybe as an adult I ought to know something about climate change. And I read it on my way up to a locum in Inuvik, which is north of the Arctic Circle. This part of the world is already 3 degrees Celsius warmer than it was when an 80-year-old elder was born. And so I read this book on climate change right as I went to the high Arctic, got off the plane, this was just sort of November, and was like, oh my God, you know, I didn't get training in climate emergencies, but I did get a lot of training in how to recognize badness in my emergency degree. And so I quickly went, I did a lit review and happened to pull up the Lancet Commission's first report on climate change and health, which said that climate change is the biggest health threat of the 21st century. So I was pretty annoyed that nobody had taught me about the biggest emergency. And so this is where we live. You can see that the river there is just starting to form, so it matters that there's a 3 degrees Celsius change, because you can walk on solid water and you can't walk on it once it's melted. And so this has consequences for hunting, for fishing, food gathering, food security, for trauma, for cold weather drowning potential, and also for cultural factors. This is at the junction of Inuvialuit, Gwich'in, and Dene territory, and the people who live here still get a large proportion of their lean protein from land-based foods. And so you can imagine when all of that changes, there's real consequences for health and social structures. And for mental health, some of the first studies on mental health have been done here. So it's a huge issue for our population. Next slide. And this has led really to a reframing of how I look at health. When I went to school, I thought that health happened in the emergency department. Next slide. And I now understand that the entire thing is underpinned by the ecological determinants of health, things like soil, water, the climate. Next slide. And when that's stable, it gives us the ability to form social and societal structures, financial systems that give rise to the social and structural determinants of health, things like income, housing, etc. And when that's going really well, we get to, next slide, build the extremely complex structures. Next slide, please. that are our high-income country health systems. And when you do a lit review, it turns out that only about 5 to 25%, depending on what country and what study you're looking at, of overall health outcomes come from healthcare structures. And so all of a sudden, I went from thinking that what I did in the emergency department was the most important thing to realizing that everything I did in the emergency department was entirely dependent on the ecological determinants and the social and structural determinants. Next slide. So I look at this as a planetary health nest, and it really informs how I work. Next slide. And of course, there's been mental health challenges associated with that. I know a lot of people have eco-anxiety, ecological grief. We actually have a dance video coming out tomorrow that Robin Stott and I put together, so I'll invite you to take a look at that. Next slide. And I've really found that taking action feels better than anxiety. But of course, we don't get taught how to make change. And so I think a lot of nerdy people, when they first learn about this stuff, they're like, oh no, big problem, big, huge problem. I will tell all the people, all the things, and then it will be solved. And I did that for a few years, and I lost a few friends. And I noticed that people sometimes would avoid me coming out of. They would duck into the bathroom unexpectedly when they saw me coming. And so it was clear that explaining the evidence does not actually equal behavioral change. Next slide. And I was lucky that I joined the Canadian Association of Physicians for the Environment, next slide, and met a really capable environmental campaigner named Gideon Foreman. And he said, next slide, you need a target. What's your change-making target? And so I was like, Gideon, we don't need a target. We just need to tell the people the things and solve climate change. He's like, no, Courtney, you need a target. And eventually I came to terms with the fact he was absolutely right. Next slide. So we've done a fair job of trying to explore this challenge of getting data into the real world. Next slide. So really, I look at this as a spectrum. It starts with data, then comes policy that you derive from the data. Next slide. And then you need to try to figure out how to get that into being in the real world. Next slide. Next slide. And there's lots of different ways of doing this. You can do this as part of an NGO, you can do this as a community group, but I've really found it helpful to start looking at this as targeted change making. So you pick a target either on a micro, meso, or macro level. We picked coal power in Canada for the large part, and what that allowed us to do was tell stories, narratives that move the heart to generate emotions that allow people to care and to get off the sofa. And so we talked a lot about keeping kids out of the emergency department with asthma when we were doing these campaigns, and it really worked. We managed to get coal phased out in the province of Ontario, and also a commitment in Alberta, and then nationally, and that helped Canada co-found the Powering Past Coal Alliance. So we've worked on most of the co-benefits. Next slide. Of course, ensuring children women and girls have access to the family planning that they tell us that they want, and education is a really key thing. I've worked on some projects that have helped with that. Next slide. Decreasing greenhouse gas emissions at the same time as health is always the best way to go. Next slide. Next slide. And of course, anytime we decrease air pollution, we can tell stories that talk about keeping people out of the emergency department with things like cancer, stroke, heart disease, etc. And those we find are really, really persuasive. Next slide. So this is some of this is Cape current President Joe Vipond, Catherine McKenna at the National Coal Phase-Out announcement. Next slide. Next slide. We've worked on active transport. Dr. Eric Notebart there as a emergency physician remapped the streets in Montreal, mapped out where the most injuries were happening, and presented an alternative map to the mayor of Montreal, and she accepted it. So ended up with an initiative to essentially double the number of bike lanes, and then they did the same project in other places in Quebec and are now doing it in Vancouver, British Columbia. Next slide. Next slide. And as we went, we realized that there are different ways to create change, and I was really inspired by a general practitioner from Canada who ran her first time in politics, and she managed to become Minister of Health. And she did something transformative. We were making our new national food guide, which, as you know, is a fundamental piece of national public policy. She put her sharp elbows up and she said that Health Canada was not going to have any closed-door meetings with industry during the development of this policy. And industry hated it. They yelled, they cried, they went to the media, they tried to circumvent her by going to other ministries, but she held firm. And what this slide is Brent Loken of the Eat Lancet Commission showing Catherine McKenna's chief of staff what the Eat Lancet Commission was about to publish at COP a few years ago. And I had already shown him Health Canada's new food guide, which had just come out, and they were realizing they were exactly the same. So because Dr. Philpott had made sure that there was an evidence-based policy process, we got an evidence-based product that looks pretty much the exact same as the Eat Lancet Commission. So you can see that exerting influence at that level matters. And so, next slide. These are the two plates, pretty much the same. Next slide. And I started thinking about what that meant for fossil fuel policy. And there are some scholars in Canada who have taken a look at influence and shown that at pre-pandemic, our government officials were meeting with fossil fuel executives 5 times for every 1 time they met with an NGO worker. And so, when you think about what we know about pharmaceutical influence and doctor prescription habits, I don't think it's any surprise that we have some of the highest fossil fuel subsidies in the world. Next slide. Next slide. And so that started to worry me. Next slide. And I was thinking about Dr. Philpott. These are our fossil fuel subsidies. Depending on how you calculate it, definitely $2 billion in direct subsidies, $18 billion in external financing, and then if you count the social and economic costs, more like $63 billion in externalities. Next slide, which nobody was talking about. And so I started thinking, okay, so we've done personal change making. Next slide. We've done change making at the institutional level. Next slide. We've done change making externally to try to influence factors at our government level. But there's no getting around the fact that the people who sit in those buildings and the parliaments control budgets and set policy that influences the entire country. And so, next slide. And all of that creates feedback loops, of course, that then change our ability to create change at the micro level and the meso level as well. Next slide. And so I was approached at the last COP to ask if I wanted to run to be the leader of one of the political parties in Canada. And I'm not even going to say which one. You could Google it if you want, but I really want to keep this nonpartisan. And I said, no, I'm like way too busy. I'm doing all these things. I was approached a few times. Next slide. And then I went to see Hamilton. Actually, sorry, go back one. And I was sitting right before the pandemic started in Hamilton, watching these people at this moment in American history find their courage and do something really scary. And I had the thought drop into my head out of absolutely nowhere that I should run to be the leader of this political party. And it was one of those thoughts you have that you have a deep certainty all of a sudden, and it was super inconvenient. I really had a lot of other things to do. I have 2 small children. I was married to the medical director. But I thought, okay, well, I should probably do this. So just back up that slide one time. Oh, other way. So in any case, my first pearl is be careful what art you consume. We talk about telling stories that move the heart. It's true. It happened to me. It could happen to you. So be careful what art you consume. My next pearl is that running for office is terrifying. Like, I have never been so scared as right before that campaign launched, because you're outing yourself as a member of a political party. All of a sudden, you're trying to sell yourself as a product. I felt nauseous, like I haven't felt maybe since I wrote my licensing exam. And something that really helped was so many of my colleagues were so explicitly supportive. So I received messages of support from many, many people in this room. Nick Watts actually spent like about 20 minutes before this launch, just like basically insulting me over WhatsApp. And that like calmed me down enough. It made me laugh that I could give the press conference without like vomiting, which is what I felt like I was going to do. So if someone that you think would be good runs for office, support them as much as you can right off the bat with your time, with your treasure. Fundraising really matters. And just with that collegial support to say, hey, we will love you no matter what, because you feel very, very vulnerable. Next slide. And something I really learned really quickly was that the minute you are in that position, the budgetary numbers matter a lot. So I had spent a lot of time and made a lot of policy briefs that got to a recommendation, but I hadn't spent a lot of time costing them out. And I felt I ended up on a sort of 2-month crash course in economics. I was deep into the primary literature on ecological economics. I'm a thorough person. We'll love that. Next slide. We need to start talking about this more so that more of us can use that interface and really negotiate those halls. So I'm going to hand over to Will now, because what you need to do then is get somebody to actually organize stuff and do the work. And if you're lucky, you have an engineer who at the time was living on a houseboat during a pandemic. So we basically ran this off of a houseboat and my deck.
I had a 3 megabyte per second internet connection on the houseboat. So at COP25, I said to Courtney, you should run for is it too close? So at COP25, I said to Courtney, you should run for political office. She said, no, I'm too busy. And then in February, she called me after watching Hamilton, being like, I think I'm going to do this. I'm like, yeah, I know. You're going to do this. And then I offered to help initially on managing that campaign, and I was kind of looking for a campaign manager the whole time, but then we got to the election night, and I guess I had been the campaign manager the whole time. So I had to figure out a lot of stuff on my own. I learned a bunch of tools. Click, please. Hootsuite, really great tool to plan social media when there's a lot going on. Click. Calendly, she was really busy and we needed to kind of like distribute the tasks and make everything a bit more efficient. So that was a great tool too. Click. WordPress, I learned WordPress on the fly, and I'm pretty sure everybody can do this too. Click. Nation Builder. This is what Alexandria Ocasio-Cortez won her campaign with, and I thought, we should use this too. I think it was a really useful tool. Next slide. I don't think we could have done this without Google Suite, the Google Suite. And I say this because I think it's such an innovative and collaborative platform. We were hosting webinars, and we were on slide 1, but she was editing slide 2. This is how she, it's great to work with an emergency doctor because everything is at the really urgent. Next slide. Slack was really great to communicate with all the volunteers, bring everybody together, and kind of delegate, let people, at some point I was the bottleneck because there was too much on me, but volunteers were able to communicate with one another. And this is like a national campaign with folks from Vancouver to the Maritimes, so that really helped. Next slide. DeepL. This is the best translation tool I found. I strongly recommend it. You can hit Control-C twice, and then it translates it and it's great. Next slide. Call Hub, we had about 60, maybe 70 volunteers do phone calls to members of the political party, and Call Hub was like super key into removing the admin work and making it run really fast. Next slide. The Adobe suite was also super key, so InDesign, Illustrator for all social media to look a little bit more professional. Next slide. Art of Wear, I really like that website to do drop orders for campaign swag. There's actual evidence that, like high school bags or university backpacks with a logo is kind of tacky, but also makes people feel part of a group. And that website is great because you could just order to different people across the country, and I really like that. Next slide. Flat Icon for just great graphics. Quickly, next slide. A thing we learned a lot. Also, we worked with a professional. What's her title?
Social media guru, let's say.
Guru, yeah. And we learned how to A/B test. So put out 2 different messages to a smaller part of your audience. Figure out which one gets the most click, and then put all your money on the one that gets the most click. It's really like a strategic game at this point. Next slide. And back to you now.
Yeah, sure. So we learned a lot of interesting things. So it turns out that in Canada, at least during campaigns for these kinds of leadership races, the media are supposed to give each candidate equal coverage, with exceptions. And so what the generic, of the, if there were 100 articles about the campaign, probably 50% were like this and 50% were like this. So 50% were a generic description of the campaign. Top quarter, photo of the top fundraiser. Next paragraph about the top fundraiser. Next paragraph without a photo about the second top fundraiser. The rest of it was about everybody else. Fair? 50%? Yeah. And the rest of it were articles representing accusations that something unfair or bad had happened. That was it. There was one of our candidates who was a very, very experienced politician and had very, very good local media contacts in his community, managed to get a positive story about a costed poverty reduction plan out. That was the only story of the campaign of that nature. Next slide. And, you know, over the course of time, we did a 65-page evidence-based platform that many people in this room helped to edit on a blinded basis. At one point, there were at least 5, like, internationally well-known scholars in the Google document at the same time, all editing. Like, this thing is solid because of a lot of great teamwork. No media, nobody cared. Published three commentaries in Lancet journals over the course of the campaign that were actually quite relevant to what I was trying to do, because they were about change making, they were about ecological grief. One was the oath for the Anthropocene, which I think is really important in terms of getting people involved. Media did not care. Next slide. And why, right? Why? I spent a lot of time trying to figure this out. And so there were these rules for equal coverage, would apparently only apply to good behavior. And then really this fundamental problem with the media where there's essentially just far too few journalists, not enough money in conventional media. And so the ones that are left are trying to do the job of, you know, many, many people. And so then it's just easiest for them to use fundraising as a proxy variable to predict success. And just the reason that's a problem is that if you're not then the top fundraiser right off the bat, you miss out on a positive feedback cycle. So basically, if you're top right off the bat, you get all the coverage, get your photo, oh, more exposure, more fundraising, and that's basically what happened in the campaign. The person who had the most money the first time it was reported, they ended up winning. Next slide. And so we just wanted to show some of the things we did. This is a change-making school.
I think we're going to need the sound on this one,
okay,
if that's possible.
There's no sound? Okay. Well, what it basically was we made, I think it was, how many webinars did we do? 12 or something? These are the top people in Canada. I had prior relationships with a lot of people, and they were willing to come on as nonpartisan experts, and I really appreciated that because it was scary for a lot of them. They were academics, they were NGO leaders, scary for them to even step into that space, but because they trusted me, they were willing to sort of skirt that border a little bit, and it made a huge difference, and it contributed to the conversation. So by the time we finalized our platform, I 100% knew that we were, kind of right on track. And we also, as part of that, for each one, we invited one of the other candidates on, totally trying to set them up to do well. We would put them in the one that best matched their area of expertise, really trying to generate collegiality within the leadership group. Because, I've been part of CAPE for over a decade now, and I know that you take an entire team of wonderful, smart people to make change at a national level, and I felt that, if I was going to win this thing, I wanted to have a great team. And so we were doing that. We were trying to build that as part of the campaign school. Next slide. And so these are some of the main pillars of our platform. So shift vision, next slide. Shift power, next slide. Shift money, so everything was under one of those. Next slide. And something I learned, sort of related to the last point, was that evidence-informed costed policy is really important, but when your team tells you repeatedly to stop working on the policy document and start fundraising, you should listen to them. It's really hard. If you've grown up in a, I really want to dot my I's and cross my T's academic culture, it is so hard to let something like that go and then make phone calls.
Yeah, that's my biggest regret, letting you really nerd out in this rabbit hole of Canadian policies. I think it was a really well-developed platform that really helped us a lot. But at some point, I think we should have shifted earlier to fundraising because, without money, you don't go really far.
I mean, just because I was emailing people who authored primary literature in ecological economics, is no reason to think that I was doing this in too detailed a manner. Next slide. So this is the budget. I'll let you talk about the budget.
Yeah, so, money is really important in a political campaign because, well, there's the entrance fee, which was about $35,000, I believe. We also had our fundraiser and also a strategic thinker person, which cost us quite a bit of money. But, logo design, travel, accommodation, mailing, mailouts, paper mailouts were also really important because we had, a younger at heart demographic and younger demographic on social media. We kind of needed to hit all our bases. And it was really tricky to know how much to spend and when to spend it, because initially we were not fundraising a lot. But then the last 2 weeks, 3 weeks, we were fundraising $13,000-$15,000 per week. So if I had known that, I think I would have spent more money initially. I would have fronted more money initially on a paper mail out, which was extremely successful, but still cost something like $30,000 to paper mail all the members. So it was a bit tricky. Next slide. Money and time are the most precious resources. So time, it was hard time that was the most precious resource, because it was spent a lot on the platform, but also every phone call that you did to individual members was way more likely to be lucrative. And yes, money at the beginning was kind of short, but then at the end, you don't want to overspend, because then you're left with campaign debt, which is extremely depressing to deal with. Yeah, and you invested quite a lot of money also in this campaign, and I wasn't paid, you weren't paid, and you spent a lot on that.
Yeah, and I didn't realize that a lot of people ended up with campaign debt. Like, I thought that was a thing that didn't happen, and which is why we eventually didn't end up sending a mail out to every member. We only sent them to half, I think. We probably should have sent it to everybody, because there are quite a few older members of this party, and they weren't accessing our social media campaigns. But I was trying to predict. I didn't want to end up in debt. I was like, well, what are you going to do? But apparently it's normal to have a fundraiser afterwards. So really, reason to be ambitious as you're doing it, and just try to do the best. So that was something that we learned.
And in Canada, every Canadian can donate a maximum of $1,625, and any political candidate can invest up to $25,000 in the campaign. So it wasn't like in the U.S. where money is easier to get. We had fundraising offers from the U.S. that we had to turn down. So I was like, oh, sorry.
Yeah, that was
Next
bad.
slide.
Yeah, so you really have to keep your eye on the bottom line. And a friend of mine who's a politician told me this, and he ended up being completely right. Like, the metrics of evaluation, they're not evidence. I mean, think of all the politicians who won who are not evidence-based, right? It's not your metric of evaluation, and you don't get the job if you don't succeed on these metrics. And so you really have to try to figure out how you're going to balance all of your efforts in order to maintain your integrity and also still win, because otherwise you're not going to be in that job making the laws, right? Next slide. Start early. This is something, had we come right out of the gates, we could have been that first fundraiser and then had that positive feedback loop. It was the pandemic. This was actually not an option for me as an Emerge doc. I'm married to a pediatrician at the time, but it's something I would do next time. Next slide.
Oh, yeah. So I had so much hate mail. Why are you sending paper mail outs? How about using trees? You're sending too many emails, too much social media. Like, everybody had something to say. And at some point you just got to okay, they probably just care a lot about this campaign. So thank you for your feedback. And yeah, whatever you my dad says, if you don't do anything, nothing happens. And it's really, yeah. So I think I would take this criticism less personal, and just kind of, yeah, because we also had a lot of people call and say, oh, we should work on Courtney's communication style. I was like, okay.
And my lipstick. And my hair. Yep. Entire essays were written about my lipstick color. And my hair. You had to talk to people on the phone about my hair.
Yeah, there was this woman this person who emailed a significant email and suggested Birds Bees number 44 lipstick color, and I was like, okay, this is...
Yeah, but I think that's a fact of life for female candidates, and it was super awkward, creating the image, the sort of image of me. That was awkward. We had an entire day of is her hair too long? Are there too many wrinkles? Not enough wrinkles? Seriously, when you are creating a public character of yourself, you really have to park your ego and realize that this is a representation of me that is my public narrative character. And yeah, it was super, super awkward though. Next slide. Am I going crackling in and out or no?
No, you're good.
Okay. Volunteers are your most valuable asset, but can certainly be time consuming to manage.
I spent a lot of time on the phone with volunteers, which felt like 90 minutes at a time on the phone with a volunteer who was kind of telling me a little bit about the campaign and a little bit about their life. But sometimes you just got to listen in and do the dishes at the same time and really appreciate the time that they give in the campaign, because some of these volunteers went and did
We have people working like full time for
600
free
phone
for a while.
calls.
Yep.
Yeah, so they invest a lot of hours.
Yeah. Next slide.
Yeah, I think that I learned how to do that. So volunteering people, Ed Maybach, who I saw earlier today, hello. He's expert volunteer, and I think this is a skill that you absolutely need to develop and be comfortable with. And if people don't do it, then it's fine. But this is how things happen because people are not really likely to take on tasks for themselves.
And they probably don't know what to do either. Next slide. Yeah, delegate and volunteer. Next slide.
Ladder of engagement is really important. So starting with a small ask that develops into a bigger ask, a bigger ask, a bigger ask, and there's a lot of platforms that can help you like keep track of who signed up for the pledge, who sent their image, and who pledged to donate, who donated, who voted for you. So I think it's really important to develop that ladder of engagement and make a clear path of where you're going to send your supporters once they've committed to one step at a time.
And ideally, I think to do that before you launch. We were in such a rush that we didn't really have this developed when we launched. And I think our biggest surge of energy was right at the beginning, and we probably lost some people right then. Next slide. Next slide.
Oh yeah, hopefully that video is going to work.
Yeah, can you play the video? Apparently we can't have sound in our
sorry
videos.
about that. So this is my BugNet headquarters in Moose Island in Wood Buffalo National Park. It's a lot of work, so it has to be fun somehow. The other video was a video of Courtney on the deck and working on the campaign. So it becomes just over like it was probably 60 hours a week.
Oh yeah, for sure.
But it was fun.
Yeah. Next slide. Yeah, all sorts of weird things like ring lights. Do you have a ring light? Do you know where they are? Do you know what they're for? They're helpful. It's so that you don't end up having to like move all the lamps in your hotel room, not to have weird shadows on your face. He came to my house with one day. I was like, what is this? What am I now, a YouTube star? Like, this is strange. But like actually helpful, legitimately helpful. Get yourself a ring light. And yeah, a little iPhone tripod can really help a lot if you're making these little videos. Just getting sort of the basic kit that works can be really helpful. Next slide. Keeping an eye on your bucket. Like this is a moment where so many people are burning out. And although we talk a lot about that in medicine, I've been to so many talks about burnout in physicians recently. I moved into politics and it turned out that everybody in politics was burnt out and didn't know it. They like didn't know that was a thing. And so the way I think about this, and I would address this right off the bat with my team next time. We didn't talk about this. This would be something we would talk about on the first day. We would check in all the time because there's a lot of different ways that you can input energy into your bucket with a campaign. You know, a sense of purpose, collegiality, love, patience, humor, people who help you learn how to do stuff. But lots of stuff also leaves your bucket. There's so much uncertainty, huge financial worries. You're like, am I still a doctor? Am I still a like advocate? Am I a like politician now? I don't understand. So like you're a change in your sense of yourself, which is quite disquieting. Lots of inefficiencies. We didn't have bereavement on my campaign, but it was in the middle of COVID, and so people were grieving. And what I really find is that this is a big humans getting along challenge fundamentally. And humans need energy in their bucket in order to get along. And so proactively encouraging people to sleep, encouraging them to eat, to take care of themselves, to get some exercise, to go for a run, it results in better work, less conflict that in the end saves time. I am way past the point in my life when I'm encouraging people to do all-nighters on my behalf. And I think we really need to be doing that, particularly right now, knowing that everybody has gone through so much over the last couple of years. Next slide. Yeah, this is hard work, so make it fun. Next slide. And when we look at vaccine equity, so, you know, since then, I ended up coming third. So not bad for a rookie. Yeah, thanks. We beat a really experienced politician who's like super well known in Canada. So everybody in Canada is like, you did really well. Like I had to be, I'm like, wow, we didn't suck, but not bad for a campaign run. Like the other two candidates were in major cities. We were like literally on a houseboat and a deck. So, you know, not bad. But let's look at what's happened since. So, you know, vaccine equity, this conference, there were risks to its occurrence as a result of vaccine equity. And that's because high-income countries weren't delivering what was needed to show solidarity with lower and middle-income countries, right? So how do we solve that? Next slide. I used to think that I needed to go to a different country to impact health in another part of the world, I now believe that political involvement is the new humanitarian mission, because it's the only way we're going to be able to decolonize global health, decolonize planetary health, shift power, shift money, and shift our vision and make that come true. So even though this is terrifying, even though it was difficult, I learned a ton. I met so many amazing people, and I sort of, having dipped my toe in, feel like I come back to this space with new skills and insight that I can contribute. So if any of you ever decide to run for politics, I believe, just like humanitarian missions, you need a financial buffer, you need sort of an emotional buffer, your family needs to be ready. So that means that there are seasons for a humanitarian mission. Sometimes it's right to go away with MSF, sometimes it's not. There are seasons for a political mission. But I do believe that this is extremely important, and if we really want to see the change that the world needs in order that everybody can thrive, we need more people, good people exactly like you to go into politics. So if you ever do, I will support you with my time, my treasure, and my talent, and just get in touch with me, and I'll be happy to have a phone call and just tell you what I know. And that's it.
So the next slide, it's really important we have the sound. So maybe we'll take 2 questions from the audience while we figure out our sound business. And then we'll be back with our concluding video. Does that work? Great. Yes.
First of all, I'd like to say a huge thank you. That was really brilliant. And particularly thank you for... Can you hear me? Yeah. Particularly thank you for all of those amazing tips on how to galvanize interest. The thing that I want to ask you is, you were running for power as a lawmaker. I don't know which political party for, but my feeling is that democracy seems to be more controlled by the executive rather than the parliament nowadays. So do you think it's enough to be a lawmaker?
I think sometimes people ask me what to do, and I say we need good people in every single position. And so I think everybody has different skills, they have different abilities, they have different risk balance. And so I think we need people in both places. Certainly, the effect in Canada that real champions, like someone like Catherine McKenna has had on environmental policy, or Jane Philpott has had on health policy, has essentially proven to me that really you can. And from what I understand from the people I spoke with, like multiple people from Health Canada in like dark bars in Ottawa about the food guide when they weren't supposed to talk to me, and they were like, it never would have happened without Jane. And so, I think we need excellent people everywhere, and sometimes it's going to be the right thing for somebody to do to go into politics, and sometimes it will be more to be a part of the Secretariat. Yeah.
Sorry, I don't know who was next.
I'm taking advantage of space. Congratulations, Courtney. It was always very inspiring. I've been working with you in the last months and years now, and we're so inspired. I'm Nicole DePaula, founder of the Women Leaders for Planetary Health. So I'm very interested in what's your advice? We need more women in politics, but as you know, and you experience yourself, there's a different image. Or what's your advice to encourage more women in politics?
I think solidarity is super, super important. Like, the money was a thing, but it was really the fear of being outed from my community that was the scariest thing. Like, I was worried that I was going to step out of this space and into this space, and everybody was going to treat me differently and nobody was going to talk to me again. And that's just the way humans are, right? Like, we care about people. We like to be part of the group. That was my single biggest fear, really, if I'm honest. And so solidarity, like people, Nick, I told them about how you contacted me on WhatsApp and basically insulted me and made me laugh for 20 minutes when I was about to vomit before I launched my campaign. That made such a difference. I was truly terrified. And so I had a lot of people really proactively reaching out. And so probably us, a subset of Women for Planetary Health, like political Women for Planetary Health, to create that solidarity, best practices, it changes social norms. And can provide tools to increase success. And so I think that for me, that's the single biggest thing. I think Sue had a question?
Are you going to stand again?
I've had a lot of people ask me that. Not right now. I have an 8-year-old, and she has forbidden me from running for politics again until she's 12. It was 14, so it's coming down. But the reality is that like this takes up all of your evenings. So because that's your kind of job at the time, but everybody else has a job. So if you want to access them, you have to do it in the evening on the weekend. So all of a sudden, all your family time is gone. And, you know, we barely had a family dinner. We barely went to the beach that summer. And it hurt my heart a fair bit. And so I think I'll wait till my kids are older. But yeah, it's tempting though, because it's such a moment of crisis that we do want to see good people there, but I don't think so. Yeah, at some point I will, but not right now. Because Vivi's bossy.
Hi there. Thank you so much for that. And it sounds like you ran such a great campaign. What I'm really intrigued about is how you can have people running and parties running where it's so much about aiming to reduce inequality, to have a clean, healthy planet, to support everybody in the community, up against other political parties where it's clear it's much more about supporting big business and maintaining the status quo, but the population generally has often voted for the second party. And I just wonder what you think that's about. Is it about personality or campaigning or their media persona? Just to hear your thoughts would be really interesting.
Well, it was interesting because the most conservative party in Canada was having a leadership race sort of simultaneously, and their fundraising totals were what, 3 or 4 times ours or more? So I would say money. Money buys you way better graphics. It buys you way better videos. It buys you way more like social media spend. So you're just getting in front of people more often. There was a really high correlation between the number of contacts the campaign had with somebody and what they did. And so even though you felt like you were pestering people, in a way, actually, that's still to your advantage. So it's more power. They have power and money, so it's a bit hard to get out from that cycle to achieve more power and money. I think really like the key things there are humor. Humor, we found, was one of those things that could really leapfrog you into a different place. So we need to look for stories that are playful, that really motivate people in a positive way. I think that's probably our best pathway to switching some of those power dynamics.
And the thing about pestering people too, I think, you know, I was really uncomfortable sending a lot of emails to people because you feel like you're going to be, you know, identified as spam, but this is kind of how it works. And compared to other campaigns, we haven't sent a lot of emails that, you know, Courtney, you were really thorough on making sure it was a great message that we were sending. And initially we wanted to, it's very difficult to gauge, but yeah, you kind of feel like you're annoying people, but the squeaky wheel gets the grease.
Courtney, thank you so much for your work and your presentation. I think your point about conflicting or dirtying your clinical life with your political life was really interesting. Could you tell me how that affected your clinical practice, if it did, and how you personally squared with the possibility of confusing or tainting your clinical image with your political one?
Yeah, I was very scared about that. I got some really good advice. So I actually had a call with Jane Philpott before I started to ask if she thought I should do it. And she said something that everybody says. She said, "I think you would be really good at it. As a member of the world, I hope you do it. As your friend and someone who cares about you, I hope you don't." I heard that from 95% of people I asked for advice. But what she then said, because I asked her that, because she transferred back into sort of civilian life super well. She's the head, I think, of Queen's University's medical school now, like just boom, boom. And I asked her how she did it, and she said that she acted like a doctor the whole time. So she said, as long as you maintain the same professional standards when you're in this space as you would in your advocacy or political or clinical spaces, people will accept you back. That was one of the reasons it was actually so important to me to do a really quality evidence-based platform. So that was partly behind some of this like extreme frustration of Will's. But yeah, that's it. I think you just have to comport yourself in a professional, collegial manner all the time. But again, that makes it really tough to get media. Because honestly, the people who were willing to throw another candidate under the bus were on national television pretty consistently immediately after. So you're not having dinner with your kids, you're working your tail off, you're not getting any media. I can very much see how people eventually get tired of it and just start playing dirty. Like there's essentially zero inherent incentive, at least in the Canadian environment, to doing things the way you would like to see things done in the world.
I think, though, you have done a really good job at keeping that professionalism. You know, I think you've had, 5 CBC interviews so far this
Oh
week.
yeah, like I
So-
have transitioned back well, and I think it's because like I'm proud of everything we did. We kept the platform up on my website under a like planetary health and politics. Like we're nonpartisan now, but we're proud of this work. I think it stands, on its own merits. And so yeah, I've had no trouble transitioning back.
So there is less than 10 minutes left. I think I'm going to try to MacGyver something with my laptop and the microphone to show you the video that we did, because I think it was a really great one. I saw one question here and one question there. We'll ask the 2 questions and then we'll...
I think Nick has a question too.
Thank you so much. The two of you are fantastic, and even if you didn't win, your story is so inspiring, so thank you for that. So I was going to ask a very similar question to that, as in terms of how do you keep your integrity through all of this? So to me, the most scary part of running for office would not be the long hours, or it would be rather how to keep your integrity when you do need to go and speak to funders, and you need to fundraise. And does that at some point feel like you need to compromise in some way or another? And is it viable, or how do we make it viable for a 100% progressive values-based campaign to eventually be able to win?
Yeah, I mean, I don't sleep when I compromise myself. And so I knew that I actually, when I was 7 years old, named my conscience Hilda. And by the end of it, my entire campaign knew that. They're like, Hilda won't like that, it's not good. And so there's no point. Like for me, there's no point in doing that, because then Hilda gets mad, I can't sleep, and I do a crappy job. And so it's just really not an option for me. I think really, as a woman, I think often we feel like we have to be 120% as good as a man in order to achieve a given position. I think that if you want to run in a completely authentic, positive campaign, you probably have to be 120% as good as somebody willing to run a negative campaign in order to achieve the same effect. That's sort of my like your graphics have to be better, your storytelling has to be better, your humor, you have to be funnier. That's okay. Like to me, that's the only viable path, and I'm willing to get better.
Okay, we're going to try something here. I'm not sure it's going to work. We can't figure out the video here, but we'll bear with me for a sec, please.
I want to talk a little bit about you. You're an ER doctor. You are an advocate for protecting...
This is getting some pretty bad feedback.
Yeah. No, it won't play up there. Why? Just one sec.
Maybe next question. What's your question, Nick?
Hello? Whoa, Jesus. Hi.
I can't hear it, actually.
Oh, really? Because I can hear myself incredibly loudly. You've sort of covered this in a few different ways, but maybe more directly. You are the most outwardly positive person I know. Why are you hopeful? What makes you optimistic? What makes you hopeful?
You all make me hopeful. Last COP, we were, if you ever went to look for the WHO Pavilion, did anyone do that last COP? Did you find it? It was like this teensy tiny little stand down a dank hallway with 3 pamphlets in it and nobody in attendance, right? Yep. Now we're at this giant, beautiful thing. There have been gorgeous presentations continuously. We're really, in Canada, CAPE now has a provincial chapter in every province. And these are smart people who learn fast. We had some MD mothers get worried about climate change last year, and they were like, we want to do a petition. And I'm like, okay, cool. Next thing I know, a month later, they were holding a press conference at Queen's Park, which is the Ontario legislature, and they had national coverage. This is their very first attempt ever at advocacy. And so, we're part of, the most evidence-based, ethics-driven profession. We are responsible for 10% of global world product in terms of the purchasing of health systems, as you well know. We have the ability to not only influence profound change within healthcare, but externally as well. What Ed Maybach is always telling us in terms of trusted messengers. And so we haven't even begun to really scale and manifest the power that we have the potential to do. And I'm starting to see it. Like, we used to be here, and now we're here, right? So next year, it's going to be different. It's going to be at a different scale the year after that as well. And that's what gives me hope. You give me hope, Nick. Look Look what you're doing. There's a like gorgeous ambulance out in the parking lot. Symbol of hope. You know, you've hit your targets. You've got 140 employees. Gives me a lot of hope.
Thanks for your work, Nick. Okay, one more try. I think this might work.
I want to talk a little bit about you. You're a busy ER doctor. You
Can you
are
hear it?
a fierce advocate for protecting the planet against
That's
climate
good.
change, and you're a busy wife and mother. Why go into politics now?
That's the former president of the
As the
Canadian
head
Medical
of the
Association.
advocacy subcommittee of the World Health Organization's Civil Society Working Group on Climate Change and Health, I helped to launch a letter calling on G20 leaders
This
to
is how you
target
can
a low-carbon
bring your work in this space into that space.
coronavirus crisis that was signed by organizations representing 40 million healthcare professionals worldwide. We're melting in the north. It's about 2.5 degrees Celsius warmer than it was in the 1950s where I live. Drought decreases access to water. Heat waves make it tough to cope and to work, can lead to heat stress, heat stroke. The coronavirus crisis is the biggest wake-up call we've ever had that we need to pay deep attention to the intersection of humanity and the rest of the natural world if we want to have healthy bodies and healthy economies. The pandemic has made very clear that politics is a determinant of health. From what I see, humans need a lot of love right now. We're scared, we're mourning, we've been disrupted. La bonne nouvelle, c'est que nous avons une opportunité de le reconstruire et d'en faire un monde meilleur. Mes parents se sont rencontrés ici, sur le territoire du chef Draghis, territoire traditionnel des Dénés Yellowknives et terre traditionnelle des Métis du Slave Nord. Ma belle-maman a développé un cancer alors que j'étais dans le début de ma vingtaine. Cette urgence de vivre a changé ma vie. I was soon resuscitating children with Médecins Sans Frontières. The first time a child died under my care, I wanted to disappear through the crust of the earth. I said to myself that when I got back to Canada, I would do everything I could to prevent further similar deaths.
Joining us now to talk more about this study is climate change expert Dr. Courtney Howard.
It turned out that that meant working on climate change.
The way you're approaching the issues of health and climate and how the Green Party positions itself is really important.
Her message is the message we all need to put our trusted voices behind.
We need to manage COVID and climate at the same time. We need to change the way we target our overall economy so we have the North Star of a well-being-based economy to guide us. We're going to support that by stabilizing our ecological foundation and keeping people safe with a guaranteed basic income. We're going to build the world together that you want your kids to inherit. People will come out and vote for that. Action feels better than anxiety. I don't worry anymore. I just do the work. Through research, policy, and advocacy, I've helped to ignite an international planetary health movement. The future won't look like the past, but it can be vibrant if we focus on clean air, clean water, good food, each other, and peace. Join me for a healthy future. I don't know what to do right now.
I still get goosebumps about this video. I think it was such a great job by, what was his name?
Keith.
Keith.
Yeah, so you can see how much like it matters. It takes a long time to do something like that, but it really, really matters to represent yourself well. And what we really found in the A/B testing was when we put something funny like that B at the end, it got shared way more. And so worth it to try to find those moments. Anyway, are we out of time here? We're probably out of time.
We're getting really close. We have 3 minutes left. One last question, sir.
Thank you. Thank you very much for your presentation. My name is Tafara, and I'm from Zimbabwe. And in 2018, I ran for local government. And my budget, I had $51, exactly.
Well done.
And I got 78 votes out of a ward of 4,000 people. So for the first time, at least people voted for me, apart from my parents and myself. So yeah, and I ran as an independent, and I was focusing on the environment, waste management in particular, because that's one of the major issues that we face. And linking up with health, we have cholera and typhoid diarrheal outbreaks, and AMR is real, antimicrobial resistance, and it's one of the major issues. And people were like, why are you running? Why are you doing that? And they didn't understand when I spoke about AMR, I spoke about the link with waste management, climate change now. So I feel inspired.
Oh, good.
And I don't know if I'm going to run,
There are seasons. It doesn't have to be right now.
Yeah, but then obviously I would like to run. I feel inspired, and I wish we could actually have more of our sisters running, have more young people running, because coming from the African Zimbabwean perspective, we do need the change. We do need to push for this narrative, this political narrative. So thank you. I feel inspired, and hope you can assist. Like, really, we need these kind of talks in Africa. Thank you.
Sure. I'm happy to give talks. And if anybody's interested in looking at the campaign, if you go to my website, it's drcourtneyhoward.ca. All the political stuff is on the far right-hand side. And we basically just created a time capsule of all of it. So you can just go click and look around and see what you think. And let me know if it's helpful. And let's keep talking about this, because I really do think that if we want to mount the kind of powerful response that we clearly need right now, we need to engage in this space and support one another and welcome one another back as we lick our wounds and tell our stories and learn from one another. So thank you so much for coming, and I look forward to working with you on this over the years and playing with you some more at the rest of COP. Thank you. Thank you to my wonderful Will.
Thank you, Courtney. It was the most fun gig I've ever done to work with, although I wasn't paid.
I gave you lots of wine.
Yeah, that's true. Well, let me know if you want to run for office. I'd be happy to support.
Okay, awesome. Yeah, good. You see, good friends. You make good friends. All right. Thank you,
Thank you for
everybody.
coming.
Thanks.
Hi, can people? Oh, yeah, people can hear me. Can everyone hear me? Okay, so we're going to start, but it's like quite a different style session. So hopefully nobody minds that. It's a Friday afternoon. Everyone's been. Oh, someone, did you turn it off? Oh, you can still hear me. Oh, fine. It's a Friday afternoon. Everyone's been, sitting down all day. And it's also Friday midway through COP. And a lot of the time that can feel like a space that doesn't have necessarily that much hope. So what we're going to do today is we're going to talk about, well, we're not going to talk about anything because you don't need to hear our opinions. So we're going to talk about climate change and health under the SDGs in the context of hope and imagination. Right, so like especially on Youth Day, and lots of us are young people. Well, I'm 23, which I think makes us young. And one of the kind of key defining features, I think, of being youth in inverted commas is the ability and the audacity to imagine a world that is so much better than the one we have today. It's to imagine a world where we've not only tackled the climate crisis, but we've tackled all the economic, social, and other injustices that underlie the climate crisis. And in order to make the change that we need to see to actually tackle the climate crisis, all of us need to have radical hope, right? Because the tasks that we need to get to where we need to be to with climate are huge, they're scary, but they're also a massive opportunity for us to do so much better and to live in such a more hopeful, caring society. So basically what we're going to do today is a little workshop with everyone here. It will be going on for roughly an hour, but you can leave and join as much as you want, because there's going to be a couple of different sections. And yeah, it's going to be quite interactive, moving around a little bit. Got some art supplies, which you will see what they are for later. But we're going to start with a quick go round, and just asking people. We'll give you a couple of minutes to think about it, so you're not totally taken aback. And talk about what has brought you hope, whether you've been here just for today or a week, or you've been in the climate movement for 10 years and you've totally lost any hope. What brings you hope? And just thought it'd be nice to share all of that before we get into as a bit of a warm up before we get into the actual exercises. And I can start. So what brings me hope is I literally just ran here from the Fridays for Future March and Strike, which is happening outside in Glasgow. There's 10,000 people there, including loads and loads of kids, and it's absolutely stunning, and it's so beautiful, and it's all people who are fighting so hard for a better world. And every time I see the little kids, I cry. There was a little kid going what do we want? Climate justice. Oh, it was so cute. So that's definitely what brings me hope. And this is Mark. I'm Rhiannon. I'm from the International Federation of Medical Student Associations, and I'll pass on to Mark.
Hello everybody, my name's Mark, I'm a medical student from the UK, also a member of the International Federation of Medical Students Association. I think something that has really brought me hope, the Fridays for Future March was incredible, but to follow on from what Rhiannon said, I think something that young people have, while we may lack experience, we have an endless supply of ambition, and we have, I think, such a vision. It's been amazing to connect with other young people here after such a virtual year. And I feel really happy and honored to be a part of the health community, which I feel has also got such a big ambition for the world. So I think that is something that has really given me hope over the last week. And it's been an honor to be among you, and I really look forward to discussing with you here today. I'll pass on to Leah.
Hi, I'm Leonie. I'm also from the International Federation of Medical Students Association. I'm a medical student in Berlin, in Germany. And yes, I'm happy to be here with you and to talk about hope and imagine a better future. What gives me hope is also I had the same thought, going out and seeing all these colorful and variety of people that are so active. And also there was one action, I think it was 2 days ago, where the Women and Gender constituency just read out names of voices that are not here. So that gave me hope also to see okay, it's not only us, it's not only these 10,000 people here or 10,000 on the street, it's even more, it's all over the place. Yeah, so I think we just need to connect and do it together. I'm gonna hand over. If you don't feel like speaking, you can just hand it over to someone else. Yeah, so if you just put your hand up, we'll hot desk people and run around. There you go.
Since I know I'm leaving early, I'll get my guilt out of the way. So I'm Tracy Morse, I'm the University of Strathclyde, just down the road from here. But I head up the Center for Sustainable Development. But I spent the last 20 years living in Malawi and working very much at the interface with communities on public health and environmental health. And what gives me hope is hearing people finally talking about how we need to listen to communities and how they have solutions, and finally listening to the voices of low and middle income countries.
Okay, great. So, yes. Sorry, just do you want to say your name, what you do, what brings you hope? Go for it.
My name is Dorit Adler. I'm from Israel, from the Israeli Forum for Sustainable Nutrition. Has to correlation to any of the SDGs. And what brings me hope is you. The young that march there will not succeed if you will not. And you know, like the IPCC is the evidence-based for climate, you should make the correlation with health, which is not here in the agenda. And I will share with you another thing which is not in the agenda, is food system. 3 weeks ago, there was the Food System Summit led by the United Nations General Secretary, because they realized that without transformation of food systems, we cannot reach the targets of the SDGs 2030. So I think you are marching in, and I think we should also bring in the nutritionists in the world, because they are not there yet. You are here, it's amazing. Thank you.
Awesome, thank you. Okay, ready?
I'll save you a walk. My name is Colin from Ireland, and I'm in our health ministry, and was part of the climate negotiations for the last 5 years. What gives me hope is if I look at what page in the newspaper we're on while we're here. It's page 1 now. 5 years ago it was maybe 6 or 7, depending on the football results. So that gives me hope. And I suppose looking at the range of people who are participating, as we touched on, it's bigger and bigger and broader and broader. So you need that. Thank you.
I agree with all the answers you all just spoke up, and what I want to add is what really brings me hope is that we all connect from different perspectives on the same topic. Like I met philosophy students, I met engineers, I met like our community, the healthcare community, and we all connect and we all have the same ambition, and that really interconnectedness is going to bring us very far, I think.
Awesome. Yeah, do you want to get it?
Hi everyone, my name is Iris. I am also with the International Federation of Medical Students Associations, and I'm a medical student, doctor, just graduated, but from the Netherlands. And what gives me hope is that tomorrow during the climate march, there will be over 200 health professionals in the Netherlands marching as well. And I know that across the world, health professionals are marching. And if I compare that back to COP25, where we did not have a health pavilion and not so much was going on about health, I think there's so much progress that has been made when it comes to climate change and health, and it's really hopeful.
Hello everyone, my name is Tafara. I'm from Zimbabwe, and what gives me hope? I don't know how I got here. I don't know how I got into the environmental space, but I got a legal background, and one day after church, I'm religious, a friend was like, oh, climate change. And I was like, yeah, I think I've seen it on the news. He's like, dude, come on. And then here I am, and I'm liking it, and would like to contribute my all to making, creating a better world for the present and future generations. Thank you.
Thank you. My name is David Imbago. I am the chair of the Adolescence and Youth Constituency of PMNCH, hosted by WHO. What gives me hope is to finally see a health pavilion at COP. I think that is fantastic advancing for health and climate change, and I do hope that this pavilion gets bigger next year, because we will still need most likely climate change and health discussions, not because it gets worse. But yeah, just want to say that. Thanks.
Yeah, my name is Peter. I'm representing the International Society of Doctors for the Environment, but more important, maybe even the International Network on Children's Health, Environment and Safety. And children are my hope. Looking at all the words that children have been spoken, and you see that in the corridor there, and I think there are so many examples of where children are really aware about the environment they're living in, and they really are my hope, and yeah, that's important.
Hi everybody, my name is Minan. I was a medical student 30 years ago,
I think that health is all the outcome of all SDGs, right? Everything poor will lead to poor health. Everything almost lead to poor health. So now health is the subjects that finally become a very important subject in SDG. So that's, I think, the hope here. Thank you.
Thank you. Hello. So I'm Marie-Fanny Racco from the University of East Anglia in Norwich, UK. And what brings me hope is a number of things. Of course, that there is an increased awareness of climate change impacts, better understanding from the public. We're listening to scientists. And in terms of the research that I do, so I'm involved as a lead author in the IPCC AR6 on impact. And really what brings me hope there is that health is really at the forefront when we talk about impact, but especially when we look at the connection of health with our environment, with the ecosystem. So what we name under biodiversity, the functioning of the ecosystem, both terrestrial and marine. So an enhanced consideration of their interaction and how much we're dependent on them and how much we need to protect those so nature basically and work together. And I think this is fantastic. And yeah, so I'll
Amazing. That was so incredible. Yeah, does anyone else? Oh, yeah, we got loads. You guys are amazing.
Hi everyone, I'm Gokul and I'm from India, and like I'm a member of Yango here, and I'm also a medical student, like the most underrepresented, like an Ayurvedic medical student from India. Like Ayurveda is not so represented internationally but it has a more potential for climate action. So I am here, and like my hope is like this is my first COP, so I can't lose hope from the first COP itself.
Yeah, I'm Kurt. I've been working for almost 20 years for the World Health Organization, now a professor in global public health. And what gives me hope are my students. They're all very kind of open-minded, interested in climate change, very active, very oriented towards action. But it's also on the higher levels that gives me hope. I come out of the Al Gore presentation at 12 o'clock, and health's really figured out prominently there too. And but I must also admit it has been a roller coaster for me. I've also seen many disappointments when I sit in the negotiation rooms and see the policy tactics just for delaying. And also, I must admit, health is not yet there where it should be. I mean, we should not be kind of telling us on how important health is. It's not really on the agenda. And I think this is also needs to be mentioned. But I'm positive with my students, but also Al Gore.
Hi everyone, my name is Nadia Nanayausu. I'm coming from Ghana. Well, this is my first COP and this is my first time coming to this booth. For me, what's hopeful for me or what gives me hope is everyone that's here, because if we didn't come here, it means there's no change that's going to happen. I'm very thankful for everyone who's here. We're at the change and we're at the hope. Each and every one of us, we want to take action, and that's the main reason why we're here. So I'm actually thankful. I'm looking forward to learn a lot. My work is in the area of communications and digital literacy. So coming here, I want to learn how to use digital tools to actually educate women and girls on how to actually connect climate change and also health. So thank you.
Hello everyone, my name is Indira Kadel. I am from Nepal. So can you hear me? Okay, thank you. Most of the persons here are from medical science, but I am from the climate service provider there. So for me, hope is that the understanding of the climate system is increasing, and I'm happy that the health is already here. So I think we can do better by integration of the climate informations in health. Thank you.
Hi folks, I'm Mark. I'm a lecturer at the University of West of Scotland and I'm here with MedAct. What gave me hope was on Monday morning there was an open letter called Real Zero, Real Solutions, which was signed by 700 organisations, which was challenging the greenwash of net zero. So and that really gave me hope that people were actually being much more realistic about the threat of climate change and where the answers lie. And I've just come out of a session of where this amazing woman was talking about targets you should set yourself, and I thought, what should give me hope? And I thought, if I could outlive capitalism, that is that would be that's my target. So thanks for having. Cheers.
So hi everyone, my name's Scott Oram, and I work for, speaking of capitalism, a big biopharmaceutical corporation, but tough to follow here. But it really gives me hope that we're making this connection between health and nature, and not just, what in particular gives me hope is mental health, making that connection between you need nature to be healthy physically and mentally as well, so I'm really hopeful for that.
Welcome to everyone who has joined us since we started. Just for context, we were just talking about the climate crisis and the need to tackle it as also a crisis of hope and imagination, and the need to have the audacity to imagine a better world. There are also seats at the front if anyone wants to come and chill. But yeah, so it's just going to be an interactive, chilled out workshop, not too formal. Has anybody who's just arrived or not spoken yet want to share what gives them hope? Otherwise, or we can go on to the drawing. Okay, do you want to take? Yeah. Okay, thanks everyone. That was really, really beautiful, and I think really important to remind ourselves of what gives us hope and why we're here. And between all of us, how many years and how many hours of experience and emotions and dedication there are in this room. So yeah, thank you so much for sharing all your stories of hope. And now we're going to get on to a fun exercise, and we'll stop sitting down as well.
Yeah. Okay. Yeah. Thank you everyone for that. I think we've been here for 5 days, but it feels like 5 months. So that was really nice to kind of take a step back and have a think about what gives us hope. So thank you for doing that. Now this next part is fully interactive. This is fully on all of you. So thank you for engaging so well so far. And this is when we actually get into the SDG part of this. So what we want to do now is have a think in the future, and to take this vision we have of hope and look at how that will actually look in 10, 15 years time once we've achieved all of the SDGs. Because like we said, we're young people, we're ambitious, we're going to achieve the SDGs. What is that actually going to look like? So what we would love for everyone to do is to get into pairs or threes, and we're going to ask you to just have a discussion and draw your street. What will your future community look like once we've achieved the SDGs and we're in a healthy world? So we want this to be, get up on your feet, walk around, meet 2, 3 people you've never met before, and we want you to take some paper, we have some pens, and just get creative and just have a think about how your future community and your future street is going to look like in 10, 15 years. So please, let's go.
Hello? Oh, okay, amazing. Sorry for probably scaring everyone. Leah?
Is it on? Hello, hello. Okay, everybody. We've been seeing drawing you like really nicely. So I think all of us would be interested in like all of your ideas. So we would suggest that each group could maybe like bring their picture to the stage and show the rest of the team here what they did. And as I told you before, like we would be interested in your ideas about the process also, like how, like maybe one idea, how do we get there? Like what could be a step from here to there? So is there a group that wants to start? Is there any group that wants to start? Yes? Okay. You want to come to the stage? Stage is yours. I can hold it for you.
Ah, lovely. Hi, everyone. Okay. They can hear me, right?
Yeah, it's working.
Hi, everyone. I hope you can hear me. Lovely. So, what I envision for the world in the next few years is a green world full of technology and human beings being the change makers. So, in order to get there, this is what I see. So, I see a greenhouse with humans using technology, green software technology, and I also envision so much greens around. There's more afforestation, so there are more trees, and there are also roads that are less emitting carbon. So we get the roads and the cars there. We have some green life, so maybe biodiversity. So we have more birds. So these are the birds. And there's technology that connects us to one another. So more of technology. So that's our technology here. And more of greenhouse stuff. And we also see individuals being the change makers. So we have nurses, we have individuals, we have every one of us here. And how we're going to do this is by starting the change, by using green practices, teaching the community. So it's like a whole place of us. And then I also see clean water. So we see clean water and a recycling hub. So where we actually recycle stuff, reuse stuff, and also teach the community. So this is my future, and this is what I envision. You want to add something?
No, that was perfect.
All right, then. Thank you, guys.
Which group wants to be next? We need you on stage. Maybe you guys. Yes.
Well, we can pass the mic on. But yeah, we really thought of this health concept in a very holistic manner, like underlying with the planetary and One Health concept. And yeah, we're living in a city, not in a village, but this is how it looks like. There's little, because maybe not even, no individual motorized transport, a lot of space for public transport and bicycles. What is important is there's a lot of green and blue spaces for mental health important. Yes, our buildings are very energy efficient for warming and for cooling. And of course, they are with solar panels. We have a lot of biodiversity with bees and other things. And yeah, I'm going to pass on the mic.
No, that was already very well said. It's really, the idea is to regain space in the cities for a kind of social life and interaction with people. And the only way to regain that space is probably if we take it away from the cars and from the individual transport. Can you still hear me? Okay. And yeah, this is, I think it needs also little autonomous sections. So this is why the house has its own solar energy production. And I think everything else was nicely said. Anybody wants to add something?
I like to, hello, can you hear me? Yeah, okay. I'd like to add that have some more medical clinics around the city. Like we should promote more clinical activities around the world, and have more like clinics around the city. Like there are more cities out there who are like more places in the world there is no health doesn't reach, so we need that as well. And also like self-developing, like a consciousness for everyone. Like everyone should have some knowledge about health. Yeah, for that as well.
Thank you so much. Which group is next?
I can explain some bits, and then I think everyone will have a go in the group. So it's a big teamwork. So we've drawn our horizon first around here, and then the horizon moved a little bit further. But so we envisage quite a long pass. So of course we have healthy rivers, healthy oceans. We need a good water security. We need to have clean water access. So we really need to protect this. A strong aspect. I'll describe the biodiversity part, and then I think my friends or colleagues here will explain more about home.
River is very clean because
So
fish
yeah,
here.
you have a good diversity, good supply. So we have a lot of diversities in the forest. Although this is very important for carbon uptake, we want to make sure that this is respected. We change also our. So we have a cow in memory. It's a statue that he kindly drew. And in order to, so here we have houses. We build some that are quite low ground, and we have some roof gardens. We also have bigger houses because we have also more people on the planet, so we need to host all of these people. Again, some roof garden, solar panel in order to make them self-sufficient, very well insulated. We need to work a lot on this, and we also thought to focus a lot on the transport, so transportation with electric car, potentially self-sustained, energy-sustained car with a solar panel on their roof, very fast trains for long distance connections, and of course more bicycling paths and walking paths. And in order having fields for growing our crops, but respecting the environment again. So building. So this is the way we get there. Building what we call hotspot of biodiversity. So not just one super giant field, but also allowing for the ecosystem to have some places where it can grow and still be diverse, and where we don't intrude so much as human into the ecosystem part, and this is how we get to pandemics and so on. I think I'll pass on the microphone. Maybe you want to explain some more.
Yeah. Yeah. For electricity, we have in the water water-driven hydro electricity without blocking. The buildings are made from sustainable materials, so we have only a very small, tiny waste box there, because there's no plastic anymore, and it's only just some leftovers of keeping households. Do we also have to say how we get here? One thing I think what could be, because we have chosen obviously for a small community, because I think we have to get rid of big cities where you have to commute for 2 hours to get to your job or to get anything. I think that's the big waste of energy anyway. So this is what we are going to build next year. This is a model village, and then everybody in the community can sign on and live there for half a year. And then the children can freely play in the woods and in the fields and in the streets. So it will be really amazing if nobody would like to live here. So after half a year, they have to leave for the other group that comes in to learn from how to live in a village. But the people that are leaving will so much be enticed by having such villages that very quickly there will be a large project in every country to build these kind of model villages. So that would be one step of showing how we can live like a model village. And then I think that would be really helpful in making the next steps in the SDGs. The long train, the distance is there, but maybe we don't, and we said it is a fast train, but maybe we don't need a fast train anymore if everything is nearby. I think all the amenities, all the stuff that we need, I think there's one city that has said now, oh yeah, Paris, I think. Paris says 15 minutes or something, you need to be able to reach anything that you need. So that's also true for this village. And then maybe we can bring it even down from 15 minutes, which will be difficult because we didn't include, you didn't give us enough time, but because there's also the social and the cultural aspects. So that's where we have to think a little bit about how to make sure that also there will be some kind of cultural and social cohesion in this city. So that needs a little bit more designing. Excuse me.
I want to add something. There's no clinic or no hospital here because everybody live here is very healthy. We don't need medical doctors.
Yeah, and the last thing I would like to add is that we started drawing the trees and all the nature, so that's why we're also going to get there. Like with every choice, we start with thinking about nature and our health. So that we put that on the number one. I think that's our.
Thank you so much. I think we have one last group left. You want to come to the stage?
Okay. Let's each do a page. Yeah? Or
I don't think we have a lot to cover.
okay.
I can hold one. Are they connected? No?
Yeah. Hi everyone. This is our place. We have a number of different things going on. We have a vibrant civil society that's protesting, and also some homegrown vegetables, and a school that has a lot of girls in it, and people with different gender identities, and also people with different abilities. And we also have these symbols of different gender identities to show we have a vibrant sexual and reproductive rights and health. And I'm going to let some other people explain some other stuff.
Yeah, we also included different means of transportation. So there are bicycles over there. We didn't include like buses or trains, but yeah, we should definitely include something like that. There are a lot of trees everywhere. What else? We did this market. It's like a community market here. It's like, yeah, like something small in the community level. What else? People are healthy, so they are happy as well. Yeah, Julia.
Thanks, David. I think we added also the importance of biodiversity. So you can see here our birds are very different from each other, and probably due to my bad drawing skills more than anything. And then on the tree there, there's also the importance of having bugs, and then also birds and other animals. There's other animals down here. So yeah, the importance about planetary health and a One Health approach. And maybe the only thing is energy. Do you want to talk about that?
Yeah, sure. So we've got some wind turbines somewhere over on the right-hand side over there. And we also got some rivers down here for access to clean water, and we put the water closet in as well, the toilet, because we thought that was important. And then there was access to sharing and reusing in the markets, and we also had a minimal recycling, but it was still there. I think that was everything. Our ideal world.
One more thing, there was people living in teepee, and we all were living together in a community, and we are all shiny and radiant, all healthy.
Amazing. Well, thank you so much, everyone, for showing us all of your really wonderful drawings. And yeah, I think we won't keep you any longer. You just have 15 minutes of your life back. But yeah, just to say a really, really big thank you for engaging. We were a little bit nervous about doing this format. We weren't sure if people were going to like it. So yeah, thank you so much. And you know, if you keep envisioning a better world and like having the energy and the passion to fight for it, then I think you'll always be young. So yeah.
So what is your way towards this future? What are your suggestions? Because you made us think about it. But what?
Oh, well, you've put on the spot here now. Quick, give us 15 minutes. We'll come up with something. I think I'm going to cop out and just echo that all of what we said together, having this community and just speaking to our neighbors about finding these solutions is so amazing, because something we felt is going to so many of these events, you don't even know the people you're sat next to. So it's just having that first step and making those connections with people to think of what the steps are going to be to a better future. I would say that together we are so much stronger than if we're divided. So having these kind of events, having these networks of people internationally, that's how we're going to find the solutions, and that's how we're going to share. And so I'm just delighted that we've all done that here today. And more of this, and we will get there. We will get to the SDGs.
Nice. My one would be completely redesign our economic system, which is a small task. But yeah, I would build an economic system that explicitly acknowledged and valued, not necessarily monetarily, and incorporated the health of people and the health of planet into how we actually run our societies. So that would be mine.
Yeah, I agree completely. I think in order to get there, I would plant like small seeds everywhere. Like if you have a revolution, then what comes after, right? So plant small seeds and give them water all the time. Like build a model village and then do something else, divest money, like plant little seeds, and don't forget to give water to it.
Thank you very, very, very much for organizing this. It's been like a huge breath of fresh air and hopes. But I mean, concretely, I also wanted to say that in some of our countries, we have the luck of being a democratic country, so we can vote. And I just want to say that I'm also very hopeful, because in the future there will be many more of you who will have the right to vote, and seeing how you see the future is very, very encouraging. I mean, it motivates me a lot to continue the work that I do, and yeah, your voice, it will come more and more, and yeah, you will make it. Basically, it will come, but it's on our responsibilities as well, and you're voting already to. Yeah, to get started and do the actions for the future. So thank you very much for this.
Thank you very much, because you make me feel young again. We didn't play this kind of game before. And then we physician, we medical professional, we care for the personal health or patient's health, but we need to end at the planetary health. So from personal health to planetary health. So that's we think we have to do. Okay, thank you.
Thank you. Okay.
Well, yeah, that's it, everyone. So yeah, have a lovely Friday. Yeah, there's a global. Huh? Oh yeah, if anybody wants to join a protest, we are organising a die-in of health professionals at 5 o'clock by the cloakroom to advocate for no new fossil fuels, and we'll be there with Parents for Future at 5. You don't have to lie on the floor with us. If you feel so inclined, you're very welcome to. But yeah, we'll be there, and yeah, have a great Friday. Have a great rest of your COP. Bye.
Good evening to everyone present here in Glasgow.
Thank you.
And hello to everyone else watching this live stream
Can you hear me?
across different
Yes, I
time
can
zones
hear you.
around the world.
We're going to have fun. My name is Usman. I'm from the UK. What's your name?
Ani. Ani, yeah. I'm from
Are you a
Washington,
doctor?
D.C. No. I'm from India. But
You're from India. Oh, Dr. Kumar.
yeah, I had a non-profit that runs the Chino Catalyst. Yeah.
Thank you for explaining.
Good evening to everyone present here in Glasgow.
We can't hear you. Am I meant to press something?
I can actually hear her.
Which one have you pressed?
Zero.
Oh, I'm on 0.
Sorry? Are we on? Okay, but we can't hear anything. Can you hear me? Okay. Good evening to everyone present here in Glasgow, and hello to everyone else watching this live stream from across different time zones around the world. A warm welcome to today's panel discussion, co-hosted by the World Health Organization and the World Resources Institute. Today, we will be discussing the triple win scenario, catalyzing action for clean air, health, and climate. Every year, air pollution kills an estimated 7 million people worldwide. The World Health Organization data shows that 99% of the global pollution breathes in air that exceeds the WHO guideline limits. Those living in low and middle income countries are exposed to the highest pollution levels. Breathing in polluted air is linked to higher rates of pneumonia, chronic obstructive pulmonary disease, stroke, ischemic heart disease, lung cancer, and other health impacts. Many air pollutants also contribute to climate change. Cleaning up our air will have both health and climate gains. To discuss this further, we have on the panel today Dr. Maria Neera, Director, Department of Public Health and Environment, World Health Organization, Mr. Anidas Gupta, President and CEO, World Resources Institute, Ms. Rosamund Adu Debra, co-founder, Ella Roberta Family Foundation, and Mr. Olumude Idowu, Youth Climate Champion from Nigeria. And I'm your moderator for today, Disha Shetty, a science journalist from India covering the scope for Health Policy Watch. I'm going to direct my first question to Dr. Neera, who for many years has been highlighting the multiple wins of clean air. Under her tenure, WHO's air quality guidelines have been updated for the first time since 2005 to much stricter limits on exposure to air pollutants. Dr. Neera, could you give us a deeper insight into the triple win solution?
Thank you. Thank you very much, and welcome everyone to this important discussion. I think it's nothing more basic than breathing. I mean, we are all doing it right now, and nothing more important. Try to stop breathing, you will see how important it is. And what is very unfair is that at the moment we are talking, 90% of the world population, as you refer, is breathing an air that not only is not protecting your health, but is putting you at risk. And you mentioned that you are from India, so I'm sure you know what I'm talking about when we said how bad it can be when you need to breathe an air that is certainly not at the quality that WHO would like to see. Some years ago, more than 15 years ago, we did the first WHO guidelines on air quality. And many countries responded that saying those standards are very tough, very ambitious, it will be very difficult to put this in place. Well, fortunately, it's true, it was difficult, but come on, it was about protecting health and putting in place measures that it will go with a normal development for any society. So years later, we saw that even if our guidelines, our recommendations were restrictive, they were not restrictive enough to protect people's health. And even at lower levels, people were exposing their lungs, exposing their brains, exposing their cardiovascular system to something that was representing a major public health issue. So with all the scientific evidence accumulated, we did the new guidelines, looking at 6 pollutants, and reducing those levels of exposure. Here we are. Again, very ambitious. Some countries will complain about this will be very difficult to put in place. But here we are at COP. COP means tackling the causes of climate change. And here is the triple win. If you tackle the causes of climate change, if you are serious about implementing the famous Paris Treaty, if you are serious about reducing emissions, one of the first and most immediate benefits you will obtain is the reduction of air pollution. This air pollution that is killing millions every year. And of course, the benefit will be for the health of the children, but for the health of the adults, for the health of our health system as well, which is paying a fortune now to correct the structural failure that we are creating ourselves. So a very simple message for all of us. Be serious. Stop burning fossil fuels, because the result of that combustion of fossil fuels, it goes into the air, and that toxic air, it goes to my lungs, your lungs, the lungs of your children, and that is causing already a horrible damage to our health. So don't talk about the planet as something very distant and very abstract. Think about, when you think about the planet, think about a couple of little pink lungs that are beautiful, and they are working permanently because we need 10,000 liters of water every day. Oh, sorry, water not. We need some water as well, but not 10,000 liters. But we need 10,000 liters of air every day. And we want this air to be clean. Otherwise, how can I breathe something to bring it into my body, something that will affect my health? This is unacceptable. And I have a lot of sympathy for people breathing this toxic air every day. I think this has to stop. And the winning, here we are talking about triple winning, but we can enumerate so many benefits. I commit myself to reach even 100 winners. I am not describing it now, don't worry. Over.
Thank you so much. My next question is to Mr. Dasgupta, who is a leader in the areas of sustainable cities, urban design, and poverty alleviation. While dealing with the issue of air pollution, the lack of equity stands out. In a city like Delhi, for instance, the polluted air affects those with means to stay indoors differently than those living in slums or with jobs that require them to be outside. How can our response to air pollution take the issue of equity into account?
So thanks for all of you for being here. End of a long day, I'm sure. I actually grew up in Delhi, so I don't know if that's why you asked me that question, but I am viscerally able to talk about how it is to live in a city which till recently was listed as one of the most polluted cities in the world. I don't think it is today, but it was very recently was. The thing is, you told me when I was waiting for you with you before this, that this is the first time that there is a health pavilion at COP. Now that is a shocking thing for the following reason, because almost all the things we need to do, almost all the things to reduce climate emissions are also very connected with causes our bodies to inhale polluted air. They're very correlated. They're not exactly 100%. So if you do all the things you want to do for climate, you will make it better air quality for people. And my understanding, and I thought that's what you were saying, politically, it's much better to do things for people if you want to win votes than to do for the climate. It's people understand clean air. So it is a surprise. So I hope from now on, there's always a WHO thing in COP, right? To your question of equity, air quality incidence, though it's a one climate, is disproportionate for the poor for the following reason. Because poor people actually have to work outside much more. Poor people also live in communities that sometimes poorer communities are next to polluting things like power plants because they're cheaper land. All these things add up to a very disproportionate. In the United States, for example, poorer communities take school buses, kids take school buses more than richer kids. the diesel pollution of school buses incidences are actually much higher. So the work that we have done to show the incidence, not just what's in the air, who actually gets affected by air quality, it is the poor, it is the poor people. So what can we do differently, right? This is what the Clean Air Catalyst tries to do in 3 of the cities in Global South, in Indore, in Jakarta, in Addis Ababa. What we're trying to do, air quality is actually a little complicated science. The chemistry of air is complicated. It's not just simple. So to make sure data is accessible to communities, why is it polluted, at what time, pollution changes across days, across years, so that they can take action or they can hold their own governments to take action. So one thing that we're trying to do is to get analysis of air very accessible, because a lot of places we have seen cities take action which is not directly correlated why there was pollution. So that is one step towards getting us data and accessibility to understanding across communities.
Right. Thank you so much for that. My next question is to Miss Adu Debra, who's a champion for the right to breathe clean air. Her daughter Ella Roberta, who died in 2013 from a rare and severe form of asthma, is the first person in the UK to have air pollution listed as a cause of death on her death certificate. Miss Adu Debra, you have fought a legal battle in the UK to recognize air pollution as a contributor to the cause of death. Children are amongst the most vulnerable to the impact of breathing in polluted air. How hard was it for you to get the cause recognized in the court of law?
Extremely difficult, because you literally, Ella had to die and there had to be a post-mortem before we could see what was inside her body. And if you think, she was under 5 hospitals, she was seeing the most senior respiratory consultants, and nobody knew what her triggers were. We knew there was something. And even after the first inquest, the most I was left with is, we've now discovered that her triggers were to do with something in the air. And I was curious. Look, my daughter is a sacrificial lamb in all this. It's something we don't say because it's very uncomfortable. But when I say to medical doctors around the world, she's suffocated in her own mucus. That will get a response from Dr. Niera because she knows what I'm talking about. And it is a real shame. I was listening to what the panel was saying. One of the reasons she wanted to know is why she had become ill so suddenly. And we were very, very fortunate that Stephen Holgate, who is a professor in immunology, he's been talking about air pollution for many years, but nobody was really listening, if I'm really, really honest with you. And I'm really happy and satisfied that finally, due to my daughter's sad death, finally, people are now talking about it. You are right. You know, even when I was sitting at home before I came, I got here on Wednesday, and my frustration the first 2 days, I thought, is anyone going to mention air pollution? And do you know why I said that? 7 million plus, let's be honest, it's not just 7 million plus, die from air pollution. I don't know what the figures are for COVID. When I last checked, it was 5.2. Look at the rush there has been. Do you know what the difference between air pollution and COVID is? COVID can shut down economies and air pollution doesn't. And that's the only reason why. Look at how quickly a vaccine was rushed out. All leaders all across the world got together and found a vaccine. How comes every single year, not just 1 year, more than 7 million die? Where is the urgency? There is a public health crisis. There has been about 70,000 papers. The evidence is there. So my only reason why I think there hasn't been that rush is air pollution does not shut down an economy. What do I mean by that? It means that it affects people through cancer, cardiac arrest, strokes, asthma attacks I've mentioned, dementia, stillbirths, miscarriages, and it's all spread out. So what that means is the economy doesn't shut down, and that's why we are where we are. But its impact is vast, and it's a disgrace that we have to fight for health to be recognized. Look, up until Her Majesty mentioned the word air pollution, seriously, I didn't hear it. And I was really worried. I thought, what is going on over there? It's like it's the elephant in the room. And my message to people, again, is unless you clean up the air, you are never going to resolve climate change. Look, it's linked to acid rain, global warming, biodiversity, human health, I could go on and on and on. And I don't, and I believe we have missed something, basically, because what COVID has showed us, what people care about. They care about their health. People have sacrificed an awful lot. And for me, it was really sad watching people with, being intubated. That was my daughter once. And in the UK, 139,000 have died. And all over the world, people still continue. And shock horror, what have we found out? In areas of high air pollution, yet again, there have been more COVID deaths. This is not a shock to us. And who has suffered the most? The poor again, marginalized communities again. And I have been pushing back in the UK because some people's solution is the poor can be sacrificed. Absolutely not. Their voices deserve to be heard. They're not at this table, let's be honest. Let's hope from now on, health going forward in all COPs is going to be recognized. Do you see? My daughter is not the only one suffering. And I mentioned that to the president of COP this morning. We have sacrificed children all over the world. I get emails from Delhi. People say to me, please don't forget us. Because when you're in the UK, it sounds like you're only talking about the UK. But for today, and Dr. Nira has given me the opportunity to be part of WHO, it's 500,000 children before the age of 5 who are dying due to air pollution. So I hear everybody, I really, really do. And when I talk about the UK, I'm really sorry, but today I get to talk about children everywhere who are dying. The child in Delhi matters to me as much as the child in the UK, as much as the child in China. I was a teacher before I started doing this, so all children matter to me. I don't have any preference. So that's my response to you.
Thank you. Thank you for sharing your thoughts. I'm going to direct my next question to Mr. Idowu, who is also the Communication Director for African Youth Initiative on Climate Change. He focuses on raising awareness with community leaders about the devastating health impacts of air pollution from fossil fuels as a way to help drive climate action. Mr. Idowu, across the developed world, the youth are driving climate action. But in developing countries like yours and mine, the youth also have other socio-economic challenges in their day-to-day life. How much is climate justice a conversation, and is there demand for local and global action among the youth in your country?
Thank you very much. Let me first of all start to say that thank you for the invitation, and I appreciate let me call my dad and my mom. I'm from Nigeria, and I'm speaking on behalf of, let me say, the developing countries. And let me quickly remind us that we are no more a spectator. We are now taking action. So it's high time for us to start looking at that angle. Another thing I want to say is that you talk about data. As a statistician, I can tell you from my country, almost 80 million people. As you know, Nigeria is one of the largest population in Africa. And I'm from the city that is up to 25 million people, that's Lagos. And it shows that when we talk about air pollution and we talk about clean air and issue like that, it's something that is very, very pathetic to hear, because I'm very happy to hear somebody talking about the difference between COVID and air pollution, which is something that, it's the way it comes to us, we, approach it. But we always forget that there's something that is killing more than what we are doing. You can see everybody covering their mouth everywhere. But when you look at the young people, you will know that, like I said, they are no more a spectator. A lot of people have started talking about how can we drive that action? How can we drive conversation that will translate to implementations, not only talking? Because it has come to a stage whereby everybody wants to be on the table. We just don't want to be on the table to talk. We want to be on the table to talk about implementation. So how do we drive that opportunity for us to contribute or complement your efforts to make sure that we have clean air? I also want to talk about we can see a lot of young people. Today is a youth day, and people are talking about they need climate justice, climate action everywhere. But let me remind you that from the developing country, you see a lot of people, there's this conversation about the climate finance, because there's no funding. If there's no, let me call it money, to drive action, then why are we talking about all these issues? Is it health? And I keep telling people that I don't call it climate problem. I call it environmental issues, because there are a lot of issues that when you say climate change, everybody will always think it's only climate they are talking about. But these are environmental problems, and it's something that is killing. My mentor says that if we don't take action, climate change is like a time bomb. When it explodes, nobody escapes. So it's high time for us to start looking at it in that perspective. So developing country, as a young people, we're actually calling for actions. We're calling for not only to talk, but want to be part of your implementations to see that we have clean air. And let me end by saying this. This is a very good compliment for my country, especially where I'm staying in Lagos State. There's what we call the air quality treatment. We have 6 air quality treatments in my state now, which is helping us to actually drive data to understand how much we are polluting. I think it's a stepping forward, but we need more, because I don't know whether you know how much pollution we are contributing to the air, or how we are, and it is always happening in a developing country the more. So it's high time for us to start looking at how we can get involved as young people from the developing country, and how we can also be compete with our other young people out there. Thank you very much.
Thank you so much for your thoughts. I'm going to come back to Dr. Neera. While we've spoken about children and youth, I want to draw attention to another vulnerable section, women. In recent years, emerging evidence suggests air pollution increases the rate of miscarriages, pregnancy complications, and even stillbirth. Dr. Neera, why do we not hear more about the disproportionate impact of polluted air on women's health?
Yeah, this is a very good question, and it is not lack of evidence. Let me start with that, because we are now putting and accumulating. Rosamund was referring to the 70,000 scientific papers that we have now proving that air pollution is having a negative impact on our health. And we know as well that those toxic particles that are in the air as a result of traffic and as a result of the combustion of fossil fuels and industrial processes and many others, when they get to our lungs, they don't stay there. Particularly if they are very small, if it's the PM 2.5, they go and they can go to the bloodstream, and from there go everywhere. But the bad thing as well is they can pass the placenta as well. So imagine what that means. A little fetus that was not even able to breathe by himself or herself, and is already affected because the toxic air that the mom is breathing, the mom that is trying to protect that baby, and is already affecting it because she lives on a place where she's breathing polluted air. So I think it's not lack of scientific evidence. It's probably not even lack of putting all the figures on the table. It's not even the lack of interventions to reduce this problem. It's lack of political willing or blindness, or I don't know how to call it. I'm asking myself every morning, what's happening here? I mean, we have 7 million, a horrible figure. We have scientific evidence proving that a very clear risk factor has been identified. We have, which is even better, evidence that is very positive to tackle the causes of climate change and air pollution, and will produce fantastic health benefits, even economic benefits. Somebody was telling us something very clear. If you accelerate this transition to clean sources of energy, renewable sources of energy, $1 invested on renewable sources of energy will generate 4 jobs, compared with 1 job generated by investing on fossil fuels, and 1 job that in few years will disappear, because obviously, hopefully, one day, sooner or later, the fossil fuels will go to fossils where they should be on a museum, not on our daily lives. So my dream will be one day going to the petrol station and seeing a signal petrol stations, fossil fuels kills, as we are doing for tobacco. It took us more than 50 years to do it for tobacco. We don't have 50 years, no way, and we are certainly not accepting such a period of time. We need to accelerate here. The evidence is too clear, but we need to start to be very clear. Fossil fuels kill us. Fossil fuels affect a young woman who is about to give life, and is putting at risk the life of that child. And if you don't want to take action as a politician, well, you need to have that on your shoulders. But we can put it in positive. We can say, at the contrary, if you take action and you reduce emissions, look at how many lives you are saving. Look at how many babies will be healthier in the future thanks to all the actions that we are taking. As you were referring, this is the first time we are having a health pavilion. This is the first time. I know that it can be symbolic, but it's an important symbol because somehow we are taking over. I mean, this is COP1 for health. Is COP26 for the environment, for negotiations, but for health, for public health, is COP1. Basta. I mean, you know what basta means in Spanish, no? Enough, enough. I mean, we don't have time. We have people dying, and we have a solution. It's not other risk factors that you don't know what to do. HIV/AIDS, for years, we were struggling what to do. We were raising awareness. We didn't know the prevention. We didn't know even the transmission. But here, what is the missing part of this that is stopping us for taking action? Where is the missing information? So nobody can say in few years from now, we didn't know. Nobody will be able to say that. We didn't know. We didn't want to do it, but don't use the thing, we didn't know. We knew and we decided to prolong because they were probably commercial interest or because lack of, strategic view or lack of interest in your population. I don't know. But we knew and we know what is needed to do from now on it. And the health people is losing patience. I think we are much more impatient than the environmentalists. So probably we have a bigger responsibility now, and we need to take over and to start to make sure that there is no one outside that doesn't know that this is affecting the health of the babies, this is affecting and killing a lot of people, and there are no reasons for that. If I were a politician and I try to be thinking like, I will be very happy, as you say, to gain votes. This can be very popular. If you put in place something that will be reducing exposure to air pollution, and somebody like WHO can quantify the health benefits for that, I think it's a fantastic opportunity for me to be vote and gain political support in emerging countries or countries that are struggling a lot with air pollution. I think it's a question of now using the health argument to really have more action on climate change.
Thank you so much. Mr. Dasgupta, much of this work of cleaning up the polluted air will have to happen at the subnational levels, but cities don't have the funding to do so. Here, I'd also like to highlight the ask of developing countries for more climate finance that has repeatedly been unmet. What would be an answer to help cities in developing countries where the air needs cleaning up right now, but the countries are also set to continue growing their emissions for a few more decades?
So I think just building on Doctor here, Maria here, is first thing is we have. I mean, think about, you just heard what causes air pollution, right? We just have to. We are building cities right now in developing countries, not in development, all over the world, that is actually produces outcome that is produces air quality. So, for example, users of cars is increasing in global south. Cars not only make cities inefficient, they're actually one of the biggest causes of air pollution. Not the only cause, there are other causes, they're biggest causes. But if we stick to that, so when people don't use public transport and cities encourage, keep building roads for cars and allow free parking everywhere, that practice, and in India, where you and I are from, there's a huge middle class boom. Everyone is not buying one car or many cars. That itself, that act of creating a mobility that is producing one person or two people to be in a 20 car, whether they should be taking public transport and decarbonizing that. So the way we're building cities, how poor people live in cities, a billion people today in urban areas live in slum-like conditions across the world. So how we build cities matter to the outcome you're talking about. It's not an exogenous problem where air quality is. And So one thing is to focus on this. I would actually say it's not health taking over climate. We at WRI would very much focus as an integrated problem, the health community, the city planning community, transport community, air quality community working together, because that is the long-term solution. And as I said before, I think it's also politically a better solution to provide better health care, better health outcome to citizens. So that's one. The second, you asked about money. So our work shows the health outcome, if you actually quantified it, just for India and China, just take two of the bigger countries here, the health benefit outcome monetized is actually cheaper than the mitigation measure. So if you spend $1 fixing air quality, the outcome for health outcome is actually higher. So that's the second part. So this idea that it's just an expensive thing to do and we shouldn't be doing it, if you do the math properly, that is the question you asked, would they get climate finance? As you heard already from Dr. Maria, that climate finance, this is also, air quality improvements absolutely also a better for climate outcomes. There's very few things you can do from air quality that is not a good. So the climate finance, when it starts flowing, and we're going to have a lot of discussion here how much it is and whether it flow, and whether it flow to local jurisdictions, which is a bigger issue than flowing to country. It is not clear yet that's going to happen, except I was in a meeting the other day with the Green Climate Fund. They said they're giving money to cities, great things. So that money has to flow, but I don't think there is any issues between climate finance versus air quality finance, because the science of climate and air quality demonstrate. We have demonstrations that WHO has demonstrated that these are very important. So I think the buy-in for getting things done locally, providing the power to communities to ask for it, and providing the science, which is what we're trying to do, I think there's an opportunity to solve climate and air quality together.
Right. Thank you so much. So, in my reportage so far on health impacts of environmental issues, finding evidence has always been a challenge. So, I want to direct this question to Ms. Adu Debra. How would you rate the evidence that allows one to challenge the issue in court, and in what way can the scientific community better support this cause?
To find evidence is obviously very hard, but there are lots of things doctors can do. I mean, one of the things the coroner said is much education needs to be had from doctors about air pollution and asthma. And, sputum, this is going to sound really medical. This is going to sound like I'm having a separate conversation with Dr. Neera, who's a medical doctor. But, there are things like taking saline in and spitting it out. You can have a look at the PM 2.5. Look, it's not an easy task. And yes, we can find the evidence, but try and imagine a parent whose child is suffering. We have talked there from a very poor background, having to be dragged to, through the courts. It's not easy. It's much more positive to talk about cleaning up the air. Let's not just go down this wild goose chase of showing, we know already air pollution is affecting. Do you know why? Because I think 300 million people around the world have asthma, and we have linked that to air pollution. So we now don't need to spend our time going to find evidence to go to court. We just need to get on with it and start cleaning up the air now, because children are actually dying. In my country, we have one of the worst. I'm from the UK, although my background is from Ghana. I see my rival who's Nigerian over there. I just had to get that in, by the way. So I don't think we need to spend our time going through the courts to actually prove it. We know now that people are being impacted. So you see, we're going on that goose chase today, money in the wrong direction. We need to get on with cleaning up the air so these children can actually breathe. Because as we speak right now, I know a great doctor in India, Dr. Kumar. He is doing operations on young people who are in their late teens with lung cancer. There is research out there in United Kingdom that shows that if you live near a busy road, you've got 15% more chance, even if you don't smoke, of getting lung cancer. My daughter has proved when you open people up, what you find there, the tiny little particles that are smaller than sand that get into the bloodstream, we know this already. Let's not waste time to find evidence, because even healthy children we know are breathing this in. We need to clean up the damn air instead of going through the court system. That's what we need to do. that focus, taking governments to court, it's a great idea, but I am more interested in young people surviving. Look, 2 minutes, or my own children will say 3 minutes without air, you will die. So that's the actual message. And as we speak right now, there are children all over the world who are on oxygen, who are being nebulized now. That is the evidence we need. So we already know that. And we also know the solutions. So we need to get on with it now.
Absolutely.
Just to interrupt, because it's so fundamental. Imagine that somebody will ask you to demonstrate, to prove, and provide even more scientific evidence that if you drink contaminated water, you will have problems. This is unacceptable. You don't want to do that. We have plenty of evidence about that. So prove me the contrary. Prove me that breathing toxic air is not affecting my health. I think this is what we need to prove, not the other way around. Sorry.
That makes complete sense. Yes, please.
Can I disagree a little bit?
Okay.
Slightly. Both of you are absolutely right. I don't think we need more evidence to prove that bad air is bad for human beings. You're absolutely right. But to take action, because we have limited resources across countries we're talking about, to take action with precision to solve the problem, what causes air pollution is needed. And our experience across countries, that a lot of anecdotal evidence produces bad policy outcome. A better science would be better. So it's
No, we are totally in agreement, definitely. No, the interventions needs to be demonstrated. But the fact that we can postpone action because we are still trying to understand the impact, I mean, it looks logic to me that we have right to clean water and clean air. Now, how we make sure that we have clean air and to reduce air pollution, it will require, as you rightly say, interventions that needs to be proved scientifically that are the most effective, right?
Could I just quickly add that we know around the world different sources of air pollution. So, like I said, Ghana, which I'm very proud of, I come from, we know it's down to cooking. We know lots of places it's fossil fuels. We know it's coal. So the evidence is, that's what I actually meant. The evidence is already there. It's not like we need to go back. We know there are different sources of air pollution all over the world. But we know, look, this whole thing is about money. Let's be honest. That's what we are talking about. Coal, which is from India, we know the impact it is having. Why are teenagers having lung cancer? We already know that. That's what I actually meant. The science is actually there. But I'm just worried what I was talking about is when you mentioned court, the reason why I got a bit worried, it took me 7 years to get where I was. We don't have 7 years again. And, I am calling out the doctors here. They were behind the tobacco. 40, 50 years it took them. We don't have that time. So medical doctors need to put pressure on governments because they take them seriously. So, doctors cycled from London here. It took them a whole week. During a pandemic, they left their hospitals to cycle up here to raise awareness about the health impact. And I want the doctors to, I know they don't like to get involved in politics, but I want them to continue. I'll hand it over to my fellow there.
So my final question to you is that given that those in the developing countries like yours and mine breathe in the most polluted air, what kind of action at COP, at events like these, would you like to see from world leaders that would feel like climate justice?
Okay, thank you very much. But before I go to that question, I think the conversation has been a little not around political will, which I think is high time for our government or the right people that make decisions on our behalf to actually understand that we are all living under the same umbrella. Because the only thing that is different is when they are in their cozy house or cozy room. But when you look at the other people that doesn't really have that kind of opportunity to be on that kind of atmosphere, you will notice that a lot of people are dying. And I will give you an example of my country, and I'm sure you people know a lot about the pollution in the south in my country, where we have the gas flaring. And we also have soot. I don't know whether you know about the soot case. What do you think is happening to children, young people, and the older generation? Because we are all interlinked. And that's why I mentioned that the people that are making decisions on our behalf, they are not part of that kind of community that we are living. So looking at the Niger Delta area, mentioned 7 years that we don't have 7 years again. Let me tell you, almost 30 something years now, we have been talking about ending gas flaring. And we've been, maybe as after 2 years I was born that they have been talking about it. Up to today, we've not even cleared the gas flaring. So calculate how many people that have died from that, from 30 something years ago. And calculate how many people that are going to still die because of our negligence and the political way that is in it. So for me, looking at the atmosphere of the COP, I think a lot of young people are now looking at how can we start looking at sustainable investment in young people. Sustainable investment to make sure that our environment is more conducive for everybody. Because we don't really have much to make a decision, but we can influence those decisions to happen. By the time we start giving them numbers, start giving them a case study of things that is happening, that it can actually affect their own children as well. So they need to start seeing that, okay, fine, these are the actions that we are looking at. And the so-called climate justice that we are asking for now, we don't want to be asking for that every COP. It should stop in this COP so that we know that as time goes on, what we are looking for is how we can now compliment to say thank you for making sure that our air is clean. So it's high time for us not to repeat the same thing we do in every COP we've been going to. So I think for young people, we are trying to look at how you can create more investment. You know, we have what we call investment opportunity. We are not asking you to give all the money in the whole world. We're just looking for that avenue to complement your efforts so that our air will be more cleaner for everybody. Thank you very much.
Thank you so much. So before we close, I want to come back to each one of you for some final thoughts. What conversations would you like to see happen more in the coming years in the public discourse with respect to this topic that would feel like progress to you?
Well, probably no more conversations. I will love to have a graphic telling me how the emissions are going down, and then the health community, we will create in another graphic where we will see how many lives we are saving. That will be the dialogue I will be very happy to have. And of course, keeping in mind that we don't have a lot of years, so something very, very quickly. And before I end, I think we need to pay attention as well to the legislation part that Rosmun is bringing here as well. This will be helping us as well. Maybe things that our conversation has not been able to provoke, maybe the law will be able now to, to push certain measures by law or by fear to legal implications. So I trust legislation as well. We will move all the fronts to make sure that the conversation ends and we start to talk about the good results after the conversation. Thank you.
Thank you. Mr. Dasgupta?
Thank you. I mean, this has been labeled correctly, I think, a nature COP, right? We had a nature day. Tomorrow we're going to have, and about oceans, forests. We've talked about agriculture. All these things require clean air. You cannot have better oceans if the air is polluted. Neither can you have forests. Neither can you have crops. The evidence of how air impacts not just humans, all the systems we depend on. So one thing we would want to see, that clean air is a connective tissue. The second, if you cared about the SDGs, 13 of the 17 are absolutely connected to air quality outcomes. I mean, and finally, it's one atmosphere. We absolutely have to do it together. We can't keep talking about it, as you said. We actually have to work together, get cleaner air. It should be a human right to have clean air.
Thank you.
Well, I'm going to end and say you've taken the words right out of my mouth, that breathing air should become a human right. And ultimately, we hope one day there will be an Heller's law, and that's what it will be. And if governments are really serious about this, the new WHO guidelines, when they all go back to their countries, they come here and make promises. why don't they implement them in their laws? And then I would take them seriously. The guidelines are very clear, and if they're confused, Dr. Nieran and I, we can point them in the right direction where to find them. Then I would take them seriously when it's in every law and when all the countries sign up to clean air being an actual human right. Then there's lots of promises. I looked at the Paris Agreement. Not a lot of that is, people come here, say so much, and they go back and produce so little. So what should be going from, if you want a good conversation with us, the new, not the old ones, not the 2005 ones, the new guidelines, the ones that have taken 16 years to get us there, when you get back to your countries, and can governments remember, they have a duty of care to their own citizens. You're not doing it to please me or anyone, your own people. So put your money where your mouth is. And it's not just to the UK. I know some people would think I'm making a dig. And also monitoring. The coroner was very clear about this, and I've checked the maps. There isn't a lot of monitoring going on in some parts of the world. Some have hardly any. The coroner was very clear. They need to monitor. They need to educate their citizens. They are, in quotes, getting away with murder. If they do not do this, the young people, they are waking up. They're beginning to know my daughter's name. They are not impressed at all. They're going to be demanding more and more. They're not going to go away, by the way. If this is what people think, they're going to get louder and louder. And do you know what? They have every right. Childhood should be about fun. It should be about having a great time, not fighting to breathe. So this matter isn't going to go away, and we don't want long conversations now. Time's up. Time's up.
Thank you.
Okay, thank you very much. I have three messages. One to the developing partners, to government, and the last one. So for developing partners, I think it's high time for us to start to help us to tell the truth to the people of our government. We don't just want you to give them money. Let us know, like you said, put your money where your mouth is. Secondly, for the government, we have a lot of promises. Example, like our nationally determined contribution, that's the NDCs. I see a lot of developing country government committing to this. My country, we have 7 sectors of our NDCs, and I'm looking forward to the implementation. Then the last thing is this: anything for us without us is not for us. Thank you very much.
Thank you so much. So, given that some of our speakers have to rush after this event, we will not be able to take any questions. A special thanks to WHO for hosting us in this event. This is also the first COP, like Dr. Neera has already mentioned, where health is on the official program and in the blue zone. I thank you all for being there at this event and for being a gracious live audience. And a thank you to all those watching this live stream from around the world. It's a wrap from us. Thank you.
Hello, everyone, and welcome to this session in the Health Pavilion at COP26. We'll give folks just a few more moments to jump on, and then we'll kick it off. Okay, again, welcome everyone. My name is Elizabeth Ployce. I'm with the U.S. Agency for International Development, and I'm here to help facilitate this session on heat overlooked populations and maternal and newborn health. And first, thank you to WHO for hosting the Health Pavilion at COP26, and welcome to all of you who are listening in the pavilion and for those of us who are joining from around the globe. And thank you very much to the members of the planning team that helped to organize this event. And this session will actually go for 90 minutes. I'm not sure if that was clear in the program, so hopefully you can stay for the whole thing. So as you know, impacts of climate change are already being felt, and they will only get more severe. We've heard this all week. Those in low resource settings or from marginalized groups will be hit the hardest, and these groups already have poor health outcomes. And we're especially interested in heat. Heat is often called the silent killer. Being a slow onset disaster, it often gets less attention than other extreme weather events such as hurricanes. However, in recent years, especially after record-breaking heat waves in Europe and then India and Pakistan, and just this summer in North America, heat is getting more attention. There are calls to start naming heat waves, just as we do hurricanes, and for governments to declare heat seasons to help raise awareness of the risks of extreme heat. And several cities even have heat officers now. This is all a good start, but there's more we need to do. And today we will hear about what still hasn't gotten sufficient attention, especially the impacts on marginalized populations in low and middle income countries, especially, and the impacts of heat on maternal and newborn health. We'll hear from colleagues around the globe about climate impacts on health with the focus on heat, and also about proposed actions and opportunities to address the situation. I know that many members of our audience, especially USAID folks, are very interested in these opportunities to address the impacts of climate change. Because here in Glasgow, just several days ago, President Biden announced the President's Emergency Plan for Adaptation and Resilience. And then finally, we'll close out this session by hearing from the voices of impacted women themselves, from interviews with women in Jacobabad, Pakistan. But first, I would like to introduce Dr. Veronique Filippi, a researcher with the London School of Tropical Medicine and Hygiene, and she's engaged in a project called Climate, Heat, and Maternal and Neonatal Health in Africa. Over to you. I think you're still on mute.
Thank you very much. I'm going to try to share my slide. I think you can see them. Okay. Okay, so I will start now. What's the impact of heat on maternal and newborn health, and what can be done to reduce it? I'm presenting this topic on behalf of a team of interdisciplinary researchers who are working together with a focus on Africa within the Shamna project. Okay, now I have to learn how to use. Okay, thank you. Temperatures are rising at twice the global rate in Africa, and in many places are already close to the limits of livability. The figure on the right represents the increase in temperature above the present day values. Using a business as usual scenario, the temperature would increase by 6 degrees by the end of the century in Africa. Vulnerable groups such as pregnant women and newborn are especially affected by heat, However, there are major gaps in evidence for maternal and child health, as found in a recent review published in the Lancet Planetary Health. When exposed to extreme heat, there are several processes that may occur which could harm the mother or the fetus, including perhaps most importantly, a reduction in placental blood flow, dehydratations, difficulty in regulating the body temperature, and inflammatory response that may trigger preeclampsia and preterm birth. Evidence is limited, mostly because of ethical reasons, and is mostly from animal studies, and is sometimes contradictory regarding the complex physiological processes that cause heat exposure to harm pregnant women. The impact of heat can lead directly to obstetric and neonatal complications, such as hypertensive disorders of pregnancies and preterm birth, or have an indirect impact on health by disrupting the access or the quality to health services and key component of the health systems, or by leading to malnutrition, infectious disease, or affect the mental health of pregnant mothers and women. There is growing evidence that heat can increase the risk of preterm birth, stillbirth, and low birth weight babies. Congenital abnormalities, malaria, which is a particularly problematic condition during pregnancy, bacterial infections, and hypertensions. Heat also affects the behavior of women and families who are more likely to supplement breastfeeding by giving water to babies, less likely to access antenatal care, and less likely to use bed nets to protect from malaria, as examples. Heat is also an issue for occupational health, with many pregnant women working in the field or in the office in hot conditions with limited protections and providers at risk of making errors and providing less respectful care. A recent systematic review led by my colleague Matthew Shergis has shown a 5% odd increase in preterm birth per 1 degree Celsius temperature increase and a 16% increase in odds of preterm birth during heat wave. Preterm birth is the most important cause of neonatal mortality globally and is linked to developmental problems for surviving children. Out of the 70 studies, it's worth to note that only 7 were from low and middle income settings. We illustrate here how it influences behavior in Burkina Faso. Exclusive breastfeeding is one of the most important interventions to reduce infant mortality. Exclusive breastfeeding requires that no water or aliment is given to a child in the first 6 months of life. In Burkina Faso, where the average temperature is 29 degrees Celsius, there is a very strong perception that the weather is so hot that babies need to drink water. Using a core study, my colleague Sherry Part has demonstrated that for every 1 degree increase in temperature, there is a reduction in the duration of breastfeeding to the child. Climate change has already had an impact on heat-related child mortality in sub-Saharan Africa. China colleagues from the University of Leeds have calculated that the average number of heat-related child deaths for the period of 2005 to 2014 are approximately 120% higher than would have been observed without climate change. This climate penalty will be worse over the coming years. Our ethnographic research in Burkina Faso and Kenya has shown that while policymakers, health providers, and women understand the impact of climate change, and they understand the mortality risk associated with pregnancy and childbirth, they have much less awareness of the impact of heat on maternal and newborn health. They describe, however, how hospitals are inadequately prepared. They speak about women's exhaustion during events, intersecting with malnutrition and health system weaknesses and compromising women's health and well-being during childbirth. And they told us that due to extreme heat, some babies are born underweight and many have blisters on the head or in the mouth, which causes discomfort and difficulties in sleeping and breastfeeding. Possible intervention for maternal newborn health can be grouped into three main categories: behavioral change, health system interventions, and intervention within the built environment. In Shamna, we are piloting behavioral change interventions focusing on daily durations and frequency of breastfeeding and harnessing the role of community and health providers. In conclusion, there is compelling epidemiological evidence that action is required. How to act is much more complicated. There is low awareness of the issues and an unclear package of interventions that are specific to the needs of pregnant women and neonates. Intervention research and implementation science are probably the most important priority, given the emergency of the situation with climate change. But for this, we also need to understand some key epidemiological, behavioral, and physiological pathways. Thank you very much for listening to me. Shamna researchers come from many organizations and are funded under the umbrella of the Belmont Forum. And this map illustrates where we work and show that there are many other places where work should be carried out. Thank you.
Thank you very much. That was a great presentation. I really appreciated how you highlighted the various ways that heat impacts maternal and newborn health, and that it isn't only the very, very extreme temperatures or heat waves that have an impact on maternal and newborn health, but just high temperatures can negatively impact health and change behavior, even when it's not enough to cause death. Thank you very much. And as you mentioned, although there's a need for more research, there is enough that we know now to take action. And so next, we'll hear from a series of additional speakers from public health advocates, scientists, government representatives, to hear what they're seeing in their communities, in the communities they work with, and what actions they have taken, and potential opportunities and tools or information that can be employed. So first, we'll have Dr. Afolabi from the Ministry of Health in Nigeria. Unfortunately, not all of our speakers were able to join us, so we have a few recorded remarks. We could also play those a bit later if it's not working right now. We're also going to be hearing from Yogan Pillay with the Clinton Health Access Initiative in South Africa to talk about some of what they're seeing through their work in the communities that they work with and some opportunities that they've identified for ways to address this. So we'll see if that video is available. And while we're trying to bring that up, I forgot to mention that if you're joining us online, feel free to add questions in the chat box. We will try to answer them in the chat box. We may not have questions for Q&A at the end, but we will do our best to answer what's there. Okay, as we're still working to get those videos coming, maybe we'll go ahead and move to another speaker. We can hear about the work in Senegal that they're doing, how heat is impacting the communities they work with, and a very interesting project that they've undertaken. So I'd like to introduce you to Dr. Ousmane Ndaye, Director of Meteorology, and also Dr. Marie Ndaye, Director of General Public Health. Thank you both for joining us.
Thank you, and hi everybody. Do you hear me well?
Yes, I can hear you.
Okay. Do you have the PowerPoint? Can you load it?
I believe that is coming.
Okay. My name is Dr. Usman Jai, and I work from the National Weather Services. And what we want to present here is a collaboration between us and National Public Health and developing an early warning system on heat waves. Uh, so I'm sorry that my colleague Marie Ngom Njai, she's on travel right now, going to the COP26 in Glasgow. So she was not able to join us. But anyway, I will do the presentation. Next slide, please. Yeah, first, those who don't know Senegal, Senegal is the westmost country of Africa, and most of the population are young, and we have quite 62% of women and 48 of men. And then the background as far as climate is concerned is we already noticed an increase in temperature. And if you look at the records, there is an increase of 1.5 in the past 70 years. And if you look at the actual report of the IPCC, it's very clear that temperature will increase and heat wave also will increase in duration and frequency. And it will be quite everywhere in Africa, as you well guessed it. There is also awareness that extreme event will be more and more prominent, as I said, and as such, it's important for us to put in place a system that will allow people to know when we have those heat waves and to prevent ill-related disease. And also, we noticed that in the record we have a lack of reporting. There is a gap in mortality due to heat wave, and we think as part of this project, as part of this collaboration, we'll try to fill all those gaps and try to develop a early warning system. Go ahead, next slide, please. The project is a pilot project that we try to put in place. So it's based on forecasting week 1 and week 2. It's out forecasting in 2 weeks ahead. And based on those forecasts, we look at if there is a likelihood to have heat wave or not. So the way we work it is NOAA is helping us. We are based on NOAA forecast on week 1, week 2, and then here, using our data, we adjust the forecast because we know always there is a error, there is a bias, as we said in the forecast. We adjust it, and then if we see any signal of heat wave, we will collaborate with the health people and then try to develop an early warning, bulletin. This is happening actually, and we are implementing it and doing it with the direction of the health services. Next, this is an example of a bulletin of heat waves for week 2. For example, 2 weeks ahead, if we see what you have on the left is West Africa. You have the countries in West Africa, and what you have in color is the intensity of heat. The darker the yellowish is going to red is likely to have heat wave and so on and so forth. And you have in the left the forecast in the whole area, and you have on the right the focus on Senegal. So this kind of product that we are putting in is the actual product that we are issuing each time that we see the heat wave forecast. Next slide. So this is the hierarchy of the early warning system, how it goes. So We develop all these tools and methodology to make the forecast at the starting point, ensuring that we are seeing very clearly in the model, climate model, that we have heat wave. When we have it, what I showed earlier, we put it on map to see that where is the heat waves, localize it, and then interpret it with, you know, the health impact risk map, knowing that this is what we have the heat wave, this is what's happening. So we have kind of a combination of that, and we can do an impact-based forecast of early warning system. Then we issue the early warning bulletin with the health community. What we do is in our climate part, we analyze it and say that this is a likelihood to happen, and they see what is the impact in health, and then we have the bulletin and we disseminate it, for the population. Keep going. This is an example of the final bulletin. The first one was the forecast. This is how the bulletin looks like. You can see on the left, this is in Senegal, the country, and the red and the colors show how severe is the heat wave. And after that, the next page, what you will see is what kind of precaution need to be taken in order to avoid the risk related to heat waves. And on the right, you can see now what is the impact-based forecast, meaning that combining those two, heat wave and exposure, you can develop a kind of map into exactly what kind of risk population are exposed to. This is a final bulletin that is co-signed by the two institutions and disseminated. It's called the early warning bulletin. Go ahead. Next slide, please. Now, from there, where we are, we want to go next. First of all, we want to extend this experimental because now you see we just, for given region, and to do more on capacity building to ensure that people understand, how things are made and to go forward in time and to make it something that is really operational. And so what we want to do also is to outreach to the local people. We know that decisions are made at the local scale. So we ensure that local communities are on board. That's why Red Cross, National Red Cross is in board in this forecast. And then the other thing is to ensure that we know that this is a co-production, should be a co-production thing. So we need to get feedback from a population. What do we mean when we issue the forecast and send it? We get feedback from population that send it, how kind of behavior the behavioral change they have, what things they do, what was the impact, and so on and forth. We know that we would adjust, the threshold of the forecast and to do better in the future. And we also have also local doctor or local medical professional in health are involved also in this. And what they will do, they will document in each time that we have a heat wave forecast. They know the threshold, and they know what is the impact, so we know exactly what to expect. We think that training is also an important part of this early warning, ensuring that people understand full well what we are doing, and they know what is the impact on that, and they know what is the climate jargon, and those two communities can work together and develop a better development. Next slide. Thanks very much for that. Thank you.
Thank you very much. That's an excellent example of collaboration between two governments and using the data and technology that's available to address this issue. So I'm sure that as we take a look, we're going to try to go back to those videos. So we'll see if we can hear from Yogan Pillay with Chai on what they are seeing in South Africa and perhaps thinking about how the example from Senegal could potentially apply there. Let me know if it keeps freezing, Kate, and I'll try to show it.
Logan Pillay from the Clinton Health Access Initiative in South Africa, and I'd like to thank the organizers for inviting me to present this evening. We are regrettably
Kate, should I continue with the South Africa example? I apologize, everyone. We are having some technical difficulties.
living in the era of colliding or compounding global epidemics, making the future uncertain for every generation that succeeds us. While this is a scary thought, it should also be an urgent call to action. Climate change and excessive heat is likely to exacerbate the already high maternal and newborn mortality, especially stillbirths, preterm deliveries, as well as delivering low birth weight infants. What's the impact of the spread of communicable diseases and natural disasters? We know that increasing temperature is also associated with increases in the rates of malaria, dengue, and Zika, which are more harmful to pregnant women compared to non-pregnant women, as well as to their fetus. Additionally, droughts and floods decrease food security, which impacts on maternal nutrition. Further, the odds of an under 5 child suffering from a respiratory illness is up to 5 times higher when fossil fuel is used for indoor cooking in a home with poor ventilation. So overall, there are significant vulnerabilities to poor people as well as, and in particular, pregnant women and their newborn. Regrettably, increased heat is already a reality for many, including people living in informal settlements, where the houses are often built of corrugated iron with little or no ventilation. UN Habitat estimates that a staggering 1 billion people live in so-called slums. These people are highly vulnerable to climate change and poor health outcomes that follow. Amongst this number are poor pregnant women who do a variety of outdoor work and the homeless who are continuously exposed to the elements. Let me now move to one country's response, and that is my own country, South Africa. In 2011, the South African government published the National Climate Change Response White Paper, which had a number of goals and objectives, including a focus on heat stress and called for heat health action plans. In 2014, the Ministry of Health published its National Climate Change and Health Adaptation Plan for the period 2014 to 2019. Regrettably, despite this early enthusiasm, little concrete action is yet to be seen to be implemented, either the policy or the plan, due to shifting priorities and, frankly, the lack of capacity. This experience illustrates that policies and plans are necessary, but clearly not sufficient. We need activism to get action where it matters most. So, what's to be done? And I have a list of 7 things that I think we can collectively do. First is to develop government-wide policies that increase awareness of the impact of excessive heat on pregnant women and newborns, as well as strategies to mitigate its impact and support civil society organizations to hold governments accountable for implementation. Second, consider the use of cash transfers for indigent pregnant women to enable them to protect themselves during their pregnancy and postpartum. Third, monitor heat levels, especially in poorly constructed and poorly ventilated homes. Fourth, work with employers to protect pregnant women from working in environments with excessive heat. Next, make health workers aware of the dangers of excessive heat and its impact on pregnant women and their newborns, and share knowledge on how to mitigate the impact of heat. For example, staying out of the sun where possible, and hydration. This is particularly important for health workers like nurses and community health workers who are at the front line of providing antenatal care to women in poor communities. Next is to promote the development of family clinic and community gardens from which pregnant women can obtain fresh produce, fruit and vegetable. And finally, improve access and quality of health and social welfare services for pregnant refugees and their newborns, and for those that are homeless. In conclusion, the science exists. Some policies and plans exist. We need resources and action on the ground. I would like to close with a quote from our former president, Nelson Mandela, who said, and I quote, "It is in our hands to create a better world for all who live in it," unquote. This quote speaks to both our responsibility as well as the importance of equity. Let us not leave pregnant women and newborns behind, especially the poor. I thank you very much.
Excellent. Many thanks for that from Dr. Pillay with chai. And one thing I really liked about that is how the specific suggestions of actions that could be taken. And again, emphasize that even though I apologize for the fireworks outside, even though we don't know everything and more research is needed, we can certainly take action now. So next, I would like to move to kind of a broad global view and looking more at the data and science available to us and how that might be used. Unless Kate, we're going to hear from Nigeria after all. Okay, Kate, go ahead.
Good evening, everyone. I'm Dr. Kayode Afolabi from Nigeria. The time has come for us all at the global community to look critically into the impact of heat on maternal and newborn health, especially among the overlooked population. Climate crisis has become a big threat that can worsen the already high levels of maternal and newborn mortality across the globe, including Nigeria. We look at the epidemiology of maternal and newborn health, realize that reduction in maternal and newborn mortality achieved globally over the past 2 decades is being overshadowed by the disproportionate burden suffered in low-resource settings and the marginalized communities that are often lacking in housing that can protect against extreme heat and other weather events, are also sometimes prone to flooding, droughts, and decreasing water supplies that are most vulnerable to the effects of changing climate. In the sub-Saharan Africa, we account for nearly 2/3 of total annual maternal death, while Nigeria accounts for about 30% of annual death in the sub-Saharan Africa, amounting to about 59,000 annual maternal death. And in the Southern Asia, they roughly account for 1/5 of the total global maternal death. These two regions account for about 86% of global maternal deaths, and this emphasizes the deep disparity that we have in maternal and newborn health outcome across the globe. Preterm births, on the other hand, accounts for over 1 million newborn deaths annually, and the highest of these occur in low and middle income countries. The impact of climate change, such as extreme weather, threatens to further erode maternal and newborn health gains that we have made over the years and compounding existing gaps, as well as amplifying the global and national failures that we have recorded on ending maternal mortality. As a global community, therefore, we need to recognize the big opportunity that we have in early and strategic planning to mitigate the impact of climate change on maternal and newborn health. Research is urgently needed for us to further understand the impact of climate change and also the options that are available to us to mitigate the impacts by government at all levels, as well as global community stakeholders. There are activities that we could adopt to serve as a starting point for focused intervention to create momentum, especially for future initiatives. These include national policies being updated to address the need of pregnant women as well as newborn, with multi-sectoral thematic approach that will prioritize protection and adaptation to changing climates. Our health workers need to be well prepared to provide basic guidance on the harms of extreme heat and to also be able to teach critical prevention methods to the pregnant women, the wider community, including community change agents, as well as key opinion leaders in the community at different levels. Again, early and strategic planning around innovation and adaptation through the integration of climate smart technology to be explored at the community level. Efforts to protect ecosystem or reforest land can aid in the provision of clean water, which of course we all know is critical to a healthy pregnancy outcome. Deforestation and afforestation in urban areas to reduce heat highland effect and the temperature that pregnant women are exposed to, also very crucial. Recently at the COP26 side event, a good example of this was the recognition that Nigeria was given on the Great Green Wall Initiative, where the leaders, the global leaders, commended Nigeria for efforts to restore degraded lands, and also the commitment of Nigerian government to restore 4 million hectares of land. There is also the importance of us to strengthen and spread effective network of care to provide comprehensive, respectful, and people-centered care for pregnant women. This will also help us to address the key the key driver of maternal and newborn mortality in the country. Let me conclude by saying that operational and implementation research sustains support from donors, community, and partners, especially to low resource setting, and articulation of a roadmap for government to adopt and adapt best practices for our local context are crucial to mitigate the impact of climate change on maternal and newborn health. Thank you very much. everyone. I'm Dr. Kayode Afolabi from Nigeria. The time has come for us all.
Excellent. Thank you very much. So as you heard, both South Africa and Nigeria are facing similar issues. These aren't unique to those countries. And certainly that also opens up the opportunity for collaboration and shared learning. And one of the ways that we heard Senegal is using the data and technology available is through Earth observations and satellite data. So here to tell us a bit more about that and some potential uses, I'd like to introduce Joy Shoemake with the Global Heat Health Information Network. Over to you, Joy.
Thank you, Liz. So I'm Joy Shoemake-Guillemot from the Joint Office for Climate and Health between the World Health Organization and the World Meteorological Organization in Geneva. And as Liz said, today I'm presenting on behalf of one of our key initiatives, the Global Heat Health Information Network, known as GIN. And GIN is a network of independent scientists, practitioners, and policymakers, including many that are on the panel today, who are all focused on enhancing existing efforts to address the health risks of high temperatures, principally by brokering and sharing knowledge. And our aim as a network is really to bring professionals who are working at all different angles of this problem together to be able to share experiences and good practices and to find new opportunities to network and work together. All of this is about bringing people together to accelerate capacity building around the world that can help reduce vulnerability to extreme heat and climate change in the health sector. And we do this through a range of activities and products that you can see here on the right-hand side. And what we have collectively learned over the last few years is that managing the health risks of high temperatures is not just a problem for the health sector, but it's what we call an all of society problem. Because heat not only affects health outcomes and human behavior, as we've already heard, but it also affects the environment, exacerbating other health risks like air pollution, other natural disasters like droughts and fire. And it affects the infrastructure where we live and work and infrastructure like electrical power grids that we depend on for delivering health services. So therefore, the solutions and strategies that we want to use to mitigate heat risks also need to involve a broad range of actors from multiple sectors of expertise and policy if we're going to reduce heat exposure that's dangerous to people. And we've also learned as a network that to reduce the impacts of heat on health, you really need three things. You first need the right people and experts to be engaged and come together in effective partnerships. And secondly, these people need to have the best available knowledge accessible to them to make decisions, such as heat vulnerability and impact science from the research community. We also need climate services that provide early warnings, such as the example we just heard from Senegal. And thirdly, we need this knowledge to be put into evidence-based interventions that can appropriately inform the risk communications with high-risk populations like women and children, and to tailor the approaches and policies we're developing to have the greatest protective impact. So engaged people with the right knowledge to take effective action. That's the core framework of how we work as GIN and what we recommend to others to have more impactful actions. And I'll just mention one key tool that's really helpful in putting this integrated framework into practice, and it's by implementing heat action plans. And heat action plans are a way to bundle key actions into strategic approaches that can be tailored at any scale, from a single health facility up to a large metropolitan area, or even to a federal action plan for heat. And two of the World Health Organization regional offices have recently developed these two guidance documents to help implement that, which can be found on our website. But the core elements of these plans are first and foremost the intersectoral coordination that's bringing the relevant agencies and experts together and can help establish a decision-making process for managing extreme heat events. Secondly, you need hazard information from early warning systems to tell you when the heat season is going to start, give that advanced notice of heat waves, and you need to involve the National Weather Service, who has the jurisdiction to issue such emergency warnings, like we heard from our colleague at Anasim in Senegal. Next, you need to have a sound communication and outreach plan that's tailored to appropriately notify the high-risk groups of dangerous conditions and what they need to do in those events. And that needs to be appropriate to context, to language, but is a really essential part of these action plans. Next, you need to deploy measures that are going to reduce indoor temperatures because people live and work in indoor environments. And this is not about putting air conditioning everywhere, but also using to the possible opportunity passive cooling techniques. We also need to have special care for vulnerable populations, such as women and children. And this might be visits or calls to high-risk groups or taking cooling support and educational materials to places like daycare facilities where you know you have a concentration of your population of concern, making cooling centers more child-friendly, but having a package of tailored interventions that can have the greatest impact. And next, you need to prepare the health systems and social care systems to deal with heat emergencies because, as we've heard, extreme heat events and heat waves are happening more frequently and more intensively in all areas of the world. But it's not only about emergency preparedness, but also becoming generally more resilient to higher temperatures. And again, WHO has a number of guidance documents on how to build climate resilient health systems, as well as climate resilient health facilities. But we can't only focus on emergency events. We need to consider long-term urban planning, as well as ecosystem preservation, like we just heard from Dr. Afolabi, because in the long term, we need to find ways to reduce heat exposures in the environment through green spaces, through ventilation, through other interventions. And finally, you need health surveillance to be able to measure and track impacts, ideally in real time, and evaluate whether the interventions we're using are appropriate, they're working, and having an impact to reduce the harms of high temperatures. So this modular package of approaches does not happen all at once, but it's an excellent framework to start to get the right people together, empowered with the right kind of knowledge to make good decisions about heat risks and start to take effective actions. So if you would like to learn more, please visit our website. There's a huge range of case studies, technical resources, guidance documents. Sign up for our newsletter that comes out every month with new evidence from the research community, upcoming events, and join this broad community of practice that's working to address the extreme, the human health risks of extreme heat. So thank you very much.
Thank you, Joy. What a great overview of what GIN does and how it can help. And from that perspective, looking from kind of a global view with some of those modular packages that you mentioned that can be tailored to each community, we're going to bring it back to the local level. First, we've known that poverty is a key risk factor for poor maternal and newborn health. And today we've been hearing about how climate change, especially heat, can compound those risk factors associated with poverty. But there can be other factors at play. And although low and middle income countries do have the highest rates of maternal mortality, there are also great inequities in maternal health in richer countries. In fact, just this week, The Guardian came out with an article describing recent research, which found that thousands of babies in England, so just next door to where COP is being held now, thousands of babies are born premature, too small, or stillborn because of what they call alarming and devastating socioeconomic and racial inequalities across the country. And I think the same can be said about the United States. And here to talk to us a bit more about this is Dr. Joya Creer Perry with the National Birth Equity Coalition. Over to you, Joya.
Thank you so much, Elizabeth. And I'm just so honored to be here in this transnational community where we are learning together and growing together. And I think about the previous presenters and where our talk kind of falls in that space. And so the privilege of being a Black American US born woman is also that we can see some privilege, but also see harm at the same time. And so ensuring that we look at the root causes of colonization, of racism, of tribalism is how we get the outcomes that we have today are so important. And so let's just move on to our next slide. So I am Dr. Joya Creer Perry, as was mentioned, and I'm the founder and president of the National Birth Equity Collaborative. And my organization creates transnational solutions that optimize Black maternal, infant, sexual, and reproductive well-being with the vision that all Black mamas, their babies, and their villages thrive. Next slide, please. We aim to create solutions that drive towards birth equity, which we define as the assurance of the conditions of optimal births. We don't want to just survive a pregnancy and say, thank God that heat went away. We want to live our best lives. So that means we have to be willing to address both racial and social inequities in a sustained effort. I want to highlight conditions here. We are all here today because climate change has been and continues to create a very dangerous condition for health, and even more dire conditions for those who are more marginalized, excluded, racialized, such as Black birthing people. Next slide. Many studies have shown that increasing temperatures and extreme heat are leading to negative maternal and newborn outcomes, as the previous presenters mentioned. For example, though, a study found right here in the US that heat exposure will lead to a 60% increase in fetal congenital heart defects by 2035. Additionally, in the US, studies have found that Black mothers have a greater risk for these adverse outcomes and are hospitalized more due to heat exposure. This is due to the many layers of systemic barriers in place in the US that are upheld by patriarchy, racism, and capitalism. Black women and birthing people are more likely to live in geographic regions that make them more susceptible to heat exposure. In addition to this, there is an unequal distribution of resources to help mitigate the harmful implications of extreme heat exposure, such as access to air conditioning and a lack of access to free, universal health care for all. It is therefore not surprising that we see similar impacts of heat on people of African descent around the world. A capstone report produced for the Office of the UN High Commissioner for Human Rights explored how climate change impacts the rights of people of African descent and found that in Latin America and the Caribbean, exposure to extreme heat and the risk of droughts impact peoples of African descent who are more marginalized due to urban poverty. In Europe, communities experiencing heat waves and flooding. Additionally, studies have shown that in sub-Saharan Africa, rural communities face water shortages, wildfires, crop failures due to extreme heat. For example, women who reside in rural areas of Sahel experience more heat exposure while walking increased distances to obtain natural resources such as water. Heat poses a threat to agricultural production and upkeep across the world of livestock. This results in both an economic and food crisis in rural areas. All necessary conditions for optimal birth outcomes, such as food security, access to quality infrastructure, adequate housing, are limited for people of African descent, no matter where we reside. Next slide, please. Climate change is a human rights and reproductive justice issue, and solutions should be based on justice. Racialized populations should not experience the least support and resources to mitigate the detrimental effects of climate change. This can visibly be seen when discussing my own home of Louisiana and Hurricane Katrina, a climate disaster that was directly impacted by self and my community. When we examine how FEMA, government buyout programs, flood assistance programs benefit those who are wealthy and exacerbated challenges for those who are low income, for example, extremely delayed response from the government, we can see how racist, elitist, discriminatory policies directly contribute to our health outcomes. It is imperative that we create climate mitigation and adaptive solutions that have a human rights-based approach and use an intersectional lens. We have to acknowledge the racist and discriminatory histories that inform how people of African descent have disproportionate exposure to heat in different regions all over the world. Mothers and babies of African descent have the right to live in dignity. They have the right to health, housing, education, water, and sanitation. However, climate change impacts are a constant threat to those rights. Despite this, there are ways that we can work together transnationally to tackle this systemic problem. As noted in the Paris Agreement, climate solutions should follow a country-driven, gender-responsive, participatory, fully transparent approach, taking into consideration marginalized groups, communities, and ecosystems. Governments also need to understand their historical contribution and work on a common but differentiated responsibilities. As the more industrialized a country is, the more likely it has contributed and continues to contribute to climate change. This can be achieved through collaboration between different stakeholders and sectors. Next slide, please. Coalitions such as SRHR and Climate Justice Coalition and the Feminist Green New Deal provide the space for policymakers, community members, and other stakeholders to come together and drive for policy change that is inclusive and incorporates historical accountability. Governments must be held accountable to completely invest in making the drastic changes needed. This is not just changing your name. This is actually changing how you fund, who is funded, who is seen as valuable. Everyone knows that the US is one of the largest contributors to climate change. Change must happen here. As a physician, I also recognize the contribution healthcare providers, specifically OBGYNs, can provide in helping mitigate the impacts of climate change on birthing communities through advocacy and education. Lastly, there needs to be an investment in localization. Communities know best how to address climate change in their spaces and should be in every room when policies are being drafted and implemented. For example, Sierra Leone has appointed their first chief heat officer, Eugenia Carbo. She has stated that she was driven to take the position in order to make her home safer and cooler for her family. This undeniably shows how climate change is a reproductive justice issue where the goal is to have a safe and sustainable communities to parent our children. In considering community-driven solutions, it is necessary we uplift and listen to indigenous communities as they are defenders of land and hold so much knowledge that we should be included in all climate change policies. The time has come. We must address climate change today for our own health and for the health of future generations to come. Through collaboration across communities and sectors, we have the power and opportunity to develop long-lasting human rights-based solutions. Let's continue to fight against the impacts of climate change on the health of mothers and babies in their communities with a human rights and reproductive justice approach. Thank you.
Thank you very much, Joya. Thank you for calling attention to the need for community-driven solutions and that human rights-based approach you mentioned. So Dr. Joya's organization and other activists in the US have worked with some legislators. And so now we have a message, we'll go right to it, a message from a United States legislator, Representative Lauren Underwood, about legislation that was recently introduced. Do we have that video? And in the meantime, I'll note in the chat box that we are trying to collect names of people interested in this specific topic. So there's an email address there you can contact if you're interested.
Good evening, everyone. My name is Lauren Underwood, and I have the honor of representing Illinois' 14th Congressional District in the United States House of Representatives. I'd like to thank USAID and your partner organizations for hosting this important event as part of the 26th UN Climate Change Conference of the Parties. History will one day look back at what happened at this summit and judge us for the choices we made and the ones we failed to make. We know the stakes. If we do not take the actions that will be required to prevent a 2 degrees Celsius increase in average global temperatures in the coming decades, sea levels will continue to rise, more ecosystems will be irreparably damaged, and natural resource supplies will likely be depleted. But this evening's event is an urgent reminder that climate change is not just a future danger or an abstract one. It's an immediate threat that is directly affecting people's lives right now in communities across the United States and around the world. Climate change is creating new environmental health risks and exacerbating existing ones, includes maternal mortality, a crisis that claims hundreds of thousands of lives per year worldwide, the majority of these deaths being preventable. The United States is no exception. In fact, we have the highest pregnancy-related mortality ratio of any high-income country and significant racial and ethnic disparities in outcomes. Infant mortality rates are also higher for Black families and other communities of color, even after controlling for factors like income. While the drivers of these trends are multifaceted, the role of climate change in fueling adverse maternal and infant health outcomes and disparities is indisputable. In June 2020, researchers published a groundbreaking systematic review in the Journal of the American Medical Association, which assessed the effects of environmental health risks on more than 32 million births in the United States. The study's authors concluded that the exacerbation of air pollution and heat exposure related to climate change may be significantly associated with risk to pregnancy outcomes, and the subpopulations at highest risk were women and birthing people of color, particularly Black mothers. As a registered nurse, I was alarmed but not surprised by these findings. My nursing education grounded me in an understanding of the role of non-clinical factors like environmental conditions and influencing health outcomes. When I served as a senior advisor at the U.S. Department of Health and Human Services, I worked on the water crisis in Flint, Michigan, and I saw how the disease burden of public health emergencies often takes a disproportionate toll on communities of color, a rattling reality that has been laid bare throughout the COVID-19 pandemic as well. And as a member of Congress and the co-founder and co-chair of the Black Maternal Health Caucus, the JAMA article compelled me to develop data-driven policy solutions to tackle this crisis head-on. The result is the Protecting Moms and Babies Against Climate Change Act, which I introduced with Senator Ed Markey in February 2021 as a part of my Black Maternal Health Momnibus Act, a sweeping package of legislation to comprehensively address the U.S. maternal health crisis. The Protecting Moms and Babies Against Climate Change Act would invest in community-based programs to identify climate change-related risks for pregnant and postpartum people and their infants, provide them with necessary support, and mitigate exposure to those environmental risks, particularly in communities of color. The funding supports doulas and community health workers, provides direct financial assistance to patients, strengthens community forestry initiatives, improves monitoring systems and data sharing, and prepares future nurses, doctors, and other healthcare workers to identify and address climate change-related risks for their patients. Critical investments for my Protecting Moms and Babies Against Climate Change Act were included in the Build Back Better Act that has advanced in the House of Representatives. And I am committed to working with my House and Senate colleagues and the Biden-Harris administration to get this legislation enacted, because we don't have any time to wait. Our moms and babies are worth it. The health of our communities depends on it, and the moment demands it in the United States and around the world. Thank you for your commitment to this cause, and thank you again for the opportunity to be with you for this important conversation. Take good care of yourselves.
Excellent. Thank you to Representative Underwood and her office for supplying us with those messages. And so we've heard from a great variety of speakers today, but there is one critical voice that we haven't heard from yet, and that's from the women themselves. So to close this session, I'm very pleased to share excerpts of interviews that our colleagues with the White Ribbon Alliance in Pakistan and Development Forum for Safe Motherhood had with women in Jacobabad, Pakistan. So here we'll get to hear from the women themselves.
क्या आप ऐसे इलाके में रहते हैं जहाँ गर्मी की शिद्दत में कोई फर्क हुआ है? क्या आपको लगता है कि पिछले 4-5 सालों में गर्मी की शिद्दत में इजाफा हुआ है या कमी हुई है? क्या महसूस किया?
गर्मी बहुत ज्यादा पिछले 3-4 साल में बढ़ गई है। इतनी गर्मी है कि बहुत ज्यादा ही
गर्मी पहले से बढ़ गई है। 3-4 साल से अब दिन ब दिन बढ़ती जा रही है। गर्मी बहुत है। जब मेरा बच्चा पैदा हुआ ना, गर्मियों में बहुत ज्यादा गर्मी थी, लाइट नहीं थी, दिन रात मैं स्क्वाड गर्मी की थी ज्यादा, कभी टैक्सी दुकान से भी करती थी थोड़ी सी जो भी काम। मैं तो समझ रही हूँ गर्मी ज्यादा है, लोड शेडिंग है, इससे गर्मियों में तो मैं तो प्रेग्नेंट भी थी, मेरे साथ ज्यादा तकलीफ थी। गर्मी की शिद्दत में इजाफा हुआ है, तो इससे आपकी सेहत पर और आपके बच्चों की सेहत पर क्या असर?
गर्मी की वजह से मुझे खुद को भी बहुत ज्यादा गर्मी लगती है और गर्मी नहीं बर्दाश्त कर सकती, हामला हूँ इसी वजह से। और बच्चों पर क्या असर बीतेगा? वो गर्मी की वजह से बार बार बाहर जाते हैं और बच्चे बीमार पड़ जाते हैं। बच्चों की सेहत पर बहुत ही असर होता है। अस्पताल बहुत दूर है, ले जाते ही पहुंचते ही बच्चे बहुत बीमार हो जाते हैं और कोई सवारी का कोई भी इंतजाम नहीं है।
गर्मी के असर से बच्चे बीमार हो जाते हैं, मोशन हो जाता है, बच्चे बीमार हो जाते हैं। तो मैं हमल से थी, तो मेरे भाई नहीं मुझसे बर्दाश्त होती थी। मैं दिन में 3-4 बार नहाती थी, तो मुझे 2 बच्चे बताए थे, तो मैं बीमार होती थी। खाना पीना कम हो जाता है गर्मी की वजह से। बहुत ज्यादा हुआ, इसके साथ में थोड़े थोड़े से दाने निकले। ये बच्चा जब पैदा होता है ना, 3-4 इसने एक दफा किया, फिर मैंने डॉक्टर को पूछा, उसने कहा गर्मी की वजह से इसको ठंडे जगह पर रखो, जाकर पंखा लाइट नहीं थी, बहुत तकलीफ हुई। मेरे बच्चे जो पहले 2 बच्चे हैं वो बीमार हो गए थे गर्मियों में बहुत, और मैं खुद प्रेग्नेंट थी। मेरे साथ
Kate, can you unmute?
जानवरों के पास चारा डालने जाती तो बहुत गर्मी होती है, क्या करें, मजबूरी है, करनी तो पड़ती है ना।
मेरे साथ यही यात्रा हुई कि ज्यादा गर्मी है, मुझे बहुत मेरी सांस फूलती है, उसके बार बार सुस्ती होती है, कोई घर का काम नहीं कर पाती हूँ, और उसके अलावा जैसी डॉक्टर के पास बार बार नहाने थोड़े अर्से पहले हमल से थी। गर्मी की शिद्दत की वजह से आपके हमल पे क्या असरात हुए और बच्चे की पैदाइश पे क्या बुरा असर हुआ? मेरी गर्मी की वजह से मेरे बच्चे बहुत तंग थे, मैं खुद तंग थी, नहाती थी दिन में 3-4 बार। खाना पीना कम हो गया था मेरा, तो दिन में 3-4 बार नहाना पड़ता था मुझे, तो मेरी सांस बंद हो जाती थी। खाना पीना बहुत कम था मेरा गर्मी की वजह से। गर्मी बहुत शदीद थी, बहुत ज्यादा हो जाती थी ना, बहुत सोती थी शाम
से यहाँ सुस्ती वगैरह भी तो ज्यादा से ज्यादा पानी पीती थी दिन में 4 5 6 7 नहाती थी जब बच्चा पैदा हुआ इसको भी ज्यादा नहाती थी गर्मी बहुत ज्यादा आप इस शदीद गर्मी का मुकाबला कैसे करते हैं आप क्या ऐसा कदम उठाते हैं कि आपको और आपके बच्चों को इस गर्मी से तकलीफ आज गर्मी की वजह से बार बार नहाते हैं और बच्चों को भी नलवाते हैं लाइट नहीं होती बाइक दरख्तों के साथ के नीचे बैठते हैं और पंखे का हाथ के साथ पंखा की हवा देते हैं बच्चों को भी खुद को भी नींबू वाला पानी बना कर पिलाते हैं खुद भी बच्चों को भी ठंडा पानी ताकि कि बच्चों को गर्मी ना लगे और बच्चे बीमार ना पड़े गर्मी ये है कि हम बस लाइट की जब बच्चा सोती है हम अपना काम वगैरह बस यही है कि सोलर का सिस्टम करवाया है गली में बचा दिया उसके बाद सोलर का सिस्टम करवाया बच्चे बहुत बीमार हो गए थे और उसके अलावा बर्फ में पानी ठंडा पानी कहीं गर्मियों में इतना गर्म निकलता है उसमें भी ऐसे सब लोग बर्फ डाल के फिर नहाते हैं लाइट होती नहीं है हम बाहर दरख्तों के नीचे चले जाते हैं बार बार नहाना पड़ता है बच्चों को नहलाना पड़ता है मैं तो चिले में हूँ मैं तो नहीं नहा सकती लेकिन बच्चों को नहलाना पड़ता है मुझे तो बर्दाश्त करना पड़ता है वे चिले में हूँ मैं मेरा दिल करता है मैं बार बार नहाऊं ठंडा पानी पीऊं लेकिन हमारे यहाँ बड़े लोग बड़े बुजुर्ग नहीं पीने देते लेकिन गर्मी बर्दाश्त नहीं होती मुझसे लेकिन ये करना पड़ता है हुकूमत इस सिलसिले में आपकी क्या मदद कर सकती है क्या आप हुकूमत को कहना चाहिए जी हाँ हुकूमत को कुछ कहना चाहेंगे हुकूमत को चाहिए दरख्त लगाएं ज्यादा से ज्यादा लोड शेडिंग कम करे बिजली का रेट कम करें रात में सारा सारा दिन एक तो लाइट नहीं होती दूसरा बिल भी बहुत ज्यादा आते हैं और ना लाइट भी भेजें और बिल में भी कमी करें ताकि हम पंखे भी चला सके और अमीर लोग तो सोलर प्लेट लगाकर पंखे पे बैठे हैं हम गरीब क्या करें ताकि वह सोलर प्लेटों की कीमत कम करें हम भी लगवा सकें और बिलों की कीमत भी कम करें और ताकि हम पंखे भी चला सकें क्या मदद चाहती है बस हम मदद यही चाहते हैं हुकूमत से कि लोड शेडिंग कम करें और बिजली का बोरा थोड़ा कम हो जाएगा लाइट चलेगी तो हमारे बच्चे भी सुकून करेंगे हम भी सुकून करेंगे इस हालत में तो हम कुछ नहीं कर सकते बस हुकूमत को हमारे लिए लाइट ही चलाएं यही हमारे लिए बहुत अच्छी बस गर्मियों में कुछ भी नहीं देती है वैसे ही गर्मियों में लाइट नहीं जाएगा बिजली होगी बिजली की बहुत ज्यादा तकलीफ है महीने 3 महीने तक गर्मी ज्यादा होती है बिजली भी हो बस तो हुकूमत से ये
Thank you very much. Wonderful to hear from those who are impacted most. And you can see that the heat stress that they're experiencing in that area, it's becoming the new normal. And of course, there are other impacts of extreme heat as well in that area. And if you'd like to learn more, Amnesty International actually recently released a report about this situation. And I was really struck about a story of a mother who needed to beg not for food, but for water for her children. And so you can see that this isn't just a health issue, and it's not just a climate change issue. Reiterating what Dr. Career Perry already stated, it's plain to see that those women in the interviews and others being impacted are not the people most responsible for the emissions causing climate change, but they will bear the brunt of its impacts. So this is really a social justice issue, or as the young activists outside marching today in Glasgow would say, a climate justice issue. So thank you for all who are stuck with us through the technical difficulties. This is an emerging area of work for us. And I apologize that the brand new email address that was created for this purpose is not working yet. But if you would like to put your email address in the chat box or contact any of the presenters, we would be glad to keep a list of folks interested in this topic so that we can work together across boundaries, across sectors, to see how we can tackle this. So with that, I see we're at time. So again, I apologize for the technical difficulties. Thank you for sticking with us. and enjoy the rest of your evening or afternoon. And many thanks to the presenters and to the folks on the planning committee that helped to coordinate this.